what has been a very successful and dynamic meeting. We will start this morning with some oral presentations. I don't know how many speakers are here already. The first one. So we would like to invite Dr. Artemiou from Slovakia, who would discuss the short-term mechanical circulatory support for severe primary graft dysfunction following orthotopic heart transplant. Thank you very much.
Okay, and good morning. The topic is the short-term mechanical support for severe primary graft dysfunction. Firstly, some definitions. Primary graft dysfunction is the cardiac dysfunction that in the immediate postoperative period following a heart transplant. It is divided into left epiventricular dysfunction and right ventricular dysfunction alone. The severity is divided into mild, moderate, severe in case of left epiventricular dysfunction, and on the right ventricular dysfunction alone cannot be assessed in mild, moderate, and severe. Is one group. So here we talk about the severe primary graft dysfunction, which is a requirement of support the patient with a mechanical assist device. So in our institution, in January 2007, May 2017, there were performed 218 heart transplants, and 40 patients, 6.7% had severe primary graft dysfunction. The mean follow-up period is 3.7 plus minus 2.7 years, and the indications for the assist device was failure to wean the patient from the cardiopulmonary bypass and hemodynamic instability with cardiogenic shock, and it should be said that the heart biopsy were negative for hyperacute rejection. So in the recipients, nothing remarkable, only were 9 male patients. The indications for heart transplant were 4 patients with ischemic heart disease and the rest with dilated cardiomyopathy. From the risk factors, 4 patients had diabetes mellitus, 2 hypertension, 2 chronic renal failure, and 1 with COPD. So from the recipients, 1 patient has preoperative CentriMac LVAD support, and 5 were in HeartMate 2 LVAD support. 1 had previous sternotomy, and the hemodynamic data you see is systolic pulmonary pressure 47.8 around, and vascular resistance 3.7 plus minus 2.1 Wood units. So, and then donors, nothing remarkable. Also, we had 2 patients with gender mismatch, which is a low percentage, and also the weight mismatch, more than 0.15, it was only 1 patient. And the radial risk score was from 0 to 4 with a mean 2.2 plus minus 1. So what type of mechanical support we used? We used in 7 patients the veno-arterial ECMO, and most patients had the central veno-arterial ECMO, 1 peripheral, and each patient was switched to LVAD later, and 7 patients had the CentriMac support, 2 patients like BVAD, 1 patient like LVAD, it was an early experience, and 4 patients like an AirVAD. So the implantation time, most of the patients had implanted the mechanical support less than 24 hours after the operation. It was 11 patients, and only 3 patients were after the first day. So in 8 patients, the support device was explanted. The mean explantation time was around 6.3 days, plus minus 2 days, and the support time was 4.7 plus minus 2 days. The operative data you see is from brain dead beating heart donors. The surgical technique is the orthotopic bicaval heart transplant. Myocardial protection was used, the custodial solution. Catabolic pass time was 290 minutes, around plus minus 60, and the ischemic time, you see, was only 156 plus minus 43 minutes. So here is the results. For the postoperative data, we have 7 hospital deaths, and the postoperative morbidity, as you see, except from the main morbidity was bleeding. Was bleeding with 8 patients had re-exploration, 11 patients had transfusions, and the mean transfusion requirement was high, 15 plus 10 units of PAC cells. So the causes of death of the 7 patients, you see, was most of the patients died from hemorrhagic shock, 2 from sepsis, and 1 from cardiogenic shock. Here the problem was that the vein arterial ECMO was switched to LVAD. It was early without adequate cardiac recovery. So the survival, the overall survival of the patient was 7 patients survived. One point to mention is that the survival after explantation was 7 out of 8 patients. And the long-term survival was 5 patients, 71.4%, and 2 patients died, who survived discharge, died during follow-up, 1 and 3 years after the heart transplant. So based on our experience with these patients, we proposed an algorithm of the management of the primary capital dysfunction. You see, if it's biventricular or right ventricular failure, we prefer the veno-arterial central ECMO in these patients with left apical venting. And if we have the right ventricular failure alone, we use the LVAD short-term Centrimac here. And then the maximum support time of the ECMO is 7 days. If there is no, according to the recovery, we can explant the ECMO. If there is no recovery, we switch to BVAD short-term, paracorporeal, the patients, and also again with the recovery of the LV, RV, or both ventricles, the BVAD or the LVAD is explanted, and if no recovery, we go to durable long-term LVAD or ERVA support. Also, following this route, you see if there's no recovery, we go to long-term ERVA support, and the end of the road is retransplantation. So in the conclusions, the veno-arterial ECMO, specifically the veno-arterial ECMO offers a reliable therapeutic option in these patients. So despite the high hospital mortality, if the patient recovers and the ECMO is explanted, the mechanical support device, and the patient has a successful hospital discharge, has a favorable outcome. Thank you very much. This is my hospital, and this is Bratislava by the Danube River. Okay, thank you.
Thank you very much, Dr. Artemiou. Is there any question before we move on to the next?
Craig Salzman from over here. It's hard to see. From Salt Lake City in the United States. Maybe I missed it at the very beginning of your presentation. What % of your patients fell into this category? What was the denominator? So about 7% of your patients were getting mechanical support. And do you have any idea about the warm ischemic time? It just seems like a little bit high rate of needing mechanical support. So I was wondering if you had any insight as to why. Yeah, why was your percentage it's a little higher than maybe expected. So do you have any thoughts as why that happened?
Little high because they have presented some data in Milano a few weeks ago from the UK registry, and they presented a severe form of pancreatic dysfunction, 14%. And they have an overall incidence, 40% of the pancreatic dysfunction. We don't think our data is too high.
Because you can have a lot of primary graft dysfunction without mechanical support, right?
Yes, but we don't have a risk analysis to answer this question. Thank you.
Okay, thank you very much. It is an honor to invite Dr. Dite, who is a pioneer and a proctor for the use of the sutureless aortic valve technology in Greece, who will discuss about the long-term follow-up following sutureless aortic valve replacement in high-risk patients.
Thank you very much, dear Chairman. Ήμουν έτοιμος να μιλήσω στα ελληνικά, να σας πω την αλήθεια. Βάλτε λίγο την ομιλία. The long-term results of sutureless valves. Διδαηλίας που λέει. So we're aiming to present our long-term results with 137 sutureless aortic valve replacements in high-risk patients. And what about these valves? There is a lot of discussion in the literature regarding these valves. You see that there have been already 20,000 implantations so far. In the literature, there are 333 studies, and these valves promise much better results as far as it concerns paravalvular leak and early mortality as compared to the TAVI procedures. From the initial issue of these valves, even in the first series, they promised that they are very compatible with a minimally invasive approach, and they offer better effective orifice area and smaller and fewer cardiopulmonary bypass time and cross-clamp time. The type of the valve is this stentless valve anchored to this cage, and the whole product is implanted very easily with 3 guiding stitches in the aortic root. The valve is loaded to this stilus, to the delivery system, and with 3 guiding stitches goes down to the aorta after we have already excluded the valve and decalcified the annulus. They can also very easily be implanted through mini sternotomies, as far as we can see here in these slides. And the benefits with minimally invasive approaches is that they offer faster recovery, reduced in-hospital stay, less trauma infection, etc., etc. We have implanted these valves in very difficult cases, such as in these dwarf and in porcelain aortas. So far, we have experience with 137 AVRs with the Perceval S. 132 were scheduled procedures, 21 accompanied with CABG, and 2 on redo cases. In 11 cases post-operatively, we have to implant pacemaker, which is approximately 8% of the cases. In 3 of them, the valve had to be repositioned. In 6, there were 6 non-valve-related in-hospital deaths, approximately 4%. 1 acute MI occurred 4 months post-operatively without any clinical effect and clean angiography, and 1 late endocarditis following hip replacement 1.5 years following our initial surgery. The patient characteristics, you see that it's a relatively elderly cohort of patients, 78 years old, with a significant Euroscore of 9.2. The BSA was low, and this is due to economical restrictions. We choose difficult cases to implant this type of valves. 12% had stroke history. 2 of them had to be as a redo case, and concomitant coronary artery disease was in 21 cases, so 15%. Patients with preoperative pacemaker implantation were 3 out of 137, preoperative AF 4, preoperative right bundle branch block 15, and preoperative left bundle branch block 3 out of 137 cases. The success of implantation was 100%, although 3 valves had to be repositioned, but it's easy to take these valves out of the first implantation and then to reposition it. And the mean extracorporeal circulation time was 71 minutes, and the mean postoperative blood loss 850 mL. The majority of the valves implanted were in small size. However, over the last few months, we have implanted more large and extra large sizes. Temporary pacemaker implantation was done in 50% of the cases, and 7.2% we had to implant a permanent pacemaker. As far as it concerns the short-term results, the mean preoperative max peak gradient was 88 millimeters of mercury, but the postoperative one went down to 15, and the mean preoperative effective orifice area from 0.7 went up to 1.5 postoperatively. Although 2 patients had significant gradient, and one of them above 45 millimeters of mercury without any clinical effect. The follow-up, which is in progress, shows that so far, after 5 years of experience, we have lost 12 of these patients, which means approximately 10%, but our follow-up is not very good. In Greece, we cannot get in touch with all these patients, especially with the ones that we had implanted these valves 5 years ago. These results are a little worse than the ones that have been reported. You see that series of 30 patients that are already in 5 years follow-up have only 10% of deaths after 5 years. But our paper is still in progress, and we believe that we might have better outcomes after we complete the follow-up. Thank you very much.
Thank you very much, Dr. Delias. Is there any question from the audience? Allow me to ask one.
Yes.
Oh, please, Dr. Panhellenic.
Congratulations, Panagiotis. This is the biggest, as far as I know, Greek series. We know that this kind of aortic valve prosthesis is the best anti-PPN procedure because we have less gradients than every other classic bioprosthesis. But we pay a price. You have clearly showed that we pay a price in the permanent pacemaker needs, which resembles not the classic SAVR, but the TAVI. And second, we must be very skeptical about the trauma and due to crimping. This is, I think, something that we should keep always in mind and try to wait the long-term results about the durability. Yeah. Because the trauma due to crimping, which is also the Achilles heel of TAVI prosthesis, surely it promotes valve thrombosis. So we should be very skeptical and wait about the long-term results. Thank you very much.
Thank you very much, Doctor. Can I reply to the
last
comment?
Question?
Can I reply to the comment, please?
Yes, you may answer.
Okay. Thank you very much, Dr. Panagiotou. This is a very important issue that you arise. We have done a study about these valves and how much do they cost. They cost in our hospital, which is a public hospital, and you consider it a cheap hospital, they cost 16,000 euros because the valve itself costs 7,000 euros. And if you add another 7,000 for the hospitalization of the patients and the pacemaker implantation goes up to 16,000, which is quite high if you compare it with 5,000 euro or 6,000 euros, which cost to the other standard valves, the average valves that we use. But then what we did is that we compare these valves with the difficult cases that we implant on the other side. And what we discovered was that the pacemaker implantation rate in the average valves in these difficult cases was also 8%. So in the difficult cases, the costs are very comparable.
That would be my comment as well. I mean, these valves there has to be a clear algorithm and specific indications as to where we put these valves, because there are difficult cases, small aortic annuluses, calcified aortic roots, and other cases, chronic renal failure, times that we need shorter bypass times, that we really need to use these valves, but the indications, I mean, globally, have to be clear enough. Yes, sir.
Yep.
Congratulations, Panayiotis, for the Loud series. It would be interesting to know what the long-term results are going to be, what the rate of degeneration is going to be, as Mattheos mentioned. The good thing is that even if the long-term results are not that great, you don't burn bridges because you have the option to do the TAVI with a valve-in-valve indication. Thanks.
Yeah, these valves basically compete TAVIs. And also this valve was initially designed to be used as a TAVI, as a transcatheter valve. That's why the name is Perceval. It comes from the percutaneous valve. That's why they call it Perceval. But later on they discovered that can be easily adapted from surgeons.
It is a good valve for every cardiac surgeon to compete the TAVIs, usually taken over by the cardiologist, should be in our armamentarium, definitely. That's what we believe.
Yes.
Thank you. Mahesh Ramchandani from Houston, Texas. Congratulations on your experience. We have been implanting the Perceval valve since it was introduced in the United States in 2016, and so far we have put about 140 valves in. We do, I would say, 95% of them through a minimally invasive right anterior thoracotomy approach. I have one comment and one question to ask you. The comment relates to the possibility of doing TAVI. It's very interesting that the heart valve app and that Vinnie Bapat in the UK, now in the US, produced shows, and you can see this very clearly, that even for the smallest Perceval valve, for a small size valve, you can implant a 23 Sapien S3 valve. So it's very amenable to TAVI. My question relates to your experience with postoperative pacemaker. You mentioned the proportion of your patients that have a variety of conduction abnormalities, left and right bundle branch block. And I'd be curious to know how many, how many of your patients who required postoperative pacemakers had preoperative conduction abnormalities?
All right. This is, yeah, that's a very clever question, but I don't have the answer available now. But this is what we are studying in progress, the pacemaker implantation. What we have found, though, is that our initial valve of these valves implanted, the pacemaker rate was much higher than what we do now. Possibly because now we decalcify the annulus much better, as we did, as opposed of what we did in the beginning. In the beginning, these valves had an indication that they can easily be implanted without a detailed decalcification of the annulus. Now we decalcify very clearly, and we do not overestimate the annulus. We do not put larger valves as we did in the beginning. Therefore, the pacemaker implantation now has gone down. But of course, it's strongly related to the preoperative conduction problems of the patients. But I don't have the answer to this question right now. Thank you.
Yes, one last question, please.
Problems with relatively large annuluses or enlarged, let's say, aortic root with the Perceval implantation. I mean,
okay, we do not implant these valves when we have a large root. If the ratio of the annulus to the root is above 1.3, these valves are not indicated to be implanted. And of course, there is no indication for aortic insufficiency. It's also only for calcified aortas.
Thank you, Dr. Delias. We will proceed with the next. That's the pulmonary endarterectomy for chronic thromboembolic pulmonary hypertension. The Houston method is experienced, presented from Dr. von Balmos. You may begin, sir.
Good morning, and thank you very much for the invitation to come speak here in this wonderful conference. It's my distinct pleasure to be here and share with you really mostly a surgical video of the pulmonary endarterectomy that we have essentially adopted from the San Diego group. We had previously a program that was temporarily closed and now have resumed the program for pulmonary endarterectomy. So we recently took a video of that, and I think it's just a nice way to demonstrate that the pulmonary endarterectomy really has a huge unmet need, certainly in the United States, and is very feasible at probably a lot of centers where people have a desire to come together and approach this problem in a multidisciplinary approach. These are my disclosures. They're not relevant to my talk. Just briefly, a little bit about the epidemiology in the United States. Chronic thromboembolic pulmonary hypertension really arises from repeated and unresolved pulmonary embolism. It develops about 2 to 4% of all patients that have a pulmonary embolism event, and subsequently leads to significantly increased morbidity and mortality as pulmonary artery hypertension leads to right ventricular failure. It's considered the only curable form of pulmonary artery hypertension, really, that is amenable to a surgical intervention, and the definitive therapy in this case would be the surgical endarterectomy, which I'll present to you in a video shortly. Again, just a little bit about the numbers and how it all adds up. In the United States, we have about 600,000 cases of pulmonary embolism, of which about 10 to 15,000 people per year develop new onset chronic thromboembolic pulmonary artery hypertension. And if you put this into proportion with how many people actually do get surgical treatment for that, you can tell that there is a significant number of patients that do not currently get treatment. And so I think there is quite a substantial number of patients that would probably be amenable to surgical intervention but do not get currently treatment. Just very briefly, the workup is a fairly comprehensive one. And is best done in a, again, multidisciplinary team. It involves imaging protocols of variety. The CT angiography is certainly one of the first or initial imaging studies that is typically obtained. MRI is another option. And then VQ scan is really what a lot of the indications hinge on eventually. It's proven that VQ scans have a higher sensitivity when it comes to diagnosing patients with CTEPH, different a little bit from other settings, the acute pulmonary embolism, where CT angiography also does real well. But specifically for this patient population with chronic pulmonary embolism and pulmonary artery hypertension, the VQ scan is a very important diagnostic tool. Other things are catheter angiography, ultrasound, and then sort of the other things that go along with pulmonary embolism and shortness of breath, the symptoms that patients often present with. It's also very important to keep in mind that not an insignificant number of patients that have pulmonary embolism and deep vein thrombosis have some sort of underlying clotting disorder that needs workup, especially in patients that have a pulmonary endarterectomy, to manage the anticoagulation strategy appropriately in the perioperative period. Just quickly, what are the indications for pulmonary thromboendarterectomy? It's essentially patients that are symptomatic, have RV dysfunction, severe pulmonary hypertension. Those two latter indications also are the patients that are a little bit higher risk population, including those that have distal disease. It's really a multidisciplinary approach between surgeons, pulmonologists, cardiologists, so everybody coming together and come to a consensus what kind of a disease pattern the individual patient has and whether there is some potential benefit to a surgical embolectomy. The University of California in San Diego has by far the largest series, I think, and experience with pulmonary endarterectomy, has come up with a classification system consisting of these 4 levels that indicate what disease process and what degree of disease process is prevalent in the proximal pulmonary arteries versus the distal subsegmental parts of the pulmonary artery. And certainly the patients that have more proximal disease, that have central pulmonary artery disease, are the ones that will benefit the most, while those that have very distal disease are a little bit higher risk again and more challenging to manage and reap some benefit from a surgical intervention. So with that sort of a prelude to the video, I'm just going to share with you a video that shows our approach, which is again an adoption of the UC San Diego way of doing this, and I'm just going to make some comments as we go through the video and look at this. So this was a 51-year-old patient that presented sort of with the typical presenting symptoms. This is the VQ scan, which is a little brief there, but shows the perfusion defects. Also seen here on the angiography, clearly evident that certain parts of the lungs are not well perfused. What we're looking for is really a clear lack of perfusion in a segment and not just diffuse disease, which again would suggest that it's more peripheral disease. We use central aortic cannulation for this, and then a sort of modified bicaval cannulation strategy that allows really mobilization of the IVC and SVC, and particularly the SVC, to give us access to the pulmonary artery. We use a pulmonary vent to help with drainage while we work on the pulmonary arteries. Here we just show the mobilization process of the superior vena cava, which is something that most of you will be familiar with from doing mitral valve cases, but just a little bit more aggressive, again, to sort of be able to really lift up that superior vena cava, lift it off from the pulmonary artery to get good access. This is a specific spreader designed by the San Diego group, I believe, and sold by Wexler, which is designed again to push the SVC and aorta apart to give access to the right pulmonary artery. Initially, when we do these cases, we perfuse the patient as we usually would on a cardiopulmonary bypass, usually with a PA vent in place that allows to do at least the proximal work real well. We'll see here a quick view of inside in the pulmonary artery. You can tell from the thickness of the PA that this is not a normal appearing pulmonary artery. And we use the scope here to get the visualization, really mostly for imaging purposes. It's if you have stay sutures and position the spreader well, you can really quite easily see down into the segmental orifice of the pulmonary artery. So here we've gotten into the plane, and that's probably one of the most critical aspects of this procedure, to get into the correct plane. The correct plane is one where you have a substantial peel, and underlying the sort of whitish pulmonary artery. You can see in some places you see a little bit of bleeding coming through, which is probably just a tick too thick of a peel, but you really want this whitish appearance of the media, and then you start peeling distally in the pulmonary artery and working yourself towards the segmental and then subsegmental bronchi. Again, the crucial part of this is really to get into the right plane, and as you subsequently push these peels using a variety of devices such as the suckers, different elevators, pickups, you start pulling on that peel and peeling the inside of it. Here we're working still on the right side, just getting more of the segmental bronchi out. And then usually we do the right side first and then turn our attention to the left side. So here we make the incision into the left main PA. We use this net to retract the heart back and out of the way, sort of lengthen the pulmonary artery, then redirect this one Gans catheter. We still have that PA vent in place that also helps with drainage. I think for some reason here we're back on the right side, but we'll shortly go over to the left side. Here's just seeing how we peel out a subsegmental segment of a pulmonary artery branch. This most distal part is accomplished really under circulatory arrest. Usually in our sort of limited experience, it's required 15 to 20 minutes of circulatory arrest. We've done most of them with a single circulatory arrest per side, so usually not necessary to get multiple circulatory arrest periods. And here's sort of what it looks like at the completion of it. When we irrigate and look down, it's important to really get down into these distal subsegmental branches and get everything out that you can get out. That's where some of these patients reap the most benefit, if you really make every effort to get even the smallest branches you can possibly get. And then here we're just closing up the left pulmonary artery as we rewarm the patient and restart the heart and come off pump. A lot of these patients will actually show quite a dramatic drop in their pulmonary artery pressures in the immediate post-operative period. Some will report much improved breathing, but certainly that's a very nice result to see if you have low PA pressures. And this is just one of the specimens that we have from one of the patients that shows the central portions and the more distal ones. And that was the video, and just in my remaining 40 seconds or so, I'll make a shameless plug for what we have coming up in Houston. We have a Re-Evolution Summit where we teach hands-on techniques for minimal invasive cardiac surgery. I figured I'd toss this in here for anyone in the audience interested in minimal invasive cardiac surgery, hoping to adopt minimal invasive cardiac surgery techniques in their practice. It's quite a unique setting. We host this in our MITES Educational Center, where we have a sheer endless amount of tools and space available for both cadaver teaching and simulation training. So I would invite every one of you here to check out the website, which is on the top, and to come visit us in Houston. It's in April. It's a wonderful time to come to Houston. And it's really great hands-on meeting for anyone interested, again, in minimal invasive cardiac surgery. And with that, I will be happy to take any questions.
Yes, sir.
What's the standard preoperative workup you do for those patients, and who is the ideal candidate?
Say it again. The acoustics in here is really challenging. I'm a pretty young guy, but I had the same issue yesterday, so no microphones.
What's the standard preoperative workup for those patients, and who is the ideal candidate for
thank you. Very good question. So the ideal candidate is really a patient that has established chronic, has pulmonary artery hypertension that can be tracked back to a pulmonary embolism event, that has chronic CTEPH, is a CTEPH patient and has central disease, predominantly central disease. As you go out to the distal branches, it gets progressively more difficult to do the end arterectomy. So patients that have central disease are certainly the ideal candidate. It's also true that a lot of these patients do have severe pulmonary artery hypertension, RV failure, which makes them much more challenging patient population to operate on in general. So at some point it becomes balancing what benefit you believe you can reap from doing a central embolectomy versus the surgical risk that is involved versus other things that are maybe going on with patients. So it's not a harmless operation per se. I think it's a very doable procedure, but certainly you have to be cognizant of comorbidities, life expectancy, and then resectability, essentially, I would call it resectability of the pulmonary artery disease.
Yes, please.
Like the San Diego group, because they had intermittent arrest there.
Yeah, so we, as I tried to point out early in my talk, we used the exact same thing. We didn't come up with anything new or different. We learned from the San Diego group. They actually came in and did first case with us and sort of walked us through their methods. I think they've perfected that approach. Again, I think there's a few other groups. I'm not aware of any other group in the world that has that much experience. The world is a big place, I always say, so I'm sure there's someone who does a lot of these as well, but San Diego is certainly on the map for it.
Yes, please.
Excellent presentation, thank you very much. I would like to know how many hospitals are giving this service in the United States. I know that in Europe there are only a few. 2 in Germany, 1 in Italy, 1 in England. And the second question, have you ever experienced any pulmonary hemorrhage, or what are the needs for ECMO postoperatively in your series?
Yeah, so all excellent questions. So it's certainly a unique disease process and has been traditionally limited to very few centers. I'm not personally aware of how many centers in the United States do these cases. Dr. Ramchandani, who is also on the video, may know how many centers there are. 8. I was partially trained at Duke. They do a fair number. I don't know. We do some. So 8 centers. Vast majority still being done in San Diego. A lot of patients flying out there specifically for that procedure. A lot of physicians referring to San Diego. So, you know, like anything in surgery, I think there's a volume outcome relationship. There's a comfort level with doing these cases. And doing the surgical procedure per se, as I hopefully was able to show you, is just one little piece of it. It's a technical exercise. It's not the most complicated technical exercise. Selecting the right patients, managing those patients is really where the benefit of a, again, multidisciplinary team And a programmatic approach to this disease process comes in and plays an important role. Both, again, I was at Duke, and when we had a team specifically dedicated, same at Houston Methodist. I think that is as important, if not more important, than just the pure technical aspects of the surgery. As far as ECMO support and pulmonary hemorrhage are concerned, pulmonary hemorrhage is one of the major complications, obviously. I think that goes back to how critical it is to get into the right plane initially. If you are in the right plane, things peel relatively easily. If you're too aggressive in terms of pushing and going deeper, you can easily break through what is left of the arterial wall. So certainly a complication that's well described in this setting. It is quite remarkable as you pull on these peels how caoutchoucy the peels are and how much you can pull on the actual pieces without causing too much damage. And it's sort of a learning curve how much you can pull on them, but you can pull on them quite a bit. It's the back and forth pulling and pushing that sort of makes the difference. We have not had anyone on ECMO support. It's available, I guess, as an option. I've seen it at Duke where everybody got put on ECMO. If they coughed twice after lunch break, they got put on ECMO. So it is, certainly an option that's out there. We haven't had that need, thankfully, in a very limited series also, I would say.
Thank you very much, Dr. Rambos. It's about time to move on to the next presentation. So we'd like to call for Dr. Snosi from the UK, who will discuss about the thoracoabdominal aortic repair with sequential clamping.
Chair, ladies and gentlemen, thank you for this opportunity to present our experience in thoracoabdominal aortic aneurysm repair from the Liverpool Heart and Chest Hospital, the UK. We adapted this method from the Houston procedures. The patient this is a video presentation I would like to share with you today, is a 72-year-old patient who had an incidental finding of thoracoabdominal aneurysm of 7 centimeters. So the usual, the standard setup of the patient on the left recumbrant position, the thoraco laparotomy incision through the 6 intercostal space. We divide the rib, and we control the neurovascular bundle. The diaphragm is also dissected, and we do and dissect the retroperitoneal space to get exposure to to the aorta and the aneurysm. The patient usually at this time is drifted to 32 degrees Celsius, and with the transesophageal echo guidance, we put the patient on the left heart bypass, draining the left atrium through the left pulmonary vein, and arterial perfusion to the lower limbs through the left femoral artery. This is we can appreciate the distal part of the aorta, and we anastomose the dacron graft distally using running proline sutures and augmented with pledgets. An arterial sidearm is also implanted, and this helps to perfuse the lower part of the body. We de-air the dacron graft and apply the clamp to maintain arterial perfusion. After that, of course, we dissect the abdominal aorta. As you can see, it's heavily calcified, and we remove all the thrombus from inside the lumen. So the aortotomy is extended, and the wall of the aorta is fixed using stay switches. This is to expose especially the posterior wall of the aorta. We perfuse the visceral arteries and the left and right renal arteries using balloon catheters. We used to use a cold saline at 15 degrees Celsius, and now we adapted to use cold blood at 15 degrees Celsius to perfuse both the left renal and right renal arteries, and we found that it decreased the incidence of hemofiltration in the post-operative period. The most important thing is to appreciate the intercostal arteries and the backflow. And by this, it could cause spinal deperfusion. So there are a few techniques that we adapted. First of all, we perfuse intercostal arteries, and we always measure the motor evoked potential. And we found that the most important costal arteries are from the T5 to L1. Also, sometimes we oversew the intercostal arteries, and this is the dacron patch anastomosed to the distal thoraco aneurysm. Perfusing intercostal and oversewing them to prevent steal phenomena and maintain the perfusion of the spine. Another technique is to take the intercostal as an island and anastomose it end to side to the dacron graft. The measurement of the dacron graft applied, and the visceral anastomosis of the superior mesenteric artery, and the celiac trunk is anastomosed end to side to the dacron graft. We usually leave the left and right coronary artery anastomosis at the end, usually using a separate graft, which is also anastomosed to the main dacron graft end to side. We anastomose the two ends of the dacron end to end separately. De-airing. Performing hemostasis using plegited switches, and anastomosis the left renal artery to the aorta. Usually our patients stay in the intensive care unit for 8 days, 5 to 8 days. This patient stayed about 5 days in the ITU. He recovered eventually and went back home on the 15th postoperative day. In our series from 1998 until 2017, we had 218 cases performed in Liverpool, which of them 134 cases has been descending thoraco and aneurysm repairs. Our complication rate, and usually the most common complication we had is postoperative bleeding, which most of the patients went back to theaters for hemostasis. Our acute kidney injury is about 15% from our series, and the paraplegia rate, we found it's about 7.5% for the patients. Routine closure. And thank you, I can. Thank you.
Thank you, Dr. Snossi. Extraordinary work indeed. Any questions from the audience, please? Yes, sir.
Very good presentation. What spinal protection measures do you use? Is drainage of the spinal?
Yes, so
the sensory potentials, because 7.5 is high.
Yeah, exactly. Thank you very much for your question. So all the patient is standardized. We use the intraoperative monitoring, which including the motor evoked potential and also the cerebral drainage, which is automated. And postoperatively, all patients are put on COPS protocol for the spinal protection to prevent the paraplegia.
Yes, sir.
Have you thought about using custodial for renal protection, since it seems that custodial solution for renal protection? Since there are different papers that evidence that the renal failure is lower with a cold colloid perfusion rather than warm blood.
So are you saying the perfusion to the renal artery? Yeah. So the first we adapted these called saline perfusion, and from our series, when we changed to cold blood at the 15 degrees Celsius, it significantly reduced acute kidney injury post-operative. So we don't use cold saline anymore.
Sorry, can I just answer that question? Yes, I'm Thomas Theologo from Liverpool, one of the senior surgeons. We do use that for a period of 2 months. And we did find out that we did have problems with creatinine, and for some reason, the patients get a more high risk of renal impairment, and that's why we moved to the cold blood. But we did try that. Safi has him here into our unit and teaches this technique since 2008, and gradually improved, and gradually, the unit like a team. We actually found out in the multivariate analysis that if someone is obese and if someone has a renal impairment and has high creatinine, this gives him actually poor outcomes, and if he's more than 70 years old. So nowadays, we have a very strict control, how many patients we will take before we operate them. So if a 75, we try to be very careful after an anesthetic assessment before we actually take them under, because they can cost a lot of the trust, and the patient finally they don't do well. And if you see in the long term, they actually die during the first year or during the second year. Thank you.
Thank you very much for this helpful remark, and we will continue with Dr. Visuli.
We would like to invite Dr. Visuli, who will present us. Dr. Visuli, please come to present us your theme. With the subject is, do current guidelines provide clear indications and patient selection criteria for destination therapy?
I'm sorry, we'll have to wait for my presentation to be uploaded. What do you believe? Do you believe that current guidelines provide clear indications and patient selection criteria for destination therapy? And which guidelines? Anyway, I focused mainly on the European Society of Cardiology guidelines published in 2016 and the American College of Cardiology Foundation, American Heart Association guidelines published in 2013 and the current update published in 2017. These guidelines are still based on the landmark trials, the rematch published in 2001, and the destination therapy HeartMate 2 randomized controlled trial by Slaughter et al. Published in 2009. These randomized controlled trials provided direct and indirect evidence of survival benefit of destination therapy over optimal medical management in patients who were in end-stage heart failure, refractory to optimal medical management, had a left ventricular ejection fraction less than 25%, and were transplant ineligible. There are no randomized controlled trials comparing heart transplantation to destination therapy, and there are no randomized controlled trials comparing destination therapy versus optimal medical management in transplant-eligible patients. I have my USB stick, if you can have it now, because it was uploaded outside an hour ago. Excuse me.
Shall we invite the last presenter? Yes, okay. So we invite Dr. Andonitzis, who will...
Mia extra.
Will present us the long-term results in surgical correction of endocarditis.
Okay, thank you, Mr. Chairman. I won't be long. I will just present our institutional experience regarding the long-term results on the management of infective endocarditis. Is one of the largest series from a single institution in Greece. So we have discussed actually yesterday for infective endocarditis, the serious systemic infection with actually increased morbidity and mortality compared to the standard surgical AVR for aortic stenosis or aortic regurgitation. There is a changing microbiological profile in terms of the microorganism involved, and also more and more patients, especially of increasing age or having prosthetic valve endocarditis or endocarditis from implantable devices appear to cardiac surgical departments, and this is reflected to the Euroscore. The active endocarditis is a risk factor for morbidity and mortality after cardiac surgery. What we did is that we reviewed our experience from 2007 until 2018 in a single institution. It's a tertiary academic center in Thessaloniki, Greece, HIPPOCRATES University Hospital, and we tried to see the long-term results of these patients. We excluded patients with device-related infection, I mean pacemaker lead infection. And what we had is that we have actually operated on 47 patients, predominantly male, with a mean age relatively high, 52 years. The majority had native valve endocarditis, 80%, as compared to 10% of prosthetic valve endocarditis, and it was considered actually, let's say, a high-risk group, according to the endoscore criteria that we've actually heard yesterday. We had 8 patients with a previous stroke and splenic infarcts, and a lot of patients with, let's say, peculiar causative microorganisms. Staphylococcus was present in 15% of cases, but it was Streptococcus, Enterococcus faecalis, 3 patients with Candida species, 9 patients with other bacteria, Bartonella, Chlamydia, Brucella, Coxiella, Rickettsia. While this is common practice in Greece because we usually administer antibiotics very early, we had a percentage of 32% with negative cultures despite having vegetations on the valve. All valves were replaced. There's no homograft bank department in Greece to perform a homograft replacement, and Bendal procedure was performed in 2 patients, while there was patch closure of peri-aortic abscess in another 2 patients. So we followed up the patients for a mean period of 3 years, but with a wide range from 1 month to 11.5 years, and we have actually collected long-term results on the 83% of patients. The overall in-hospital mortality was 23%. It involved 11 patients, while only 3 patients, 2 patients that had IV drug abuse, and 1 patient died from a non-cardiac cause. The native valve endocarditis mortality was 19%, while the prosthetic valve endocarditis was 44%. It's a relatively huge percentage, while there was also a high risk patients who had fungal endocarditis with Candida species. Actually, 1 out of 3 only survived. And this is the long-term survival. As we can see, there are, let's say, 2 critical points. One is the immediate postoperative period, and one is 2 to 3 years afterwards, especially in patients with IV abuse, having endocarditis of the tricuspid valve. They have problems there. Otherwise, we can see that the long-term results can be considered as excellent. And why is this increased morbidity and mortality? It's really a systemic infection. I mean, we had a patient with multiple splenic emboli that had a mycotic splenic artery rupture in the abdomen, losing virtually all his blood on the 13th postoperative day. The next day, he was supposed to be discharged from the hospital. So in conclusion, the surgical management of infective endocarditis is still challenging. The population is high risk, but with increasing experience and with meticulous surgical technique, we can achieve optimal results in the immediate postoperative period, and we can actually believe for an excellent long-term outcome. Thank you very much for your attention.
Thank you very much. Are there any questions from the audience?
Actually, I would like to congratulate you on this very nice presentation, and also for your very good follow-up of the patients.
Yeah.
I think that there's something that needs to be done generally in Greece to do a proper follow-up of the patients, if you agree.
Okay. Yes, please.
These patients.
The standard indications.
Pardon?
The standard indications for operating on
yeah, but in this patient population, I mean, how many patients had heart failure or valve penetration or complication of endocarditis? This is very important in order to say that the prognosis of the patient is excellent after surgery.
Yes. That's a very nice question, and I don't have the real data, but it's mainly what indications exist nowadays. It's heart failure.
Yeah, I know the indications. In your population, for example, how many had heart failure? How many had valve penetration? How many had this complication?
No, I don't have the actual numbers. Actually, the prognosis, I don't think that is related to the surgical indication. The prognosis is related to age, to the causative microorganism, to either prosthetic valve or not, to either being fungal endocarditis or not.
Let me tell you something, because I'm maybe I'm older than you, okay? In this type of presentations, you need, the audience has to know which was the cause of surgery. This is my opinion, before I reach this conclusion.
Yes, please.
Thank you for this nice presentation. My question will be, what will be your attitude when you have a patient with a recent stroke? How long would we wait, if at all? Or generally, what will be your attitude with a situation like this? Because that is what we are facing very frequently.
What we do is that we operate all patients as urgent cases. So we do not have elective endocarditis cases. As long as the diagnosis is established, the patients stay in hospital and they are operated within a frame of 2 to 4 weeks. So for a patient with an ischemic stroke, we wait for at least a couple of weeks in order to have a re-evaluation of the stroke, and then we operate.
But the patient has a highly suspicious vegetation that will embolize again. So that is our major concern, what to do with the patient that stroked already, but there is a concern that he's going to stroke again if you don't operate.
Yeah.
And you are not, you know, in a safe range, so it's within 4 weeks, so we don't know what to do usually with these cases. That is our, yeah.
The timing still remains controversial.
So, thank you very much. If now we are ready, we can proceed with Dr. Visuli.
Hello again. You already know the question. To whom and when should we offer destination therapy? This represents one of the most challenging medical decisions created by modern medicine. Destination therapy is a highly invasive, largely irreversible, resource-consuming and costly treatment associated with major adverse events. Nevertheless, it can offer survival benefit with improved quality of life in carefully selected patients. Heart transplantation and mechanical circulatory support, mainly as a bridge to transplantation or as destination therapy, represent the surgical treatment options of end-stage heart failure, with palliative care and investigation and treatments being the only alternatives. Typically, destination therapy is long-term mechanical circulatory support with implantation of a left ventricular assist device as a permanent or lifelong treatment in end-stage heart failure reduced ejection fraction patients who are not eligible for heart transplantation. 2 landmark trials provided direct and indirect evidence of survival benefit of destination therapy with LVADs over optimal medical management in selected patients. All patients enrolled in the landmark trials had advanced heart failure, a left ventricular ejection fraction less than 25%, were refractory to optimal medical management, and were transplant ineligible. All these characteristics were mandated by the inclusion criteria. The majority of patients enrolled in the landmark randomized controlled trials were in New York Heart Association 4, receiving intravenous inotropes at baseline, despite the inclusion criteria were designed and broadened, aiming to enroll mainly ambulatory, non-inotrope-dependent advanced heart failure patients. Current guidelines and eligibility criteria are based on these guidelines, of these landmark randomized controlled trials. Thus, FDA indications for destination therapy with FDA-approved LVADs and CMS eligibility criteria for financial coverage of destination therapy in the US have criteria based on these trials. Commonly, transplant ineligibility is required, unresponsiveness to optimal medical management. New York Heart Association Class 4 is required by the CMS, who is paying the money, while FDA covers 3B as well. Inotrope dependence is covered by both eligibility criteria, including cardiogenic shock, Intermax Profile 1. CMS further requires a left ventricular ejection fraction less than 25%, and in patients who are not receiving inotropes, reduced VO2 max less than 14 mL per kilogram per minute. CMS requires a multidisciplinary experienced team, which will ensure patient and caregiver education to support necessary participation into shared decisions and appropriate informed consent. Under these circumstances and these eligibility criteria, survival of destination therapy recipients in the US, according to the Intermax registry, is 78% at 1 year and 66% at 2 years. Survival in Europe, according to the Euromax registry, is somewhat lower. Thus, always challenged, heart transplantation is still associated with higher survival than that occurs with destination therapy. In the 2017 American College of Cardiology focused update, heart transplantation received a Class 1 recommendation, while LVAD implant received a Class 2A recommendation. Current treatment algorithm of advanced heart failure includes evaluation for transplantation first, and then evaluation for mechanical circulatory support as destination therapy only in transplant-ineligible patients. In patients with uncertain eligibility for transplantation, mechanical circulatory support may be applied as a bridge to candidacy. In a significant percentage of patients, this strategy is applied because they cannot be definitely categorized into bridge or destination. Thus, bridging to candidacy overlaps to bridging to transplantation and to destination therapy. Despite regulatory requirements for distinct strategies, the device strategy remains dynamic. Crossovers can occur to both directions, but they mainly occur for bridge to destination therapy, that is gaining momentum. Continuous overlapping and crossover between device strategies underline their imprecision. Dichotomization between bridge and destination was considered arbitrary and problematic. Experts in the field suggested long-term mechanical circulatory support instead of premature assignment into bridge or destination. It seems that current guidelines adopt expert recommendation, at least regarding terminology. So there are no recommendations for destination therapy in current guidelines. It can only be inferred that certain recommendations for durable mechanical circulatory support or LVAD implant are related to destination therapy. According to the American Heart Failure Guidelines, patient selection for mechanical circulatory support remains under investigation and requires an experienced multidisciplinary team. Destination therapy is not defined in the American guidelines. It can only be inferred that the third recommendation can be related to destination therapy. And this recommendation just says that durable mechanical circulatory support is reasonable to prolong survival in carefully selected patients with stage D heart failure, reduced ejection fraction. The paradox of destination therapy being offered not only in transplant-ineligible, but also in transplant-eligible patients was incorporated into the definition of destination therapy included into the recent European heart failure guidelines. The number of patients with a permanent LVAD who are considered neither too old nor ineligible for transplantation is constantly growing. For a majority of these patients, lifelong LVAD therapy, despite eligibility for transplantation, has become a clinical reality. It can only be inferred that the third recommendation can be correlated to destination therapy. According to this recommendation, an LVAD should be considered in transplant-ineligible, end-stage heart failure, reduced ejection fraction, refractory to optimal medical management. Trying to sum up, the common inclusion criteria, the common patient selection criteria of the European and the American guidelines include stage D or else end-stage heart failure, reduced ejection fraction, left ventricular ejection fraction less than 25%, transplant ineligibility clearly stated or inferred, and refractoriness to guideline-directed medical treatment or as to optimal medical management. Both guidelines include a severe profile, making a patient eligible for destination for long-term mechanical circulatory support, New York Heart Association Class 4, and inotrope dependence, and a less severe profile with criteria non-inotrope dependent patients with criteria alternative to inotrope dependence. The American guidelines include reduced VO2 max and poor clinical prognostic scores, while the European guidelines have clinical indices including frequent heart failure hospitalizations and end organ dysfunction due to hypoperfusion. In both guidelines, short-term mechanical circulatory support is advised in acute profound compromise, expression used in the American guidelines, or in critical cardiogenic shock. It can be inferred that destination therapy is not indicated in these acutely and terminally ill patients. According to the 2013 International Society of Heart and Lung Transplantation Mechanical Circulatory Support Guidelines, there are some circumstances under which long-term mechanical circulatory support may be offered to patients in cardiogenic shock, in case that the ventricular function is deemed unrecoverable or unlikely to recover without long-term device support, in patients who are too ill to maintain normal hemodynamics, in patients who cannot be weaned from inotropic support, and so on. According to the fourth Intermax annual report, there is prevailing opinion for short-term mechanical circulatory support in critical cardiogenic shock, but the definitive analysis was not available. The 2017 American Heart Association scientific statement included indications and contraindications, and the indications are a combination of several criteria. The most severe profile involves New York Heart Association Class 4 and inotrope dependence, while the least severe profile is variable. New York Heart Association Class 3B and criteria alternative to inotrope dependence, such as reduced VO2 max, frequent heart failure, hospitalization, increasing refractoriness, intolerance to optimal medical management, and organ dysfunction due to low cardiac output. Thus, generally accepted indications for destination therapy are end-stage heart failure, reduced ejection fraction, less than 25, refractoriness to optimal medical management, transplant ineligibility, New York Heart Association Class 4, and in inotrope dependent or non-inotrope dependent patients. With the exception of the CMS.
Could you please wrap up, please, Dr. Vissoulis, speed up a little bit? Could you please wrap up? So
Λοιπόν, inotrope dependence is a commonly accepted indication. Criteria alternative to inotrope dependence are valuable. Timing of intervention is also crucial. The Intermax profiles were introduced to facilitate patient selection and timing of intervention. The only guidelines that include inferred suggestions according to Intermax profile are the European guidelines, and according to these, an LVAD implant may be indicated in patients in Intermax profiles 2 to 6. Thus, gaps in evidence result in uncertain indications for long-term mechanical circulatory support for patients at the end of the spectrum, patients who are too well and patients who are too ill. The majority of patients implanted in Europe, Japan, and the US are inotrope-dependent patients, with ambulatory heart failure patients fluctuating from 4 to 23%. Two-year results of the roadmap, re-evaluation of the roadmap, the Intermax registry, and the MEDAMAX prospective observational study showed that the LVAD implant is appropriate in patients in Intermax profile 4, non-inotrope dependent patients, but expansion to a greater proportion of ambulatory advanced heart failure patients in profiles 5 and 7 will probably require neutralization of adverse event, hopefully achieved with newer generation devices. There seems to be expert opinion that there is a benefit from LVAD implant in patients in Intermax profiles 1 to 4, and not established benefit in patients in Intermax 5 to 7. So we can say that there is no single indication, there is consensus for early repair and a multidisciplinary decision by the heart failure team. Use of risk scores can be beneficial, further to risk scores such as the Seattle Heart Failure Model. Mathematical solutions for quantification of a survival plus quality of life were suggested. Risk scores can be a starting point. They are not meant to replace clinical judgment. And patient and care, they can facilitate patient and caregiver education to allow shared decisions that will ensure concordance with the patient's values and expectations, concordance of the benefit from treatment with the patient's values and what the patient expects from this treatment. Thank you very much for your attention.
Okay, thank you very much, Dr. Risuli. Excellent presentation, very interesting field. Unfortunately, no room for questions. So we conclude this session before we move on to the next one. Thank you very much for your attendance.
Ladies and gentlemen, welcome to the session about heart failure. This is going to be a record. I've never chaired a session which is 45 minutes late in starting, so we will try to go through the lectures quickly. The first talk is by Professor Bojan Biocina from Croatia, the short-term mechanical circulatory support, IABP, Impella, EACLS. Bojan?
Dear ladies and gentlemen, thank you very much for inviting me to this prestigious meeting. I'll try to be as short as possible as we've already been late. So, okay, what's it? Going on? No? Yes. Great, that's me. So I come from the Zagreb University Hospital Center. One of the brand of this center has been mechanical circulatory support, and we've been trying to pursue the method as much as possible. Now I have something to explain, give an update on a balloon pump, Impella, and ECMO or extracorporeal lung support. Does it work or no? No, it doesn't. Good. So this is something as a statement about device selection in cardiac surgery, and a class second evidence that International Society of Heart Lung Transplantation recommend temporary mechanical circulatory support in case there's a kind of pending death or the case there's some kind of problem that will prevent recovery of the patient, to allow neurologic assessment and clinical optimization because consideration of the long-term device or transplantation as a final exit strategy. So which features we do require for the acute MCS method? This is very simple, but not very easy to achieve the kind of features. First, it has to be ease of application, because usually they're put in some kind of urgent situations, so percutaneous access is highly recommended. It has to be applicable to separate both left and right ventricle, as high degree of support as possible, and of course, as high biocompatibility or as low physiological damage as possible. Come on, as long lasting the method to be as possible. So what do we have in option in our second portfolio so far? Old intra-aortic balloon pump, now it's a kind of fading away, the legacy of the aortic balloon pump. The new version of the previously well-known hemopump, now is now Impella. Tandem heart has a unique opportunity to transseptal puncture of the left side of the heart. So left side support applied from the right side, and after all, veno-arterial ECMO as a one-in-all solution. Some other percutaneous for the right ventricle, the Impella for the right ventricle, of course, paracorporal pump for the right side, also the tandem or Levitronics or whatever else, and again, VA ECMO as a one-in-all solution support for the both sides of the heart. Now, the choice of device that we need to apply really depends on the severity of the shock. Here is a great slide after Samuels that show which is mortality according to the previously applied inotropes. So everything can be treated by inotropes and patient can be alive, but as high as your inotropes are, the patient is more temporarily alive. So the mortality reaches with the 3 high doses inotrope, the mortality reaches 80%, and as well materialized also in the famous Berlin IABP score. When they reach a certain level of grading of the Berlin IABP score, then the mortality reaches 100%. So what to say about the intra-aortic balloon pump? Is the first historic and probably was the most useful method for a long period of time, long ages, but after the shock trial, mostly is fading away, and very few centers now using balloon as an auxiliary measure to reduce the afterload, as an auxiliary measure to, let's say, support the coronary circulation, yes, but as a main method for the mechanical circulatory support is not. That's based on this, trial. I mean, that compared balloon pumping cardiogenic shock together with the optimal medical management control and show no difference whatsoever. Well, I still personally believe that there is some place for the balloon pump in portfolio mechanical support. However, the efficiency or hemodynamic efficiency as low as 10% of the cardiac output, and that's probably not enough. Second is a kind of modernized version of the all-known hemopump. Well, used to be manufactured by Medtronic, now shifted to Abiomed. So Impella 2.5 and 5.0, 2.5 and 5 liters of the liver of the flow. It's transaortic and delivers to the aorta from the left ventricle. It's percutaneous and it's very convenient, especially for the cardiologist. It doesn't really need surgical intervention, a part of peripheral intervention to the femoral arteries. It used to be utilized for LV support only, but now is appropriate use with the right failure, with a special device for the right failure. Impella can be inserted percutaneously. 5.0 is inserted with a surgical cut down, and FDA is approved for support up to 6 hours. However, in the reality, support can be long as 2 or 3 several days, and it's very efficient in unloading the left ventricle. So that's a kind of relatively simple device, and it's becoming highly sophisticated, more and more sophisticated, and results are getting better and better. So of course, there are some intriguing data from some pumps that kind of all-cause mortality in some trials show there is no difference between Impella and intra-aortic balloon pump. However, it's been caused by the fact that was the fact that I will address later on, that the timing is important. Once the multiple organ failure occurs with the case of low cardiac output, nothing really helps. Not ECMO, not maybe only total artificial heart or transplantation, or not even so. So the primary support with Impella has to be appropriated timely, in timely good manner. Has to be applied when you didn't escalate the inotrope dosage to the highest possible supra-pharmacological levels. And of course, survival, you see this after initial drop in survival, and you see, of course, the post-cardiotomy patients, they do worse than the regular patients. However, after the initial drop, the late survival, those who are rescued or resurrected from the imminent death, their late survival is not that bad at all. After all, tandem heart is another unique opportunity in temporary support. It's unique because everything can be done from the venous side. So you have peripheral cannulation of the arterial, and then from the venous side is transeptal puncture to the left atrium. And it's also a relatively simple device with a centrifugal pump attached here and a set of percutaneous cannulas, so very, very, very low invasiveness of the whole device. And then how does it look? It's mandatory to implant the tandem heart under the fluoroscopic guidance in a cath lab, but that's the reason it's very convenient for cardiology, especially. Well, it's not being utilized very much in Europe. I don't know really reason for that. Hopefully now it's been acquired by Livanova. The tandem heart has been acquired by Sorin, and we believe that's going to be more exploited in Europe as it's exploited in the United States. And the unloading of the left side is quite good. Centrimag, of course, is another centrifugal pump. It doesn't come together. It doesn't come together with a set of percutaneous cannulas, so there's a need of surgical cut down. And at the end, probably the king of the all mechanical circulatory support is ECLS or ECMO, is a miniaturized version of the CPB machine, but can provide mobile and longer lasting up to several weeks or even months extracorporeal circulation and oxygenation. It's the main advantage of ECMO, that's all-in-one solution. So where you are unsure which kind of respiratory or cardiac or combined failure, you can cover both respiratory and cardiac failure with one machine. Also comes with a very handy and convenient set of percutaneous cannulas. It's probably the best, well, in my opinion, because it covers both cardiac and pulmonary failure, can be converted to CPB, so you can continue with surgical operation after resuscitation by ECMO, can be converted to temporary LVAD or RVAD just by removing the oxygenator, can serve as right support after permanent LVAD implantation. We did in our center quite much about that, and peripheral access is possible in most cases. It's cheap, it can last long enough. Long enough means weeks or days, several days, or maybe up to 1 to 2 weeks. And of course it's mobile. It's the first ECMO. It was everything but mobile, but now is the smallest version is only 9 kilos weight. It's complete CPB. It's a miracle of technology. Can be used as a general resuscitation tool or special facilitator for other procedures, and it can facilitate galore of procedures. Galore of procedures, all kinds of cardiac and peripheral and vascular procedures can be facilitated by ECMO, of course, to buy some time and to buy peace in mind and to buy calmness to the operator to be sure that he's not doing anything in a rush. Of course, in general, resuscitation tool can be used in the form of eCPR, and there is a long and still ongoing discussion on eCPR, whether eCPR is efficient or not. So, of course, and there is a, and there is a, well, later on, I will discuss a little later some about data about eCPR, but eCPR is definitely efficient, especially where there is no ROST, where there is no return of the spontaneous circulation. ECMO can be used in such extreme measures of the necrosis of the left ventricle with the Satinsky clamp place of the heart. Now is a peripheral ECMO from our institution with the left drainage arm, and that's a kind of persistent VF for 3 days, and now patient being successfully transplanted after that, and still living, I believe, in our institution. There's some outcome from our institution on ECMO or acute support, and roughly it's 50% of survival. So that's not 50% of mortality, that's a 50% of resurrection, because all those patients had already been dead in the past, now being resurrected. So that's not a bad idea. And of course, post-cardiotomy, well, can be upgraded and can be transferred to other final exit solution, and the primary ECMO share the same fate, and the mortality is more or less half. Again, that's all around. That's the number of 50% in good centers. You can achieve 50% survival of those who had already been dead. Of course, there's still guidelines always go a little behind, and now AHA said there's insufficient evidence. It's very difficult to find evidence because it's very difficult to set up a kind of randomized trial who you will resuscitate and who you will not resuscitate by ECMO. But we believe there's a kind of perspective or future in this methodology. There's a famous Lancet paper that showed that eCPR is far superior to the conventional CPR. That's what I might not need to mention that any longer. So should be considered one of the primary resuscitation tools, should be referred based on spoke and hub principles. So initiation everywhere, but maintenance only in specialized centers, as we did in Croatia. And of course in Croatia, I'll show you later. Oh, I didn't show them much. So we have already in Croatia set up the network of ECMO with 32 machines scattered all around the country, and few centers serve as hubs. And we did in Croatia, in a country of 4 million inhabitants, we did about 700 procedures so far, and finishing right there. So, and of course, a kind of
would you like to close, Boyan?
Is a bleak picture of kind of ECMO in post-cardiotomy in America, because the survival is going worse, but that's because usually that method has been applied too late. So with this, I'll conclude my talk, and thank you very much for your attention.
Thank you very much, Boyan. I was informed by Professor Prapas that because we are so late, that the discussion will take place at the end of this session, so we just proceed with the next lecture.
Yeah, of course, it would be nice if we had time to discuss these interesting topics, but we have to go on, and I'm asking Dr. Nachev to present his experiences with complications after pump implantation, pump infection and thrombosis. How can we prevent those?
So I would like to inform you about our experience with ventricle assist device implantation. In Bulgaria, we have a big problem with donors situations, and so we make a very low number of transplantations according to the waiting list. So we perform a lot of ventricle assist device. We started our program with the X-Core Berlin Heart System in 2001. We have 12 patients on X-Core system. Support duration was about 75 days. Outcome is one went to the heart transplantations, 5 patients winning the system and die on the system. Complications after X-Core system were re-exploration for bleeding 5 patients, stroke with 3 patients, and device thrombosis in 2 patients, sepsis 1 patient. We have no technical problems. The reasons of that are shown here. And this is the first Bulgarian with X-Core system. I show you a patient, 33-year-old male who went to X-Core system in 2003. 81 days later, he went to the heart transplantation and died 8 years after. Other case is one 11-year-old boy which went through the ASD mitral valve annuloplasty. The next day after the operation, he had STEMI, and we implant X-Core system. His ejection fraction was 9%. He went through a very complicated post-operative time. He was with open chest 3 days, inotropes for 21 days, and mechanical ventilation for 14 days, suffered to sepsis. 1 month later, we explanted the X-Core and discharged the boy with ejection fraction of 55% 1 month later. And so this is in 2003 we started Berlin Heart in-core system. So we have till 2017 30 patients with in-core system. We have discharged 14 patients with the system at home. 6 patients went through the heart transplantations. 1 was without device after that, and 9 patients died on the system. Maximum support duration was 800 days. Complications were re-exploration for bleeding, 9 patients, stroke in 2 patients, device drop-positive 5 patients. In one of them we exchanged device, and with 4 we do successful fibrinolysis. Severe drive-line infections in 5 patients which required hospital care. We have no other technical problems, and sepsis in 3 patients. This is the reason of death in our patients. We use anticoagulation, which is protocol from the Berlin Heart. 36-year-old man went to in-core implantation in 2004. After 2 years, he went through heart transplantation. He is now living and is in good health. This is the longest our support duration, which is 800 days. Interesting case is one 26-year-old patient with Marfan syndrome went through the bento de bone operation in the United Kingdom and come to us, and we implant in-core system, and it was the first to allow implantation of in-core system in the bento, after bento de bone operation. There was no thrombosis of the mechanical valve. Unfortunately, he died on the system 426 days later. And complication with him was acute device thrombosis, and we perform fibrinolysis. We put Retaplas into inflow cannula, acute relief after that, and discharge on the 9th day post-operative. Another case is a 29-year-old patient with implanted in-core. He was discharged on the 36th day post-operative, readmitted on the 84th day because of the drive-line infections. We started therapy with antibiotics. On the 106th day, after a routine insertion of central venous line, there was a hemoglobin drop and tachydyspnea. He went to ICU and was intubated. After putting chest drainage, there was about 900 milliliters of blood. He went to the CT, and we saw there is a coagulum in the pleural cavity, and we saw acute bleeding from the subclavian artery. So we went to the operating theater and evacuated about 2,000 milliliters of blood and coagulum. The acute bleeding was stopped from the subclavian artery. 96 hours later, we have problems with the suction of the device, and we decided to perform fibrinolysis. A bolus of Reta Plus intravenous was given, and 1 hour later the patient have no problems anymore with the system. The patient was discharged 26 days after bleeding with no problems with the drive-line infection, and after 23 days he went on the heart transplantations. He was on the ventricle assist device about 155 days. In conclusion, I want to say that with patients implanted with ventricular assist devices, surgical technique is required to minimize the risk of post-operative bleeding and the need of re-explorations. Careful monitoring of the anticoagulation in the ventricular assist device patients is mandatory to avoid thrombosis and massive bleeding. Device fibrinolysis is possible and suitable alternative to device exchange, which would be performed safely with precision control. Thank you for your attention.
With Dr. Kilitz from United States. He will present about the current situation and the future of the long-term mechanical support devices.
Good morning, everybody, and thank you for the opportunity to speak here in lovely Greece this morning. I have such a vast topic this morning that I think it would take 45 minutes alone, so I'll try to be as fast as I can. I'm supposed to give you an overview of the current state of mechanical circulatory support and what the future lies. I really have no financial disclosures, but maybe my disclosure should be the fact that the program has done such a good job of outlining all of the big topics that hopefully mine will be more of an outline of what's to come later today. As we all know from the Intermax database, perhaps one of the best things that has come out of having an interagency has been the ability to communicate with each other just about how sick patients are. Profile 1 patients being the sickest of the sick. Profile 7 patients being ones that are in advanced New York Heart Association Class 3, which has been summarized in the last session by saying that those are probably ones that don't benefit from mechanical circulatory support. That being said, one of the things that I think draws the most attention is the very first talk we had today, talking about acute short-term mechanical circulatory support. These patients, which are outlined on the bottom here, have actually a worse 30-day, 1-year survival than even the sickest of the sick patients, those profile 1 patients. Unfortunately, increasingly more, these are the patients that we're dealing with, because these are the patients that are being evaluated when they come in through the doors, that are sick, have a large myocardial infarction, and you get asked what to do. We have a variety of different things that we've talked about this morning. We have different algorithms of trying to get them past the state of acute sickness, but we know that the mortality lies between 50 to 80% with shock following acute myocardial infarction. It's no surprise then, there's been a huge impact on left ventricular assist devices for patients that are moving on to durable support from temporary support. ECMO, in fact, has been worldwide. So just as a show of hands, how many people utilize ECMO? How many people use LVADs? Okay, very good. So you can imagine that those are the patients that I think are very unique, and some of you may have these capabilities in your facilities and some may not. But really, left ventricular assist devices aren't used for patients that are in acute shock. They're used for more in patients that have chronic heart failure. So these are the patients that we talked about that have inotrope dependency, that only have options of even palliative care, saying that's it, or having mechanical circulatory support or heart transplantation. We know very well from rematch studies back in the late 1990s, early 2000s, that pumps are better than medical therapy when it comes to these moribund patients. We know that the sternotomy followed by the laparotomy, the XVE days are gone. We moved on to the HeartMate 2 days, where it required mostly a sternotomy with a preperitoneal pocket. And we've moved to pumps that are now all able to be placed intrapericardial. This gives us the option of moving forward as well in terms of technology. We've gone through the pulsatile pumps to the continuous flow pumps that were axial to now the centrifugal flow. And you can see why, as the ease of implantation has come, the way that we implant these devices has changed quite a bit. This is a patient I did recently. It says minimally invasive, but there's nothing minimally invasive. It's a partial sternotomy and a thoracotomy. This is a 74-year-old gentleman that came in and essentially wanted to go golfing. So that's actually a video that doesn't play right now, but it's him golfing 3 months later. A lateral child that looks at the sternotomy versus looking at this incision shows that there's actually 89% survival using a hardware device after 1 year. which is significant improvement from the rematch stage when you looked at 1-year survival of being ordered of 50%. And that's all in relative of medical therapy, which is about 20%. Obviously, with these devices, the HeartMate 3, the latest one that has come out earlier this year, showed a 2-year survival of 78%. This is in line. Unfortunately, as good as we are in terms of improving patient survival, the real thing that we should be focusing on is the quality of life. When you look at the adverse events, these are the INTERMAX profile 4 to 7 patients, there's a whole host of adverse events that occur. The 4 that I want to highlight are strokes, bleeding, sepsis, right heart failure, and cardiac arrhythmias. As you can imagine, if this is the current state, the future is going to be something that's aimed at making all of these better. Strokes, 1 year after the HeartMate 3 is at 90%. I think that's personally unacceptable to say that 1 in 10 patients is going to have a stroke, even with the best of circumstances. This is to show that it's an improvement over the HeartMate 2, but still nowhere where I'd want any of my family members to be. Aortic insufficiency has gained more and more attention. We talk quite a bit about the geometry of the outflow graft, that's anastomosed to the aorta, how it should be, where it should be, close to the aortic valve, away from the aortic valve, transverse, longitudinal. But to be honest with you, we still don't know. We're still learning what the best place is. Looking at aortic insufficiency, it's not just at the time of implantation and just the outflow cannula. You can have de novo aortic insufficiency as it relates to the fact that now you have differential blood flow going through the pump and going through the native artery. Looking at this, we've certainly looked at the Levaris cycle, which is in the heart-wear pump, but it speeds up and slows down every 60 seconds. And we've realized that the more you open up the aortic valve, the less chance of having aortic insufficiency. We've also started coming up with new techniques of how to deal with aortic insufficiency. Everyone has at least 1, 2, maybe 4 instances where they've taken care of aortic insufficiency with an off-label TAVR. We've also had off-label Amplatzer devices to close this aortic insufficiency and allow the pump to have forward flow. We do know that if you leave patients with residual valvular problems, that's not just the aortic valve, but really the mitral valve regurgitation, as well as tricuspid regurgitation, it actually has a significant impact on survival curves and also has a significant impact amount of readmissions you have for recurrent heart failure symptoms. So these are things that as we're starting to gather our own global experience with, that we'll have better answers for in the future. When we think about pulsatility, we realize that you can have continuous flow. It doesn't necessarily affect your end organs, but it does something that's not physiologic. You were not meant to not have a pulse. And we know that depending on which one of these things we do with continuous flow, either closed aortic valve, intermittent aortic valve opening, Levaris cycle, that the body sees blood flow in a different manner. In fact, I would say that the role of pulsatility, that even though there's no clinical significance having continuous flow, pulsatility has a great role in terms of reducing de novo insufficiency and ensuring that you don't have stiffer arteries, that is increasing arterial resistance, ensuring that you decrease pump thrombosis by reducing stagnant blood flow, perhaps ensuring myocardial recovery by allowing the heart to continue beating, and maybe the most important thing for all of our healthcare is for reducing admissions and adverse events. The concept of hemocompatibility has come across within the past year to say that maybe some pumps are better tolerated by the body than others. Myocardial recovery as a whole is still a black box. No one really knows. We know that when we take a look at the INTERMAX registry in between the year 2015 and 2016, there was almost 1,400 pumps placed, yet only 1% recovered to the point that they could be explanted. Now, when we think about explantation and myocardial recovery, it's just not the global function, right? It's not just the gross function. There's a whole host of genetic, microscopic, and protein alterations that occur in the heart itself that you can't necessarily measure by turning down the pump speeds and measuring things on echocardiogram. Future, I'm not going to talk about it because Dr. Salzman is the next talk, and that's his talk. All right? Now, we've thought a lot about what we can do to prevent adverse events, and perhaps the biggest adverse event is having a right heart failure. We have come up with a whole bunch of different papers that talk about how to assess and accurately predict RV failure, but to be honest, we're not good at it. What we're good at now is maybe bailing these patients out. You already heard about the Impella RP. There's a tandem Protoke Duo that you can use, and there's also double-stick tandem heart that you can use too, all to get us out of the trouble of getting into right heart failure after an LVAD. Indeed, when you look at patients that do have biventricular support after LVAD, the chance of being alive after 1 year is 50%, which I believe is quite dismal. We certainly have things like the total artificial heart. There's a patient that I did. I don't like doing it because I know that the chance of them being alive is 50% after a year. There's the CARMAT that's coming out that doesn't utilize mechanical valves in France that I think will hopefully be an advancement to the existing Syncardia heart, but we'll see. Undoubtedly, there's increasing ventricular assist devices being implanted in many more centers, many more patients having it. In fact, in 2016, it was the first time there was more VADs implanted in the United States than heart transplantation. So we have to be clever. We have to start partnering with our colleagues around the United States and around where the institutions are on the spoken hub model, where everyone feels empowered to take care of these patients. And as a result of this is where I am in Baltimore near Washington, D.C., so I go to all these various different places to ensure that patients get good care. When I look at the population that could be theoretically helped by these devices, it's about 1/3 patients. Heart transplants, as we said, is stagnant, but we have to ensure that the device that we're putting in has some degree of benefit to these. The roadmap study that we talked about shows that it's not there. Even though it improves survival, it actually has the same amount of hospitalizations due to adverse events as optimal medical therapy for those INTERMAX patients 4 through 7. We need to have better follow-up for these patients, and perhaps maybe better than better follow-up is that we need to be able to predict adverse events before they occur. And one of those things is going to be remote hemodynamic monitoring. That's either having smart pumps that tell you when a patient's having issues, or having pulmonary artery pressures with the CardioMEMS device that is going to allow you to know that a patient's in trouble before they get in trouble. Certainly drivelines, we have talked about the different stages of drivelines. We've talked about whether or not you should bury the entire velour underneath the skin, but the future lies in abandoning drivelines altogether, transcutaneous energy transfers. So undoubtedly, we have more and more tools. We're going to continue to make more devices, and each one of this is going to be up to the practitioner to figure out how to do them. But our patients are going to be increasingly more complex. There's a patient I did an aortic valve after he had a HeartMate 2, then I had to put a heart wear on his right side, and finally got him to a transplantation. The other one's double heart wears for biventricular device, and the other's a total artificial heart. So in my opinion, the contemporary utilization of left ventricular assist device shows an improving survival and wider application of these tools. However, the future depends on continuing to ease implantation of these devices, restoring physiologic blood flow, reducing adverse events, and perhaps most importantly, ensuring that when we put these devices, truly improving patients' quality of life. Thank you.
Thank you very much, Dr. Kilic, for the interesting presentation. This is a present for you. And we will proceed, because we don't have enough time, we will proceed with Dr. Selzman from the United States. Do we have LVAD-mediated myocardial recovery, lessons learned and future directions? Mr. Selzman.
Thank you so much for the invitation, Dr. Propis, in the group here. So I'm going to become very focused as opposed to Amit's wide, broad discussion here. The University of Utah is where I live right now, and it's quite known for the first implantation of a total artificial heart for destination therapy. This is a kind of a famous patient, Barney Clark, from 1982. And some big names, Willem Kolff and Dr. DeVries there, that got some fame and attention to this. But underlying all that was the team of Greeks that was there behind the scenes, Dr. Nanis, Kralios, Garces. And so behind the scenes of the total artificial heart is a strong Utah-Greek connection. And some of what I'm going to talk about today, I also will call out to our current Greek mafia that we have at the University of Utah, which is Dr. Drakos, and who we stole from University of Athens, and Dr. Koliopoulou, also from Evangelismos, and Dr. Bonios here, who's now at Onassis. So we're very grateful for the relationship that we have with our Greek colleagues. This is the slide that has already been shown that shows that there's not a lot of options for patients that have advanced heart failure. The transplantation is not increasing. We can put devices in, but one of the things that we all are a little bit mysteriously intrigued about is can we take the pumps out? So this is a 33-year-old female had heart failure, inotrope dependent. You can see she's got severe mitral regurgitation associated with this. We put a HeartMate 2 in this patient. 9 months later, we recondition, we test, and you can see that if you list this patient for transplant, and there's nothing quite as unsatisfying as going and opening up a chest and seeing a normal ejection fraction that you're about to take out with the transplant. So in this case, we went ahead and explanted the device. I'm not going to belabor the video. You can see on the left side the HeartMate 2, and we left the inflow cannula, and about 9 months later, we have now 2-year echo data on her, and you can see that her ejection fraction is still quite good. You can see the inflow cannula is still there in the apex. And we have another case that sometimes doesn't work out as good. This is a 19-year-old, and you can see the huge heart silhouette, and then when you put this was a HeartMate 2 in this case. A year later, he looked good, and we took out his pump, but we weren't able to completely get out his drive line. Sometimes the drive line is really stuck in there, and we didn't do sternotomy to remove this. He had recurrent infections of the drive line, which we think kind of led to him having decreased function, and ultimately we had to list him for transplant. So myocardial recovery doesn't always work. So what is recovery? It can have a lot of different things to talk about. It could be reverse remodeling, the shrinking of the heart, or it could be to the point where you look and you can look at genes and proteins and they all reverse and normalize. It's usually not that quite simple. As Dr. Killick showed, there's a sense that this does not happen very much. When you look at any INTERMACS slide, it's going to say that about 1% of the patients that have ventricular assist devices are candidates. We looked at this a little bit, and actually I should state back that this field kind of got energized, even though that there were heart pumps that were removed prior to this by the Harefield group and Yakub and Burks, who looked at 15 patients, and this was back in 2006, and had quite good results. The problem is when you look across the whole spectrum of this, is there's not a lot of programs that are very devoted to this, and these are more just kind of things that happen, and that's what INTERMACS is. So we looked at the INTERMACS group. We published this a couple years ago, and we looked at patients that were stratified to those that had a priori strategy of trying to get the pumps out. And if you look on the far left, maybe not. If you look on the left, you'll see that there was only 125 patients of about 14,000 patients that met this criteria. Long-winded way to get to it is we went ahead and created a score to look at whether or not these patients would be candidates for device removal. There's a series of characteristics, including age, non-ischemic dilated cardiomyopathies, renal function, whatnot. You plot this all out, and then you can create a score. And actually, I'll just get to the sum of it, which is that if you look at patients that are a priori designated as candidates for recovery, nearly 25% of them can actually have their pumps removed. When we validated this score against our own population at the University of Utah, we saw that about 40% of our patients could have their pumps removed. So there's this discrepancy between kind of all-comer registry data, which is INTERMACS, which is 1%, versus being a very aggressive approach to whether or not you can take these out. So if we summarize and look at candidates for recovery, you'll find that patients that are young, non-ischemics, a little better. In our population, only about 4% of patients that were ischemic were able to get their pumps removed. Short heart failure duration, and we do need to know that we exclude patients that have what are at least biopsy-driven myocarditis. So we try to not just say, we know myocarditis is usually going to get better. If their function gets better, and we do turn down echoes, which is very important when you look at these patients, you turn the pump down to look and see how the function is. You need to get reverse remodeling. And then you have to actually be very aggressive. You need to be looking at these patients on a weekly basis, up-titrating their heart failure medicines. And so the restage trial is something that I'll share with you. It was just presented earlier this year. It's the only prospective multi-center trial looking at myocardial recovery. It included patients non-ischemic, age less than 60, less than 5 years, so trying to have patients that were a little bit more amenable to recovery. This were the 5 or 6 centers that were involved. Louisville was the PI site, and we were very involved as well. And then we did turn down evaluations prior to explantation, which included showing that the heart got smaller, that the function got better, the hemodynamics were reasonable as well. It was a fairly young population, 35 years old, pretty sick. You can see that their hearts are big, 7 centimeters in dimensions. And if you look at their LV ejection fraction over time, you can see that it goes up prior to explant. Same thing with volume, so we can see nice reverse remodeling both in systole and diastole. And then if you look at the total group, there were 40 patients that were started, 36 that were able to be evaluated, 18 or about 50% were able to get their pumps explanted. So the question is, you take the pump out, but what good does that do? Is it sustainable? Does it hang on? And actually, if you look at the 16 patients that were involved that had their pumps removed, at a mean follow-up of about 2 years, the ejection fraction was about 47%. They didn't remodel again, most of them. They stayed below 5.5 centimeters. One of our patients actually committed suicide about 3 weeks after he had his pump. I don't know, maybe he missed his pump, but he actually stopped some of his bipolar medicines, so I'm not sure that counts. Well, anyway, it's a death. It was part of the program. And then it's a distinct honor to be able to sit here with Dr. Hetzer here. Clearly, the Berlin group has the widest experience of looking at these patients, and they've published 5 years, almost 2/3 of the patients were still free of their heart failure. And again, they show very similar things, that if your final turn down echo is good, you have a 45% or more ejection fraction. If you have a shrunken ventricle and in your heart failure is less, that you have a good chance. What about transplantation? If you look at the Harefield data and you look at folks that had their pumps explanted, the lines almost look the same as those patients that get transplanted. And if their post-exercise capacity, the orange dots are those that had their LVAD explanted, and the blue dots are those that are healthy controls. The gray dots are actually those that are getting transplanted, so that some of these patients that are explanted, because they're not taking triple drugs and all this other stuff to fight rejection and infection, are less valuable. So where are we going? This is a map of the United States. The red dots are the Salt Lake City is over on the Intermountain West over there. These is a grid of all of our patients that have been enrolled in a prospective trial that have looked at almost 450 patients now that we've prospectively looked at echoes and collected tissues on that have ventricular assist devices in. And this is important for us because it allows us to define what is a responder versus a non-responder. And we kind of already talked about it. The echoes aren't going to run. I'm going to keep moving. And we define responders as those that are able to decrease their size, reverse remodeling, as well as able to keep a good ejection fraction. It appears that this phenomenon occurs usually in the first 6 to 9 months. So if you're looking for it, you can look and really try hard for 6 to 9 months. We take the tissues. This is a very unique situation where we can get tissues at the time of the implant, at the time of transplant, so we can do all this serial follow-up. We can start looking for molecular signatures of recovery, and we are focusing particularly on metabolism and inflammation. I'm going to just skip through this stuff, but a lot of neat stuff in terms of structural, microstructural predictors. Dr. Bonios over there is looking at some really cool stuff, looking at the pre-LVAD in terms of rotational dynamics of the left ventricle. And what I've just tried to do in 11 minutes is what we spend 2 days talking about at this symposium, the Utah Cardiac Recovery Symposium. It's in January. If you want to come ski in Utah, please come out. And so in conclusion, one of the things that's important with this is that if you don't look for it, you're not going to find it. And if you just hope to see that your heart's going to get better, it's probably not going to work. You need to do turn-down echoes. You need to very aggressively up-titrate your drugs. We treat hypertension with 5 different drugs: high doses of carvedilol, high doses of both ACE inhibitors and ARBs, and now we're adding Entresto to some of these things. So we very, very aggressive in the medical management. If you give it a first 6 to 9 months. The future includes a lot of the stuff that I spent a minute talking about in terms of biomolecular predictions. Imaging has a large say to it. The way that the VAD is used is important. A lot of us just turn a VAD on and look at the flow and just stop. But the VAD itself and the speed that you use can be used as a dose. You can titrate the amount of unloading. And then finally, we just finished the Cardiothoracic Surgical Network doing a large-scale trial, about 169 patients, that's being presented at the American Heart Association right now, or maybe tomorrow, and that is going to be looking at using mesenchymal stem cells as adjuvant therapy. So, thank you very much.
Thank you. Thank you. I just would like to mention again that in 1997 we published our first 6 cases, and since then we have explanted pumps in more than 100 cases in Berlin, as you know.
Yes.
And it would have been nice to include into the symposium. My colleague Dandel
Dandel and Evgeny have both been over, so.
Because this will probably accentuate all the data. But I think this is very important that the topic is being picked up.
And we're very grateful for your work that you put into it. Thank you.
Thank you, Dr. Seltzman. We will continue with the next talk, Hamageorgakis, Total Artificial Heart Indication, Technique of Implantation and Outcomes.
Good morning, everybody. I would like to thank the organizing committee for inviting me to give this talk. Dr. Turina, Dr. Hetzer, Giorgio Drosso, Matteo Panagiotou, good morning. I'll talk about total artificial heart. I'm not going to say that I'm the expert, but I've done few cases. Certainly, I do not have the experience that Dr. Jack Copeland has or Francisco Arabia in the States. I have nothing to disclose. This is my home institution. It's Henry Ford Hospital in Detroit, Michigan. This is a patient that recently was supported with a total artificial heart as a bridge to transplantation, who received a heart and a kidney organ successfully. He was a law enforcement officer, then he switched, he became a pastor. This is a publication from the media when we successfully implanted the first total artificial heart in Baylor, Dallas, my previous institution, on a patient who 6 weeks later received a heart. We had the privilege and the fortune, because the OPO there, the Organization Procurement Transplantation Organization, we get many offers in a very quickly, and therefore we were able to transplant this particular patient within 6 weeks after the total artificial heart implantation. This is the patient who had the total artificial heart in Baylor, Dallas, who was successfully transplanted 6 weeks later. There have been more than 1,800 implantations of total artificial heart worldwide. Some of them were implanted in the United States, some of them were implanted in Europe. There are currently 2 devices that they are FDA approved to be used as a bridge to transplantation in the United States, and this is the Syncardia, the 50 cc's and the 70 cc device. Basically, males have received, the majority of the males have received the 70 cc device, and the majority are females that have received the smaller version of that particular device. The age distribution, most of the patients that they were 18 years of age and younger received the 50 cc device, and the older received the 70 cc device predominantly. There are 148 centers worldwide that have implanted the total artificial heart Syncardia, and the etiologies are ischemic cardiomyopathy, following extensive myocardial infarction, restrictive cardiomyopathy, HOCM patients, hypertrophic obstructive cardiomyopathy, post-infarction ventricular septal defects, patients who cannot have a left ventricular assist device implanted, and patients who have chronic rejection after an allograft implantation. Here is basically the same slide. And with regards to the outcomes, this is a graph that shows the competing events. Basically, over 60% of the patients have survived, including those that they are still alive, that are waiting for an organ, and those that have been successfully transplanted. This is an old study, a retrospective study that compared the TAH as a biventricular support mode and the biventricular support with the old generation volume displacement pumps, the Novacor, and what that shows is that the total artificial heart had a better clinical outcomes. The survival was better, and the overall survival and survival as a bridge to transplantation was better as well. Now, I will share something with you that basically it's unpublished data from the Intermax registry, and what that tells us is that the biventricular support with continuous flow devices now, compared to the total artificial heart, they have a little better 1 year and 2 year survival. The 1 year survival is 58% for the biventricular support with continuous flow devices, as opposed to 51% for the total artificial heart. And for the 2 years, about 50% for the biventricular support with continuous flow devices, and about 35% for the total artificial heart. And this has to do with the nature of the device, because the total artificial heart, the Syncardia, in that case, it's a volume displacement device, and we know from our experience from previous studies that in theory, the volume displacement devices, they don't do as well, they don't perform as well clinically as the continuous flow devices. There are currently 2 ongoing trials that, 2 ongoing destination therapy trials. The one includes basically pediatric patients, 18 years of age and younger, and this is for the 50 cc total artificial heart Syncardia device, and the second ongoing trial is for the 70 cc destination trial for older patients. We don't have any results yet, and that remains to be seen in the future. Again, the indications for the total artificial heart implantation are cases where the patient basically has biventricular failure, the patient is not a candidate for transplantation, or a graft is not imminently available, and biventricular support with conventional ventricular support devices is not possible due to anatomic reasons, such as ventricular septal defect, restrictive cardiomyopathy cases like HOCMs, primary cardiac tumors, etc. With regards to the implantation technique, this is a case that I did that Dr. Copeland, you can see on the screen on the anesthesia side, proctored me. For patients with BSA greater than 1.7 square meters, or a distance between the sternum and T10 greater than 10 centimeter, we choose the 70 cc device, and for smaller patients, the 50 cc device. The components of the total artificial heart are those things that you can see here. You see the two artificial ventricles with the two mechanical valves, the one atrioventricular valve and the other valve that connects the artificial ventricle with a great vessel, either the aorta or the pulmonary artery. You have the grafts and you have the drive lines. You spray the outflow graft with hemostatic agent to have a little better hemostasis. In this particular case, we sprayed with Co-Seal. And with regards to the technique of the ventriculectomy, you do a median sternotomy initially, you do standard bicaval cannulation, you stay normothermic, you cross-clamp the aorta, and you start excising the ventricle. You start from the right atrioventricular groove, and then you excise the tricuspid valve. You leave about 2 or 3 millimeter rim of the tricuspid annulus to sew your atrial cuff. Then you extend your incision over to the interventricular septum, and then in a similar fashion you excise the mitral valve and the subvalvular apparatus. You leave a rim of about 2 millimeters at the mitral annulus to sew the atrial cuff, the atrial connector. And this is the specimen basically to take out. And finally, what you do is you transect the great vessels, the aorta and the pulmonary artery, a few millimeters above the corresponding valves. And after having done the ventriculectomy, the right and left ventriculectomy, then you can either use felt or you cannot use felt. Doesn't go forward, I'm afraid. Can anybody help me with the remote? Does not go forward. Okay, good, thanks. And this is a picture after you have sewn the atrial cuffs in the tricuspid and the mitral position. And then you can test those cuffs to see if you have hemostasis. What you do is on the left side, you snare the vessel loops that you have passed around the superior and inferior vena cava. For the left side, you cannot do that unless you compress the pulmonary veins. And then you sew the grafts. The longer graft is the pulmonary arterial graft that crosses over the aortic graft, which is a shorter graft. The longer is about 6 centimeters and the short is about 3 centimeters. And then you pass a drive line through the subxiphoid area and you connect that to the console, and you connect the artificial ventricles to the corresponding atrial connectors and the great vessel, the big vessel grafts. And this is the final product of the implantation. This is my last successful implantation of total artificial heart. In conclusion, total artificial heart is indicated in cases for anatomical reasons. You cannot implant two continuous flow ventricular assist devices such as primary tumors, restrictive cardiomyopathy, HOCMs, post-infarction ventricular septal defects, or perhaps cases with extensive myocardial infarction where the myocardium is very friable to put a ventricular assist device. Thank you.
I think we have to proceed because we are already late. And I'm announcing the next presentation, LV reconstruction. Question is still a tool for heart failure treatment by Dr. Panhellenic. Oh, thank you.
Mr. Chairman, dear colleagues, after all this technological achievement, we will go back to muscle surgery and try to answer the question whether is it still a space for ventricular restoration in heart failure treatment. We know that if a transmural infarct happens and we lose more than 30% of the left ventricular circumference, we're going to have serious changes in both volume and the shape of the left ventricular cavity. And when we lose more than 40% of the muscle, the left ventricular end systolic volume index goes 3 times the normal values. But when our friends, our colleagues, the invasive cardiologists open the lumen, the common situation is not a transmural infarct, but partially necrosed LV wall, and which ends with akinesia and not dyskinesia. But both akinesia and dyskinesia do not contribute to myocardial contraction, so there is asynergy, and with both these asynergic conditions, we have triggering of the reverse remodeling with all the morphological and pathophysiological consequences that end to a situation which resembles dilating cardiomyopathy. Of course, the annular enlargement, the papillary mass displacement, and the tenting due to lack of proper coarctation brings us the functional mitral regurgitation, which is a very common situation together with the bad ventricle. We know from our cardiologists 30 years ago that the bigger the heart is after the infraction, the bigger the relative death risk. Also, we know that 1.5 hours after a huge myocardial infarction, if the left ventricular end systolic volume index is more than 60 ml per square meter, this is associated with both early and late mortality. So, from Yamaguchi, we know that the larger the heart are in both diastolic and systolic dimension, the poorer the predicted response will be to CABG alone. And we know also that a greater than 100 ml per square meter in left ventricular end systolic volume index is an independent predictor for the development of postoperative congestive heart failure in a single CABG alone population. Our Belgian colleagues from Brussels, Van Overzet, showed very clearly that when we deal with huge heart, with the left ventricular ejection volume index more than 70 miles per minute, even if we have substantial viability, we don't have improvement in ejection fraction after CABG alone. So, something else we're missing, probably the LV geometry parameter. This is the rationale for the ventricular restoration. Actually, we are dealing with a triple V concept of heart failure. We have to deal with the vessel, with the CABG, to deal with the mitral valve, and also to do something in the ventricle. And the decision to go on with ventricular restoration should be based not only on viability studies, not only on volumetric studies, but the final inspection in the OR is very crucial. We have well-described operation nowadays that can be adapted to
different scar distribution. If we have scar in the anterior septal or apical distribution, we can go on with linear closure, modified linear closure, septal exclusion, door operation, shave operation, Elliott, overlapping operations. If we deal with scar in the inferior wall, we have triangular patches, and most probably we have to do something with the mitral valve. And if we have a synergy in the lateral wall, we also can adapt, and there have been adapted different operations. This is the history of ventricular restoration. This is a very useful operation, the modified linear closure with a patch septoplasty. We know that we can exclude both the septal and the apical scar with this operation. You can see here the huge scar in the ventricular septum and how it is excluded from the left ventricular cavity with this patch. This is a very useful operation to be adapted also in post-MI ventricular septal rupture, as you can see here, with the same concept where we are excluding the dead area with this patch. The door ventriculoplasty is recommended for apical scar distribution. You can see here the pair string of the Fontan stitch and the circular patch. These are well described and operation. These are the measures for the residual diastolic volume from the history, from the cheapest balloon to the blue egg and to the Menakin devices. This is the Japanese proportion for septal anterior ventricular exclusion from our colleague Suma. And this is the same concept, the septal exclusion from the Italian school, from Antonio Calafiore. It creates also a new apex, and the new apex concept also described by Lorenzo Mercati from the Milan school. The endocardial linear infrared exclusion technique, another Japanese, and the overlapping as a volume reduction operation with no patch use. For the inferior wall, we have the triagonal patches, we have adapted here, and the endocardial linear infrared exclusion for the Kyoto group. You have to mind the interpapillary mass distance. It's a very good operation because you not resect the wall, you have low risk of coronary damage and shortens the papillary muscle, so you're reducing the tending. A modification of this is the, by Suma proposed, the imbrication techniques and the papillary muscle relocation. You can see you end the ventriculotomy 2 centimeters from the mitral valve annulus, and you can also create cryotherapy in cases of malignant arrhythmias. I'm not going to stay in the not well designed and stitch protocol, but I'm going to show you that the stitch protocol reduced the ventricular volume to a less extent than any other previous series was in the literature. So this must be the main reason that the stitch protocol did provoke the crisis in the ventricular restoration. I'm going very fast. And the 3 papers that changed the history after the stitch was the first published by Dr. Dorr. Actually, he presented 117 patients that were excluded from stitch trial because they were sicker. They didn't have target coronary, they were acute heart failures, they were VS rupture, they were dependent on inotropes and balloons, they have multi-MI patients, and he presented very favorable results. Also, from Netherlands, our colleagues showed that the stitch results can be modified if we see
the residual end systolic volume index. So the patient with the residual end systolic volume index less than 60 do better than the others, so they have a survival benefit. This was also shown by the trial investigators, and this actually kept a place for ventricular restoration in the recommendations, only with the achievement of postoperative end systolic volume index of 70 or less. This is two more series by Calafiore. Nowadays we have much worse patients than the stitch. We have 84% of mitral valve combined procedure and 1 out of 3 patients with diastolic dysfunction. The same from recent from Japan. So we're going to conclusion that the choice to perform ventricular restoration should be based on a careful evaluation of patients. We should have heart failure symptoms predominant over angina. We should have acute measurements of geometric parameters, careful evaluation of mitral valve, assessment of transmurality, assessment of viability in the remote areas, should be performed only in centers with a high level of surgical expertise. So, despite controversies, ventricular restoration, the muscle surgery seems to have a role in treatment in ischemic heart failure, especially if a postoperative end systolic volume index can be less than 70 ml can be predictably achieved. The choice should be to proceed with the ventricular restoration procedure should be as a result of a tight collaboration between surgeons, cardiologists, and radiologists. So I'm saying that it is still a useful tool for heart failure surgical treatment, especially as a part of the triple V concept. Thank you very much for your attention.
Thank you very much. I now have the honor to introduce my co-chairman, Professor Turina, who will give us some insight into the early times of heart transplantations.
Thank you. Ladies and gentlemen, I wanted to share with you some of the lesser known aspects of the heart transplantation. Everybody knows the story of heart transplantation. It began when Christian Neethling Barnard performed his transplant on December 3rd, 1967. It was a world sensation. I happen to know Chris Barnard since 1973. And I have been meeting, he has been coming to Zurich, he became a friend, so we were quite close, had a lot of discussion together. The whole thing, which if you ever brings your travel to Cape Town, by all means go and visit the museum in the Crossroad Hospital, where the whole thing started. Crossroad is now new built. This is a new building under the very spectacular location, but in this is a Heart of Cape Town museum. This is the old Grotescour operating room tract, which was totally reconstructed, and everything looks exactly in the time in the first heart transplant. And you can find all information, lesser known facts about the transplantation, for instance, about the details about the donor, the first accident which killed Denise Darval, who was the first donor. It was a drunk driver on 10:30 in the morning who hit her. She was out with her mother, and she suffered a terminal brain damage. You can go to see the operating room where the first transplant was performed. It's exactly reconstructed with the original instruments for those times, and there are human figures which show exactly how the operation was done. It's also a donor operating room you can see. The interesting facts remain, for instance, the ethical rules. Grotescour directors were very careful about the ethical aspects of it, and especially in the time of racial segregation in South Africa. So they made the rule number 1, to avoid controversy, donor and recipients must be a white race. It is obvious now when you think about it. If he has taken a heart from the black man, they would say, oh, the patient was not quite dead or something like this. And he would have put a heart in a black man, they would say he was experimenting on the blacks. That is why the rule, white donor and white recipient. And second rule was more difficult to follow. It said that the donor heart must stop before starting organ harvesting. There was no rules about the brain death at that time, so the heart had to stop. The first report was written by Christian Barnard. It was published 27 days after the transplant. It's probably the world record in publishing. And it is very interesting to read. You can find it in internet. And there is a very meticulous report exactly describing the patient, the donor, describing the recipient, the condition, the way it was organ retrieval was done, the way transplantation was done, really interesting to read. But when you look at the Christian Barnard, you will see that his academic credentials are really very impressive. Not only an MD, but Master of Science, PhD, and Fellow of American College of Surgeons, and Fellow of American College of Cardiology. He was well established as surgical scientist when he performed. It was not just a quick reaction when he performed his first transplantation. Some other lesser known details is, for instance, that the anesthesiology at that time was really primitive. There was no oscilloscope and the arterial catheter to measure blood pressure. The blood pressure during surgery was measured by the mercury manometer. In the old times, central venous pressure by water, and the astrup they had could measure only pH and PCO2, but not PO2. And there was, of course, no saturation measurement. The ischemic heart arrest was 8 minutes in normothermia. It meant that they were prepping the donor and they had to wait until the heart stops. And when the heart stopped and there was a pathologist present to certify that the heart really stopped, then the Christian Barnard opened quickly the chest, put the patient on cardiopulmonary bypass, and then cooled the heart in bypass. So it took him 8 minutes to get the heart, to get the cardiopulmonary bypass going. And then there was only 14 minutes after retrieval of the heart. It took him only 14 minutes to go to the other operating room and attach aorta again. So he must have been a very superior surgeon, and you can read about it, his book about the tetralogy of Fallot, which is also a difficult surgery, which has excellent results. The recipient had a pulmonary hypertension of 11.5 Wood units. He would never been accepted for transplantation in present times. He would be put on an assist device to see if we can get his pulmonary resistance down. But he was really inoperable by present standards. And it is logical that support with the pump oxygenator could be stopped only after 3 hours and 41 minutes. They tried 2 times to go off bypass and they couldn't go in spite of catecholamines, and they had to go on bypass again. Of course, that was a high pulmonary vascular resistance, and I don't know how much Christian Barnard was aware of the problems, because it's something that does not exist in animal experiments. And it's also a fact, it was, of course, the nighttime procedure, and nobody took photographs or movies. And he told me that afterwards the media were offering him millions for a single photograph of the first heart transplantation. There were none. His immunosuppression is partially modern, partially old. He used hydrocortisone 500 milligrams as a loading dose, and then 100 milligram daily, similar today. He was using mercaptopurine, 150 milligrams a day, also well-known fact. By that time, the opinion was that the cobalt radiation is necessary to reduce the rejection. So the patient was pushed every day to radiology and had a cobalt radiation of 100 rads per day. And he used actinomycin C for rejection at 200 microgram per day. The first patient died soon after the operation. It was a tragic situation. He was Orthodox Jew. There was a Jewish burial ceremony, and he died only 18 days after the operation. He was over-suppressed. It was a pneumonia, the cause of death. The technique which Christian Barnard used, of course, is not his technique. He learned it in Minneapolis, and he later visited Norman Shumway. It is called Norman Stanford technique or Lower Shumway technique, which is the old technique of a biatrial attachment. Biatrial attachment, I used it until 1989, and then I switched, like many other people, to bicable anastomosis, but this was the technique used in the first heart transplantation. But it is not the first heart transplantation, the Christian Barnard operation. The first transplantation heart in history was done by James Hardy, professor of surgery in Jackson, Mississippi. And in 1964, he transplanted in a patient who they couldn't separate from cardiopulmonary bypass after valve surgery. He reported it in JAMA in 1964. He used a chimpanzee heart. They had a lab, they were working on this problem, and they took a chimpanzee heart from the experimental lab and put it in the patient. It did not work. He said the heart was too small, but most probably it was a hyperacute rejection which caused the death of the patient. Another impressive reading, which I don't know if you read, it is by Jordan Haller, working with Kantrowitz and Mount Sinai, and that it was published in American Journal of Cardiology in 1968. They brought together first surgeons who did heart transplant, and it was tabulated, for instance, in the first 19 cases of heart transplantation worldwide. It is interesting to note that only 3 patients survived more than 30 days. So it was a real rocky beginning, and the people who were doing transplants were really not qualified. They did not have experience with immunosuppression. They had a very poor myocardial protection, so the death rate shortly after surgery and during surgery was high. And when you look how it happened worldwide, 1967 he did his first transplantation. In 1968, every well-known surgeon thought he will have to do a heart transplant, and the results were disastrous. They were really not prepared, especially from the aspect of immunosuppression. 1969, only half of the number of transplants were done. 1970, few. And since 1971, it was only Stanford which continued persistently to perform heart transplantation. The Christian Barnard, which is also lesser known, was so disappointed with the results of heart transplantation that he introduced the technique of heterotopic transplant, not to rely completely on the transplanted heart in the action. So this he has done about 49 of these transplants, some of them surviving several years. And the breakthrough, of course, was developed the cyclosporine as immunosuppressant. Philip Caves developed on myocardial biopsy with a microtome. He died very young, 38 years old, had a family history of coronary artery disease. And the Margaret Billingham, the Tanzania-born pioneer, she formulated the classical histological grading of transplantation. And all this together and all this advancement you see in green line is the increase of the median survival of patients after all these numerous improvements. And nowadays, when you look at the graft survival, kidney and heart have approximately equal graft survival at 10 years, which is really positive for us. And you know everything how it happened. You've seen again the number of heart transplants increased, and they are kind of stagnating, most of them being done in the United States. The real problem remains, it is here in use of visible, the very low number of donors. And strangely enough, if you can read the upper part of the scale, 2 countries which are really not the world centers of cardiac surgery, Slovenia and Croatia, have the highest number of transplants because they have a very clever policy of this. We cannot go into details, but governmental support, support of the hospitals doing this transplant, they really improve the number. My own country, Switzerland, is placed in a second league on a low number of transplants. The US, it's 10.1 per million. So to summarize, this is a perfect definition that the homografts owe their surgical promise not to the number, but to the gravity of the occasion on which they might be used. And that is why we are still fascinated with the transplant. It was Sir Peter Brian Medawar, Nobel Prize winner in 1960, which formulated that. Thank you for your attention.
Heart transplantation versus mechanical circulatory support is the gold standard changing?
Dear Chairman, dear ladies and gentlemen, I first want to thank the Society for the kind invitation. It's a great honor for me to speak here, and after this wonderful presentation about the past of the heart transplantation, I will now jump on the present and the future. This slide doesn't. Okay. As you can see here on the ISHLT graph, this is the number of annually performed heart transplantations by year, and you can see they're pretty stable over the last years. However, when you're looking at the yellow chart, which represents the number of transplants in Europe, they are steadily declining. When you're looking at the transplant outcome, what we've already seen is that there has a major improvement, and the median survival time is now over 12.2 years for the heart transplant patients. Also, the functional status of these patients receiving a transplant is pretty good, and also pretty good over the long-term course of 5 years. They have a high quality of life. However, as we already have heard, in European countries, and especially Eurotransplant countries, is a donor organ shortage, and we have a much higher number of patients on the waiting list than we can perform transplants, and there's a big mismatch between the donor organs and the recipients that would need a transplant. Especially here in Germany, we have a situation where we have a rapid decline numbers of heart transplantations, and in 2017 there have only been performed 253 transplantations in Germany, and if we see we're coming from over 500 transplantations per year in the mid-90s, that's a rapid decline of transplantations. With that, the median waiting time in days is increasing, and especially in Germany, you can see the red graph. We have a median waiting time for more than 100 days at the moment. Why is this the reason? This is probably because the organ donation rates per million are relatively low in Germany, and if you compare it to Spain, which is the #1 country in Europe, we have 35.3 donors per million population, and in comparison in Germany we have only 9.7%, so this is one of the problems that we have at the moment. In several European countries there is some discussion how to increase the organ donor pool, and the Netherlands have recently implemented a new system for the organ donation, and they have used already, they're going to use the opt-out solution, which means that all adults are organ donors unless they opt out. And there are several times they get 3 letters, and if they do not respond, or they respond with yes, they are an organ donor. In Germany, there's much discussion at the moment in the politics and the newspapers if we also should use an opt-out solution, but the debate hasn't come to an end, and we need to see what we can do, and probably in the future we have also to use some opt-out solution to get more donors, but until now, there has no decision been made. What can we do to extend the donor pool unless we don't have an opt-out solution for donors? We have to think about other possibilities. The use of marginal donors is probably one of the solutions we can go for. And if we're looking at the median donor age, we probably also using some kind of marginal donors regarding the age. If you compare the median age of the donors from the patients in Europe, which is 45 years, compared to North America or the other countries with less than 30 years, we're probably already using some kind of extended donors. Another possibility to extend the donor pool would be the use of DCD donors, but this is also not allowed in most of the European countries. But in the UK, they've been performing several cases in Harefield and Pepper's, and in Australia, St. Vincent's Hospital, they've a total of 45 transplant from DCD donors, and they have pretty good survival rates of 90.1 year and 90.1 after 1 year. So probably this would be also an option to increase the donor pool, but as I already said, it's not allowed in most of the European countries. Another possibility could be the organ perfusion with transportable organ care systems like the Transmedic system, where we probably could increase the radius of the retrieval for the organs. However, this has to be proven in prospective and large studies. But this could be a solution in the future to increase the number of donors. I've already told we have declining number of transplantations in Germany, but with that we have an increasing number of LVAD or airward implantations. We had 1,003 WAD implantations in 2017. We've already heard the several generations of durable devices, and now we're using mostly the centrifugal pumps, the HWAD or HeartMate 3. And when looking at the outcomes, the probability of survival had changed over the years, and here you can see the 24-month survival of the different generations of the LVADs, and you can see that the newest generation are, especially in the short-term run, which means 24 months, are performing as good as the heart transplantation, however limited in the long-term run by several complications like bleeding, strokes, infections. The LVAD therapy has been proven to be superior to the optimal medical treatment. This is the roadmap trial, which has shown superiority after 12 months for the HeartMate 2 device compared to the optimal medical treatment. Then the newer generation assist devices like the HWAD have been intensively investigated in post-CE mark registry like the REVOLVE trial, and you can see they have good results during the first 2 years. However, we have to admit they have a high or intensive rate of complications like bleeding, strokes, driveline infections in the long-term run. We've already seen the newest publication of the Momentum 3 trial, which had been a prospective randomized trial comparing the HeartMate 2 versus HeartMate 3, and the primary endpoint was a survival-free of disabling stroke or survival-free of reoperation to remove or replace the device. And what we've already seen is that we have a superior event-free survival for the HeartMate 3 device, and this is mostly driven by the number of reduced pump thrombosis and the reduced number of strokes. But however, as Professor Kielisch already has told us, a number of 10% strokes during a 2-year period is rather high. But this is some improvement in comparison to the older and assist devices, and probably we we'll see some improvement in the future, and then we'll see. The 2016 ESC guidelines have also implemented the ventricular assist devices as a bridge to transplant and destination therapy with a Class 2A indication. And what either you're doing a transplantation or LVAD implantation, a very essential thing is that you have a designated multidisciplinary team, including a heart failure cardiologist, psychologist, general practitioner, a coordinator, and a surgeon, so that all of these specialties are together trying to improve the patient's outcome and do the best for the patient. So in conclusion, I would like to say that heart transplantation is an established and successful treatment of end-stage heart failure for more than 50 years now. The long-term results and the quality of life are excellent. However, the organ donation is further decreasing, particularly in European countries like Germany and in Asia and Africa. Therefore, we need surgical alternatives like the ventricular assist devices. There have been a significant increase in the number of WAD implantations, and up to 2 years the survival is comparable to the heart transplantation. However, in the long-term run, the main complications like driveline infection, pump thrombosis, or stroke need to be further reduced. Probably the indications and rules for the heart transplantation are ventricular assist device need to be modified in terms of that we need to see which patient will get the organs that we have, and the heart transplantation will always be the gold standard, but will remain a rare operation and should be restricted to the patients with a high probability of the long-term success. Thank you for your attention.
Thank you, Dr. Pea. Sorry, but we are really 20 minutes late and you would like to have your coffee. We'll have to cancel the discussion, and thank you for your attention.
Very interesting subjects. I guess we should start this session. First talk will be by Dr. Dimitrios Iliopoulos, and the title is Recent Advances in Surgery of the Thoracic Aorta. Dr. Iliopoulos. Okay, Dimitri. Ring the bell.
Should we start?
We wait for the bell. Okay, you may start.
Okay. I would like to thank the organizing committee for this invitation to participate in this great congress. And my lecture is on recent advances in surgery of thoracic aorta. The descending thoracic aorta is a very, very special segment of the whole aorta, and is the classification is according to this ABC. These A thoracic aortic aneurysms have a high incidence of strokes in manipulating this upper segment. This kind of aneurysms have high incidence of paraplegia, and the most difficult, like thoracos type A, is type C. The indications are known, therapeutic and prophylactic, and we have to concentrate on the symptoms, size, and growth. And the aneurysm growth, according to many publications, is something like 2 to 3 millimeters. Over 4, 5, we have to consider that is an active aortic disease. The monumental paper by Crossroad and Natal in 1986 put the evidence and the basis of the treatment of these aneurysms, which means that the fate of this disease, if remains untreated, is very, very bad. First attempts in Houston by Cooley and DeBakey in 1953 for the surgical treatment of this disease, and first publications by DeBakey, these excellent pictures. And it's very important for us to know that the growth rates of thoracic aneurysm, descending aortic aneurysms, are higher than the other segments. It's an indolent process. And as we can see here, over the size of 6 centimeters, it seems that there is a very, very high incidence of rupture, dissection, or death. So we have to be very careful, and we have to measure and to calculate the aortic size index, which is the safest index for whom we will operate, and this is the risk of complication according to Cody's group. We know that in a dissection, 1 second before the event, the thoracic aorta is 30% smaller. So many aortas with small diameters in special groups of patients could dissect. And now we go to this surgical treatment. We have to know that the application of the aortic clamp at the upper segment has a high incidence of strokes, which are very, very bad events, especially when cover the posterior territory of the brain. And then we have to know how to dissect the area away from the esophagus, which is very important, away of our suture line, and to protect the intercostal. The surgical treatment is, of course, something that cardiac surgeons have to do, because the protection, the organ protection, means that we have to put the patient on partial bypass, left partial bypass, to drain the CSF and also to give blood to intercostal arteries and to protect the lower part of the body. And we know the drawing, what happens with the ischemia of the spinal cord, and these are a very important paper came from our group, which shows that the lower numbers, 9, 10, 11, and 12, intercostal arteries, if are ligated or occluded or not reattached, have a higher incidence to produce paraplegia. Something that is very important if we have repair in endovascular or open repair in abdominal aortic aneurysm, as we can see. And of course, I will concentrate not in the surgical treatment, but in the endovascular treatment. And this is, we cross the Rubicon, and we use now the endovascular treatment, which is recommended in most cases. And the first device was put 12 years ago. And now we have from the United States a population-based analysis which show that the elective cases and the open repairs and the endovascular repairs somehow increase. Endovascular repairs increased a lot, and open repairs somehow diminished, and but the total number is increasing. Why? Because we discover more descending thoracic aneurysms, and this is the treatment after 2005 with the TEVARs. And here we can see that 64% of TEVARs applied on descending thoracic aneurysm treatment, instead of 10% for traumatic disruption or 8% for aortic dissection. So more patients with aneurysms are treated, but also the acute type B dissection has endovascular treatment plays a great role. This is the trend in a type B aortic dissection, TEVARs, and the TEVARs, it's interesting that most cases are performed by vascular surgeons, not by cardiac surgeons. And it's very important to know that we have cardiac surgeons to be in this field, because in cases of complications, who will treat the patient? That's the question. Aortic surgery is especially thoracic aortic surgery, has to be done by cardiac surgeons, not by vascular surgeons.
You have 2 minutes. You have 2 minutes.
2 minutes. We'll continue. We'll continue. A lot of cases, very interesting. And now see what happens if we have synchronous or metachronous thoracic aneurysm with abdominal thoracic aneurysm. See that 25% of these patients having an aortic aneurysm, abdominal aortic aneurysm treated, have also thoracic aortic aneurysms. So we have to consider, because this group of patients have higher incidence of paraplegia. This is the open repair. These are the requirements, the debranching that we have to do, and the clinical results, the early results from the open repair, see that we have a renal failure of 5.3, paraplegia 3.7, and mortality 8.8%, which is a big high incidence of mortality. And we go also to the TEVAs. In 30 days, we have similar results and paraplegia, and with open repairs, of course, the death again is 5.2. Now we have this Koselis analysis, which show that, of course, TEVAs are better than open repairs in this field, or that complications are significantly lower. Women need more conduits, longer OR times, and higher mortality, 6/3. And again, the female sex predicts the mortality after thoracic endovascular repair, which is great, 7.6, and the stroke rate, 4.7. And the paraplegia numbers are high, so we need to protect the spinal cord. And of course, we have to insert in these repairs CSF drainage. In cases that patients had a repair, abdominal aortic repair, the spinal cord ischemia is increased during TEVA, after TEVA treatment.
Can you wrap it up, please?
And the stroke risk is high. The migration is a big problem, and the endoleaks also is a big problem with this new endo anchors to treat the endoleaks. In my opinion, or according to the results of many studies, we have to go to this point that although the mortality is improved, we don't have still long-term survival, and the advantage should be expected after a long period and studies that will come. Neurological complications is an issue, and expansion of the aneurysmal sac is a big problem for these endovascular devices. Thank you.
I guess we're going to proceed with the second talk and all the questions later. The second speaker is John Kakotsakis, and he will talk to us about aortic arch replacement using the frozen elephant trunk technique, surgical strategy, and brain and spinal cord protection. John?
Καλημέρα σας και ευχαριστώ την Οργανωτική Επιτροπή, ο μέρος μου, για την ευγενή πρόσκληση να συμμετέχω σε αυτό το σημαντικό συμπόσιο της χώρας μας. Θα μιλήσουμε για την τεχνική Frozen Elephant Trunk
τη χειρουργική τεχνική που εφαρμόζουμε στο νοσοκομείο Ευαγγελισμός και τις μεθόδους προστασίας του εγκεφάλου και του νοτιαίου μυελού. Σίγουρα η αντιμετώπιση της σύμπλοκης αορτικής παθολογίας στο θώρακα, είτε ανευρίσματος είτε διαχωρισμού σε 3 επίπεδα, αποτελεί μεγίστη πρόκληση για όλους τους καρδιοχειρουργούς. Από την εποχή της πρώτης επέμβασης αντικατάστασης του αορτικού τόξου στο Houston από τους Cooley-Debakey μέχρι αργότερα την εφαρμογή του Elephant Trunk του κλασικού από τον Bosch στη Γερμανία, μέχρι την τελευταία ανακάλυψη, την τεχνική του Frozen Trunk από ένα Ιάπωνα το 1996 το Γκέιτο, και η ονομασία αυτής της τεχνικής πάλι από τον καθηγητή Bosch σε Frozen Elephant Trunk. Οι ενδείξεις της τεχνικής αυτής αφορούν είτε ανευρισματική νόσο του αορτικού τόξου και της εγγύης κατιούσας, οξύς χρόνιους διαχωρισμούς τόσο τύπου Α όσο και τύπου Β, ανευρίσματα συγγενούς προελεύσεως του αορτικού τόξου όπως είναι η ανώμαλη εκφιωμένη δεξιά υποκλίδιος ή αριστερή υποκλίδιος αρτηρία και επιπλοκές των ενδαγγειακών τεχνικών. Οι υπάρχουσες συσκευές που χρησιμοποιούμε στην Ευρώπη κυρίως είναι είτε το Evita Open Plus είτε το Thoraflex. Οι δύο άλλες, το Cronus χρησιμοποιείται περισσότερο στην Κίνα και το Frozen X στην Ιαπωνία. Η εμπειρία μας αφορά κυρίως σε 35 περιστατικά το Evita Open Plus και που βλέπετε εδώ και κατά δεύτερο λόγο το Thoraflex. Όλες οι χειρουργικές αυτές επεμβάσεις είναι εξαιρετικά πολύπλοκες και αυτό οφείλεται στο γεγονός, πρώτον, στη χειρουργική προσπέλαση, δεύτερον, στην προστασία του μυοκαρδίου, την αντιμετώπιση της αορτικής βαλβίδος και γενικά την προστασία εγκεφάλου, νοτιαίου μυελού, αλλά και περιφερικών οργάνων. Το σύστημα της εξωσωματικής κυκλοφορίας που χρησιμοποιούμε είναι αρκετά πολύπλοκο. Καταρχάς, ο ασθενής τοποθετούνται στον ασθενή 3 αρτηριακές γραμμές, 2 κερκιδικές και 1 μυριαία, και το σύστημα της εξωσωματικής κυκλοφορίας έχει 3 pump heads. Ένα για συστηματική κυκλοφορία, δεύτερον για αιμάτωση του εγκεφάλου και τρίτον για την χορήγηση καρδιοπληγίας και την προστασία του μυοκαρδίου. Τα τελευταία χρόνια στην Ευρώπη η πλέον συχνά χρησιμοποιούμενη θέση διασωλήνωσης είναι η δεξιά μας χαλιά αρτηρία και η εγχείρηση γίνεται σε μέτρια υποθερμία 22-26 βαθμούς Κελσίου. Εναλλακτικά, στην περίπτωση που δεν είναι δυνατή η διασωλήνωση δεξιάς μας χαλιαίας αρτηρίας και πάμε στη μυριαία, τότε θα πρέπει να τοποθετηθούν, όπως βλέπετε στην πρώτη εικόνα, 2 καθετήρες ορθόδρομης εγκεφαλικής άρδευσης σε ανώνυμο και αριστερή καροτίδα. Όσον αφορά την προστασία τώρα του νοτιαίου μυελού, ξέρουμε ότι με την ορθόδρομη εγκεφαλική άρδευση η προστασία φτάνει περίπου μέχρι το θ8 level. Πιο κάτω είναι πλημμερής. Γι' αυτό επιμένουμε στην διατήρηση μέτριας υποθερμίας 22-26 βαθμών. Χρησιμοποιούμε άρδευση πάντα της αριστερής υποκλειδίου αρτηρίας, η οποία μέσω της σπονδυλικής βοηθάει στην προστασία του νοτιαίου μυελού, και κοιτάζουμε να συντομεύσουμε όσο γίνεται περισσότερο την υποάρδευση του σώματος. Μεγάλη σημασία μεταχειρητικά είναι η διατήρηση της μιας μέσης αρτηριακής πίεσης πάνω από 70. Εν συντομία, τα procedural steps είναι πρώτο το cannulation through the right axillary artery, η χρησιμοποιούμενη συσκευή, η εισαγωγή της οποίας διευκολύνεται με καθετήρα Foley με το οδηγό σύρμα, η distal τοποθέτηση της συσκευής, η τοποθέτηση μοσχεύματος 4 διακλαδώσεων στην distal αναστόμωση, άμεση έναρξη της άρδευσης του σώματος από το perfusion branch της προσθέσεως δάκρων και είτε ακολουθεί, αν είναι multi-branch προσθήσεις, η αναστόμωση της left subclavian artery, είτε γίνεται η αναστόμωση island, όπως βλέπετε εδώ. Ακολουθεί η proximal αναστόμωση και τελικά οι δύο αναστομώσεις των τελικών κλάδων αριστερής καροτίδας και ανωνύμου αρτηρίας. Στην περίπτωση που έχουμε εξωανατομική παράκαμψη της αριστερής υποκλειδιοαρτηρίας, εδώ βλέπετε την κεντρική αναστόμωση του PTFE δάκρων στην ανιούσα ορτή και το τέλος της εξωσωματικής κυκλοφορίας. Εδώ βλέπετε περιστατικό με island τεχνική και η μετεχειρή του αγγιογραφία. Τα πράγματα όμως δεν είναι πάντοτε έτσι εύκολα και εδώ βλέπετε ένα περιστατικό 70 ετών, ο οποίος είχε resection of acute type A dissection 3 years ago and the graft ήταν κολλημένο στην οπίστια επιφάνεια του στέρνου μαζί με τη δεξιά στεφανιαία αρτηρία, πράγμα το οποίο απέκλειε εύκολη επαναστερνοτομή. Και σε αυτή την περίπτωση αναγκαστήκαμε να πάμε σε hypothermic arrest στους 18 βαθμούς, με άρδευση όμως through the left subclavian artery and the left common carotid artery και να ακολουθήσουμε debranch τεχνική για να γίνει η επέμβαση. Και εδώ είναι το μετεχειρητικό αποτέλεσμα με remodeling της chronically dissected aorta μέχρι το level του stent graft. Εδώ είναι debranching τεχνικές σε ένα ανέβρισμα με δεξί αορτικό τόξο, 6,5 εκατοστά descending aorta και distal arch, όπου βλέπετε έγινε ξεχωριστή αναστόμωση όλων των κλάδων του αορτικού τόξου. Και τον τελευταίο χρόνο έχουμε εφαρμόσει την τεχνική αυτή του debranch first, δηλαδή σε περιπτώσεις reoperations που είναι δύσκολη, παίζει μεγάλη σημασία ο χρόνος, κάνουμε πρώτα αριστερό καροτιδοϊποκλίδιο bypass και debranching όλων των κλάδων με διπλή εξωσωματική κυκλοφορία από ascending aorta και right axillary artery. Η τεχνική αυτή διευκολύνεται τα μέγιστα με αυτή την καινούρια έκδοση του Evita Open Graft, η οποία όμως δεν είναι διαθέσιμη. Εδώ την διαθέτουν μόνο στο τμήμα του Σαν Ραφαέλε, που βλέπετε υπάρχει ένα side branch για perfusion και ένας δεύτερος για το debranching του αορτικού τόξου. Τώρα, στους οξύς τύπου Α διαχωρισμούς, τα αποτελέσματα του ΦΕΤ είναι σχετικά θεαματικά. Εδώ είναι ένα περιστατικό με non-anon B acute type A dissection με malperfusion, όπου βλέπετε φοβερή συμπίεση του αληθούς αυγού από το ψευδί με preoperative high lactate levels, όπου εφαρμόσαμε την τεχνική ΦΕΤ και βλέπετε το remodeling της κατιούσας θωρακικής αορτής μετά την επέμβαση, την επανάρδευση του celiac superior mesenteric and right renal artery and 6 years still stable findings μετά από το FET. Εδώ είναι σε chronic type A dissection με rupture in the trachea, pretracheal space, που βάλαμε ένα bovine pericardium να καλύψουμε την τραχεία και έγινε bental και FET. Εδώ είναι FET in pseudoaneurysm, ruptured, that was managed with a classic technique and the postoperative result, and FET in chronic type B dissecting aneurysm with concomitant ascending aneurysm. Έτσι, η τεχνική FET στους οξύς διαχωρισμούς αποτελεί ιδανική μέθοδο για να αντιμετωπίσουμε όλα τα σύνδρομα του malperfusion. Η μεταφορά της δίσταλ αναστόμωσης μεταξύ αριστερής καροτίδος και αριστερής υποκλειδίου έχει διευκολύνει τα μέγιστα την επέμβαση, διότι έτσι αποφεύγεται και η κάκωση στο παλίνδρομο λαρυγγικό ή το φρενικό νεύρο. Με την συσκευή Evita επιτυγχάνουμε πλήρες remodeling τόσο στους αξίς όσο και στους χρόνιους διαχωρισμούς μέχρι τη μεσότητα της θωρακικής αορτής και αποφεύγεται η μελλοντική δημιουργία περιφερικών ανευρισμάτων σημαντικά ποσοστά. Τα τελευταία 11 χρόνια έχουμε χειρουργήσει 37 ασθενείς με διάφορους συνδυασμούς ανευρισμάτων και διαχωρισμών, 12 οξέα αορτικά σύνδρομα. Εδώ βλέπετε το comorbidity Στις περισσότερους έχουμε χρησιμοποιήσει cannulation της right axillary artery με separated graft 28 περιστατικά και 9 island. Είναι μακριές επεμβάσεις, πολύ ώρες. CSF drainage δεν χρησιμοποιούμε πλέον μετά την μεταφορά της περιφερικής αναστόμωσης στη ζώνη 2 παρά μόνον εάν μετεχειρητικά ο ασθενής παρουσιάζει συμπτώματα παραπληγίας ή παραπάρεσης. Mortality γύρω στο 16 με 18%. And these are data from Dr. Jacob's place in Essen, Germany, που είναι στο ακροατήριο μαζί με τον Dr. Τσαγάκη, όπου υπάρχει το Διεθνές Registry πάνω από 1000 περιστατικά. Εδώ βλέπετε τη θνητότητα με για τέτοια περιστατικά εξαιρετικά αποτελέσματα. Και για να γίνουν επιτυχώς αυτές οι επεμβάσεις χρειάζεται καταρχάς αορτικό κέντρο, όπου να γίνεται centralized των περιστατικών με έμπειρους καρδιοαορτοχειρουργούς, αναισθησιολόγους, πολύπλοκη εξωσωματική κυκλοφορία και οπωσδήποτε εξειδικευμένο προσωπικό στη μονάδα εντατικής θεραπείας. Κατά συνέπεια, τελειώνοντας, θέλω να σας συμπληρώσω ότι η τεχνική ΦΕΤ είναι πολύ σημαντική, είναι ίσως η μεγαλύτερη πρόοδος που έχει συμβεί στην ανοιχτή χειρουργική της αορτής τα τελευταία 15 χρόνια για την αντιμετώπιση της πολυσυστηματικής αορτικής νόσου. Με την αυξανόμενη εμπειρία όλο και βελτιώνονται τα αποτελέσματά μας και αυτό που θέλω να τονίσω, το εξαιρετικό remodeling της αορτής, ιδίως στα οξέα αορτικά σύνδρομα, που μας υπαγορεύει την πιο ευρεία εφαρμογή της. Ευχαριστώ πολύ.
The next talk will be by Dr. Tsagakis, and he will talk to us about extending aortic repair in acute type 1 dissection, strategies to deal with malperfusion. Dr. Tsagakis.
Dear Chairman, dear colleagues, at first I would like to thank you for the kind invitation to participate this meeting to be in Athens. I will speak there about the extended aortic repair in acute type 1 aortic dissection and strategies to deal with the malperfusion, and I will focus in the distal malperfusion. The standard treatment in acute type A dissection is the replacement of the ascenic aorta with the open distal anastomosis in order to release the tamponade, to resect the proximal entry tear, and to stabilize the circulation. However, dilemmas arising from this standard technique periprocedurally with regard to how to deal with the persisting visceral or peripheral malperfusion, but also postoperatively with regard to the progress of the residual aortic dissection. The malperfusion is associated with increased mortality. We have the double mortality in patients with malperfusion compared to patients without. And we know that the major killer within the malperfusion sites is the visceral malperfusion. About the residual dissection, we have complications in the future. The aneurysm is growing through the follow-up, and this can result to occlusion of arteries, like in this case on the left, with occlusion of the left common carotid artery and progression of the aneurysm dilatation in the proximal descending aorta. In addition, we can have a collapse of the true lumen downstream, like the case on the right, with a remained collapse after proximal aortic repair and residual malperfusion peripheral. From the study from 2012 from Dr. Evangelista from Spain, he demonstrated that the residual entry tear in the proximal descending aorta or in the distal arch is associated with increased mortality and reoperations rate, with increased adverse outcome during the follow-up. And especially these cases can be treated very well with a frozen elephant trunk. In a previous study from us, we found that about 73% of the entry tears are located in the re-entry tears, are located in the proximal part of the descending aorta within 5 centimeters distal of the left subclavian artery. And all of these tears can be covered and excluded with a Vita open device with a length of 130 millimeters. And thereby, sorry, I don't know. So now it starts. This exclusion of the entry tears results to thrombosis of the false lumen and also remodeling during the follow-up. This remodeling occurs mostly within the first 2 years after the surgery and may result to a complete obliteration of the false lumen, at least in the thoracic aorta. And this remodeling in acute type 1 aortic dissection as positive or stable remodeling is observed in our population, in our institution, up to 90% at the level of the stent graft, up to 65% distal of the stent graft up to the celiac trunk level, and in 58% more distally. However, frozen elephant trunk is a major surgery, and the question if is an extended arch repair increase the risk for death in acute aortic dissection, type A dissection. These are results from IRAD published last year. In this study, the colleagues compared patients with proximal aortic repair, limited operation versus extended arch replacement. This not refers absolutely to frozen elephant trunk, but more to extended arch surgery. And in this population, the mortality rate was similar in both groups. And also the long-term survival was similar in both groups. And more especially in the multivariable logistic regression analysis, the complete arch repair was not a risk factor for mortality. Therefore, in order to facilitate the frozen elephant trunk and to make perform the surgery faster and easier, we initiated in the year 2009 the Zone 2 concept, which combines deep branching of the left subclavian artery with the frozen elephant trunk. 4 techniques can be used. Our favorite is the use of an aortic axillary bypass with an 8 mm graft. The advantage of this technique is that the distal anastomosis comes closer to the surgeon and can be performed faster, and also we can perfuse the left subclavian artery through the graft, thereby increasing or probably improving the head protection as well as the spinal cord protection during the surgery. And we have no risk for laryngeal nerve injury by operating the aortic arch. And using this technique, we could reduce significantly the operative times, including the cardiopulmonary bypass time, the cardiac arrest time, the selective antegrade cerebral perfusion time, and the visceral ischemic time. And we can operate nowadays with a visceral ischemic time with a median of 31 minutes and a cardiac arrest time of 126 minutes, which is not far away for some extended arch repair technique without frozen elephant trunk. In addition, with using the frozen elephant trunk, we can address the problem of true lumen collapse in the abdominal aorta. This is a patient, 70 years old, male with Marfan. Patient came to us with abdominal pain and vomiting. This is the first CT. You can see a complete collapse of the true lumen along the entire aorta. So we performed immediately frozen elephant trunk surgery, and this is the result thereafter with decompression of the true lumen and in the thoracic part as well as in the abdominal part. However, in non-Marfan patients with severe visceral malperfusion, the complementary endovascular procedures can be added to the can be performed also. And for this we use uncovered stents in order to stabilize the true lumen in the abdominal part, and this can be performed prior to surgery or immediately thereafter. Therefore, all of these patients are treated in the hybrid operating OR. The patients are admitted directly to the operating room, and after preparation from the anesthesiologist, in patients with aortic rupture or CPR, we proceed immediately to surgery. In patients with tamponade, we release the tamponade first, thereafter the patient is stabilized mostly, and thereafter we add an invasive diagnostic, this is an angiography, in order to evaluate the extent of dissection and the malperfusion. If we have a severe malperfusion, then we perform endovascular repair, and then we go to surgery. In stable patients, we perform invasive diagnostics first, malperfusion treatment if necessary first, and then after the aortic surgery. And of course, postoperatively, we have the option in the hybrid OR table to perform an additional angiography and additional endovascular procedures if it is required. For the implantation of the uncovered stents, as the implantation can be performed easily, in the most cases retrogradally, no landing zones are required. The stent can be placed over the orifices of the distal arteries. The stent, in some cases, if this retrograde approach is not possible, antegrade implantation can be also performed by guidance of the angioscope, like in this case, in which we had to stabilize the true lumen in the abdominal and thoracoabdominal level of the aorta. And you see here the visceral arteries after stenting. Our experience with acute type A dissection since 2005 includes 359 cases. Of them, 28 patients had isolated dissection of the proximal aorta up to the level of the left subclavian artery. We call these cases as modified type 2 dissections. And a classic type 1 dissection was present in 72%, and of them, a vita and frozen elephant trunk with a vita open underwent 64% of the patients. Comparing now the patients with no FET and FET in acute type 1 dissection, we had patients who underwent FET were younger significantly, but according to the PEN classification representing the status of the patients according to malperfusion size and circulatory situation, we didn't have a statistical difference. However, of course, we perform a selection in order to perform a frozen elephant trunk. The complete arch repair, of course, it was performed in frozen elephant trunk procedure significantly compared to no FET patients with 18%, but with regard to the distal to the proximal surgery in the root and the heart, we didn't have any statistical difference with regard to the procedures. The mortality rate was significantly less in the frozen elephant trunk procedures with 12%. The overall mortality was 16%. Of course, I said before, we have a selection in this patient cohort. The new stroke rates as permanent stroke was 6%. The spinal cord ischemia was 1%. We had 1% in no FET patients and 1% in FET patients. And the temporary hemodialysis, renal replacement therapy was necessary in 37%, similar in both groups. And the incidence of red thoracotomy for bleeding was also similar in both groups with 10%. Now, with regard to the downstream aorta, we had a false lumen thrombosis of 91% in the frozen elephant trunk group and 13% in no FET group. And this resulted to a significant difference or to a significant improvement of freedom of intervention downstream, with 90% freedom from interventions in the frozen elephant trunk group and 66% in no FET group after 5 years. The survival was also improved in the FET group after 5 years with 66% versus 56%. And within now the patients with a hybrid OR concept, that means treatment according to the malperfusion situation, patients who underwent surgery in the hybrid OR was 270, in no hybrid OR 89 during this period. The 30-day mortality was significantly decreased in the hybrid OR group. The patients with visceral malperfusion, also in this case, we had a mortality rate of 16% versus 50%. And also in patient classification B and BC patients with malperfusion and circulatory problems, the results were better by operating the patient in the hybrid OR room. Also, the survival was between malperfusion patients and no malperfusion patients was statistically similar in both groups. After using the uncovered stenting in the abdominal aorta, we performed this treatment in 19 only patients. We use this treatment really very rarely. This is a bailout situation actually. However, we had a mortality, 30-day mortality only of 11% in this very high-risk group, and the survival after 4 years was 66%. In summary, the frozen elephant trunk can be performed safely in acute type 1 aortic dissection. The frozen elephant trunk enables durable true lumen stabilization and false lumen exclusion downstream, and provides an ideal docking zone for TIVA and open thoracoabdominal repair if it is required. In addition, the intraoperative angiography in hybrid operating room settings enables first an on-time evaluation of a malperfusion and also gives the option for endovascular procedures in order to restore the perfusion and especially the visceral perfusion. And this concept is also included in the guidelines from European Society of Cardiology. Thank you for your attention.
I guess we'll proceed with the next talk, and we're going to leave the questions for later. And the next speaker will be Dr. Bertoglio, partial and total supraortic vessel rerouting for endovascular arch repair. Dr. Bertolio.
Thank you again for the kind invitation. These are my disclosure. hybrid repair has been out for a while. Nowadays there are different series presenting results regarding this technique with acceptable mortality and stroke rate. This is our experience in Raffaele Hospital. Since the very beginning, we treated more than 242 cases according to the different zone of landing. And I will focus on the zone 0 and zone 1 because they truly believe that they are arch repair rather than zone 2 that refers to descending thoracic pathology. Regarding the zone 0, we do a tangential clamping without church, a wide graft in the ascending aorta. We wrap the ascending aorta if needed, and usually during the deployment of the TVAR, we perform a rapid pacing. And this is a short video. You can see the ascending side clamping, the small incision in the ascending. Usually we use a 12 millimeter tube in the ascending aorta. And we decide the side branch for the carotid artery according to the diameter of the vessels. Here you can see the innominate artery clamping, the resection of the innominate artery, and the hand-to-hand anastomosis to the innominate artery. And the same concept applied to the left common carotid, ligature on the origin, and then debranching of the left common carotid artery. Usually we wrap the ascending aorta if it is enlarged, and we will discuss it later. Of course, those cases are patients that are high risk for open surgery, so they come out with some kind of ascending disease. And usually here you can see the deployment of the stent graft, which is performed in the same session, so in an hybrid OR nowadays, under rapid pacing. Here you can see the deployment. There is a marker on the debranching graft so that it is easy to locate the graft and land as close as possible to the debranching. And here you can see final results. For the zone 1, so the zone that requires the coverage of the left common carotid artery and the left carotid subclavian, usually we perform a carotid to carotid and left subclavian bypass, and we plug the origin of the left subclavian artery. And these are our results nowadays. As you can see, the mortality is 5.9%. We had 5% of type 1 endolic, mainly in zone 1 due to the shortness of the landing zone, and a stroke rate of 3.4%. No spinal cord ischemia, and as you can see, low incidence of respiratory failure and cardiac problems. Of course, the stroke prevention is the topic in this area. We do plug the left subclavian artery before deploying the stent graft in order to avoid any kind of trash embolism during the delivery of the stent graft. And as you can see, usually the stroke are mostly fatal. 3 out of the 4 cases died to the consequence of the stroke, and 1 case died due to immediate retrograde dissections. Regarding the midterm results, as you can see, in zone 0, the results are pretty good, with only 1 case of type 1 endolic, and 1 and 2 cases of secondary procedure, both open and endovascular. If we look on the zone 1, we had new endolics, but also late rupture, because usually the zone 1 is very, very short, and so we have migration and late rupture related to new onset endolics. And here you can see the later intervention causes. As you can see, the endoleak was the main cause, a retrograde dissection again, and an anastomotic pseudoaneurysm on the late. This is the case of the retrograde dissection. That the onset was 3 months after the index procedure, and you can see was treated with a sort of standard elephant trunk and reimplantation of the surgical graft to the ascending graft. And here you can see the final result on the CT scan. Here you can see after 13 years after the hybrid surgery performed in another center, this is a huge pseudoaneurysm in the anastomotic anastomosis on the ascending aorta. And here you can see the intraoperative view, the stent graft, the bifurcated graft floating in the pseudoaneurysm, and the re-performed ascending repair and the branching from the new tube. And this is again the final result. And this is the migration. As you can see, this patient had a zone 1 landing. You can see the carotid to carotid subclavian bypass. And you can see, due to the shortening of the landing load, the stent graft completely migrate, and we had to convert this patient in a zone 0 and reline the stent graft. What are the topic of discussion in this field? Well, why should we need still an hybrid repair when we have available a total endo repair nowadays, at least in our center? If we look on the numbers, you see that in the last 3 years, we did only 6 cases by means of total endovascular repair, comparing with the total experience of the hybrid repair. So meaning that there is a gap between the feasibility and the real world in terms of application of this new technology. We have different total endovascular options to treat the arch, so avoiding the sternotomy, parallel graft, fenestrated and branch graft. And here you can see that in our center, a few are feasible by means of a total endovascular approach. This is an emergent case we treated for arch rupture with a parallel graft technique in zone 0, and you can see what happened. Usually you can have some kind of endoleaks. Fortunately, the patient survived and the endoleak solved after. But we should remind that 10% of the patients with hybrid parallel graft repair have type 1 endoleaks. Regarding the arch, total arch repair, you can treat those patients. Here you can see one of our case. And this is truly appealing in cases in which the patient has a previous ascending repair with, for example, reimplantation of the coronary artery on the tube, and you can treat nicely those cases, avoiding the sternotomy. But the problem at the moment, and this is the final result, the problem is at the moment there is a waiting time of 12 weeks. It is only available in few centers. It is anatomical feasible in few cases and is not feasible in patients with short graft and valve insufficiency. And still nowadays, the results are not there in terms of comparison with the hybrid repair if we look on the mortality and the stroke rate. So coming to conclusion, in our experience, hybrid surgery has good short and long-term results in high surgical candidates. We'll still do a lot of open surgery for arch repair. Just to give you numbers, the last year we did 34 fat repair, 3 hybrid, and 2 total endos. So meaning that this is a selected cohort of patients. The advantage of the hybrid surgery is that it allows to use off-label, commercially available stent graft to repair cases that are unfit for open surgery. And I think that we need still a comparison with the current endovascular repair in those patients. And this conclusion has been wrapped up in this publication that is available nowadays in the website. It is a consensus paper in which we work, and I had the pleasure to be involved. And as you can see, the indication for hybrid surgery in zone 0 should be only considered in patients unfit for open repair and with a suitable anatomy. Regarding the TIVAR in zone 1 and zone 2 with a hybrid repair should be considered if the patient is suitable anatomy, meaning that if a patient comes with a nice landing zone in zone 1, there is room to discuss to treat those cases by means of an endovascular approach. and we consider a case suitable if the landing zone is at least 25 millimeter in length and a diameter which is below 38 millimeter. Thank you again for your attention.
Next presentation is total endovascular treatment of aortic arch and thoracoabdominal aortic aneurysms by Mr. Bisdas from Germany.
Hi, everybody. Thank you very much for the very kind invitation. Appreciate it a lot. And I'm really happy by returning now back in Greece after 15 years in Germany and the US to speak now here about this issue. Here are my conflicts of interest. What I would like to tell you today and to answer is what is really feasible in the total endovascular era. And we are going to speak about thoracoabdominal aortic aneurysms, where we have fenestrated branch endografts and the so-called sandwich technique. And of course, regarding the aortic arch, where we have branch endograft chimney sandwich technique as well. Let's start with the thoracoabdos. Here you have different options. Let's go through the different indications. Starting with the branch endografting, actually the branch endografts are really applicable to the vast majority of the thoracoabdominal aortic aneurysms. We have there de novo thoracoabdos, type 1A endoleak after EVAR. We have type 1B endoleak after TEVAR at the distal part of the descending aorta. We have paraanastomotic aneurysms after open surgical repair, and of course the urgent setting of symptomatic or rupture aneurysms. Until a few years ago, we had different customized devices. Here you see such a customized device that it is implanted now to the patient. I don't know if I can show it. Here you are. So you see here the markers. This is the anterior markers showing that you are at 12 o'clock, and then start the different branches of the device. Can we start the second video, please? And then you see here, after the anterior markers, that's showing you that you are working on 12 o'clock. So if you are implanting a branch endograft, you are imagining the aorta as a clock, and you are starting looking where is the clock position of its target vessel. So here is, let's go please to the second video. Here you are. So here you see now it's opening the branch of the celiac trunk. You see 3 markers. This is the entrance of the branch. 2 markers. This is the exit of the branch. Here is the marker for the SMA. And then you have 2 branches. This is the branch for the renal artery. 3 markers is the entrance. 2 markers is the exit. Again, you see 3 markers. This is the anterior markers that they reminding you that you are at 12 o'clock because the SMA is almost always at 12 o'clock. And then you have here, it's difficult to see, a so-called J-tip. The J-tip, if you see it like a J, you're sure that all the branches are in the anterior part of the aorta. Actually, it is really simple to understand the markers. Then after putting the main body, you're closing the groins, you're giving back perfusion to the hypogastric arteries, and then you go through a small cut down through the transaxillary approach, and you're bringing the bridging stent graft through the branch of the SMA into the target vessels. We are using balloon expanding stent grafts, and at the end you have a very nice perfusion. After then connecting all 4 branches, you have the aneurysm excluded. This is the way how it works. Now, until a few years ago, we have only custom-made devices, but the problem is that you have a waiting time. We had some ruptures in the meantime. So there was a lot of work and projects trying to develop an off-the-shelf device. Nowadays, the off-the-shelf device is there, and this is the so-called T-branch device. It has a proximal diameter, always the same, 34 millimeter. It is tapered to 80 millimeter. The total length is 202 millimeter, and you have always the same orientation for your branches. The company provides you this planning where you can see that you have a very simple planning schedule here. You have the longitudinal axis. This is the distance along the aorta. You have this box. At that level is the clock position of your branches, and here you have again the distance between the branches. You're putting always at that level the SMA, and the SMA is your reference vessel to decide the distance distance of the celiac trunk to the SMA, and of course the clock position. So if, for example, I have the celiac trunk 20 millimeter above the SMA, I'm going 2 boxes above, and I put my brands here at 1 o'clock. And then you're using this mask. If the target vessel is in the 90 degrees area of the respective brands, and this is the case for all 4 brands, then you know that it is the T brands is applicable for your thoracoabdominal aneurysm. And we have already checked in the previous publications all thoracoabdos that we have performed with custom-made devices, which is the T brands in those cases, and we have seen that we had an applicability, primary applicability of 63%. That means it is really an off-the-shelf device. And here is the case of an urgent thoracoabdominal rupture, and you see here very nicely we have excluded this aneurysm in an urgent setting. The question is, when should we use custom-made devices? When should we use off-the-shelf devices? We have already performed the first comparison between custom-made and off-the-shelf devices for thoracoabdos, and the same work was done also 2 years later from the San Francisco group, and both groups have not seen any safety issues, no differences regarding adverse events, and shorter wait times for the off-the-shelf device. And if you see the line here with the black line, you see the off-the-shelf devices, we have now an increasing use. Actually, in our department, we are almost using only off-the-shelf devices. There is, however, a space for the custom-made devices. This is a very difficult case. A patient that was treated about 10 years ago with a Ballard technique for a thoracoabdominal aortic aneurysm. For the people that don't know what is a Ballard technique, it is actually a technique that using a Y prosthesis for the SMA and left renal artery, and then you're putting the celiac trunk and the right renal artery as an island to a second prosthesis. This was a very difficult, let's say, situation because you can see on the drawing, we have here the aneurysmatic degeneration. It was very difficult also to treat it openly. The cardiac surgeons denied, and in that cases, we decided to manufacture a really difficult device with an helical branch, and this is how it looks, the device at the end. Here's the helical branch, and this is the nice result that we achieved with it in a total endovascular era. Now, let's go from the branch endografts to the fenestrated endografts. The fenestrated endografts in the thoracoabdominal era, they have only one indication, in my opinion, and this is the post-dissection aneurysms. And why is this? Because the problem with the post-dissection aneurysms is the true lumen. It is very narrow. You see here the false lumen, and the only case to bring something inside, you have to use a very tapered devices with 4 fenestrations, and then at the end you can achieve a really nice result. Which is, however, the biggest challenge in those cases. The biggest challenge is to go from the true lumen to the false lumen, because you have a really rigid membrane due to the chronic dissection, and in case that you have a target vessel coming from or arising from the false lumen, you have to connect it to the true lumen. And this step is sometimes really difficult, but we have in a total endovascular era very good tools for this, and the tool is the Outback catheter. Is the catheter that we are using in the SFA recanalization to go from the true lumen from the false lumen to the true lumen, and this is the way that we are using it. You are going through the fenestration. This device has a needle. You are penetrating the membrane, and then you are opening the membrane, and you are performing the connection with the bridging stent graft. So by this way, in a total endovascular era, you can still also treat these challenging aneurysms. Another technique is the sandwich technique. The sandwich technique uses parallel grafts. In these cases, you can, it is an off-the-shelf device. The problem is the gutters, that mean the spaces between the parallel grafts. We have checked the natural history of those gutters in patients with sandwich technique, and you can see a nice case of a contained rupture. In that case, we use the parallel grafts. You see, after 2 months, we have a completely thrombosis of the aneurysm, and after 1 year, we have even aneurysm shrinkage and the close of the thrombosis of the gutters. Now, going to the aortic arch aneurysms, again here you have branch endografts, you have the chimney and sandwich technique. We don't like fenestrated endografts on that level. The studies have shown really poor results and high stroke rates. This is the endograft that we are using. You see that you have here inner branches at the level of the proximal part of the branch. And this is a case, 67-year-old male with severe comorbidities, 8 centimeter aortic arch aneurysm, and you can see that that the diameter of the aorta is about 40 millimeter, and we decided to use a 46 millimeter. The oversizing is the most important part, the most important thing in this case. Here are the branches. This is the branch for the left common carotid artery, the branch for the subclavian artery. You can appreciate here some markers. You have to learn all of these technical issues in order to have a good outcome. And we are doing first the left carotid subclavian bypass, and 6 weeks later the custom-made device. Here is the left carotid subclavian bypass. You are introducing the device. The device has been manufactured by this way that the branch is always on the upper curvature of the aortic arch. You are introducing first from the brachiocephalic trunk. You are getting into the branch. This is the branch for the subclavian, for the brachiocephalic trunk. You are introducing a custom-made device, and then you are introducing from the left common carotid artery a second device, and then you are closing the subclavian artery in order to avoid any endoleak. The final result is really very nice in this case. So the branch endographs, as Dr. Bertolio said, it is a very nice treatment strategy, in elective aneurysmatic degeneration for unfit patients, and of course you have to have the suitable anatomy. An alternative is the chimney sandwich technique. You are putting parallel grafts inside. I like always to use a periscope. That means for the subclavian artery, I'm putting a periscope down to the descending aorta in order to have always an antegrade approach to treat an thoracoabdominal aortic aneurysm. And in that case, you are putting then a second thoracic endograft, and this is the so-called sandwich technique. This is a case that I had to treat in night for the cardiac surgeon. This was a patient with COPD gold fear. They didn't want to open this thorax, and what we have done is that we have put 2 chimneys for the brachiocephalic trunk and left common carotid artery. You see the nice result at the end without gutters, because you have to use the right devices for those cases, and this is the final result. The future direction, if I can put it in one picture regarding the total endovascular era, is this one. You have here in total valve replacement, the endovascular repair of the coronaries, and a branch graft that it is actually has branches to all 3 vessels. This is what is coming next and what will be the future. Very quickly, some limitations of the endovascular techniques. The first one is the bridging stent grafts. We don't have, the grafts were connecting the branches with the target vessels. We don't have dedicated bridging stent grafts. None of them is CE marked approved, so all of the devices that we're using are off the shelf. And we have seen that the renal artery is still a big problem, because we have sometimes the problem of the movement of the diaphragm that causes some occlusions. And of course, keep in mind for the people starting using these techniques that you have always the aortic remodeling. This is the aorta directly after the operation. 1 year later, the device was moved back, and by this way was pulled out the bridging stent graft from the celiac trunk. By these cases, we have then an endoleak, and we have a big problem. Small cord ischemia is not anymore the issue in the endovascular era, because we have seen that the current algorithm is very effective. We are doing stage procedure, first the thoracic, then the branch endograft. We are removing everything after implanting the main body and before delivering the bridging stent grafts in order to restore the perfusion of the hypogastric artery and of the common femoral artery. And we are very liberal with the stenting of any stenosis of the hypogastric arteries to support the collateral network. Dedicated softwares allows us the reduction of the operation time and radiation, because we know where is our target vessels. This is a 2D fusion for the different vessels, and by this way Stefan Hulon showed that they were able to reduce the spinal cord ischemia from 25% to 2%. In conclusion, the endovascular treatment of the aortic arch and TAAA is feasible and safe with high technical success rates. I still think, because I have done also cardiac surgery in Hanover, and I know exactly how it looks like, the open repair, and how safe it is, that the open surgical repair still belongs to the cardiac surgeons, but the endo approach could have a complementary role. However, in the TAAAs, the endo approach is the first-line treatment strategy. And we have some selected patients like connective tissue disease and Marfan patients that still need to be treated open. High expertise is required, dedicated aortic sentence, and we still have the limitations of the bridging stent grafts. If you want to see more videos and all these techniques, you can visit the website that we're developing in Germany called Vascupedia. There you can find all of these presentations that I have, all of this information that I have already presented. Thank you very much for your attention.
Next, Professor Nienaber, please.
Yeah, good morning, everybody, and thank you again, Soterios, for the kind invitation to come to this fantastic meeting and be the only cardiologist, I guess, among cardiac and vascular surgeons here, but I enjoy it. My talk today is about another concept of treating patients with dissection. You know that classically we're dealing with a true lumen, but in this particular presentation I'm showing you that sometimes a true lumen is not enough and you have to address the other side of the dissection and work on the false lumen. This graph, I try to show that in my presentation, shows you what's going to happen in the next couple of years. This is statistics from Japan, and they show us that the conditions such as aortic dissection in red is going to increase at the expense of coronary artery disease, also valvular disease is on the increase. We have to deal with these issues in the future much more than we think. Again, statistics from Sweden show that the need for operations and interventions to dissection and aneurysm is going to increase in the near future. And this slide is just to show you that the era of endovascular stenting of dissection started some 20 years ago. And I was very happy to find my collaborator at the time, Nikos, here today in the audience, who helped me on this first case in Hamburg 20 years ago to show that this is feasible and can be done without open surgery, and started an era of endovascular treatment of aortic dissection, which is basically based on two principles. One is to redirect flow to the true lumen and reperfuse the distal malperfused areas of the body. And second, a little bit later, to induce remodeling and healing of the aorta, despite the fact that the stent is only placed proximally. The abdominal aorta can also benefit from it and remodel over time. Those are the two principles of stenting of dissection. In the meantime, various authors have shown that this is good. It improves the patient's prognosis long term. Even in so-called uncomplicated type B dissection, there's plenty of data from various registries and studies to support that endovascular treatment is the way to go. And the guidelines have picked it up, both for complicated and uncomplicated. We have a 1 or type or 2A indication. So the endovascular approach to these conditions are backed up by guidelines. So don't be afraid to even treat complicated or uncomplicated chronic or acute type B dissection if you have the proper background, the proper aortic center, and the proper skills at hand. Finally, to close my first part of my presentation, both surgery or endovascular treatment is better than medical management alone. This is a composite summary of publications, a meta-analysis, everything supported and published in this area, and shows that medical management alone is probably not the best way to treat our patients both in A and B conditions. Here's now, just to finish up on how we treat these patients, a case from last week, a patient with type B dissection. He had a revas procedure in the left neck, when we placed an LSA occluder in the proximal part of the LSA in order to prevent backflow into the false lumen. Then a proximal stent graft is placed, as you can see here, finished up with a petticoat or distal open extension. And on the way back out, the re-entry tear in the iliac artery was also taken care of by a small patched stent in order to isolate the false lumen completely from pressure and from flow. This is the standard of treatment of type B dissection as we do it these days in my institution. So on the way out, we actually take care of the re-entry tear as well. This shows you the concept of petticoat. You can stent even across side branches of the abdominal aorta without compromising flow to it. And in some cases, we actually have a calculator now that we can use in order to address a simply look in type B dissection in terms of 2-year prognosis, and this calculation is based on images and tells you that this particular person, Y2, has a 22% risk of dying from type B dissection of complications in the next 2 years. So we treat these patients according to this algorithm with the idea to completely remodel the false lumen and the true lumen and abolish the false lumen. But sometimes it doesn't work. You don't have complete obstruction of the false lumen and complete remodeling. We know that this is a bad player or a bad actor. If remodeling doesn't occur, and this is independent data from other groups, the outcome of those patients is not so good. And from IRAD, the International Registry, we have calculated an odds ratio of more than 5 that only complete false lumen thrombosis and remodeling gives a patient a stable prognosis and a good outcome after 5 years. What we see sometimes is this kind of behavior in the follow-up after previous stenting of a type B dissection. You see here that there's flow, remaining flow in the false lumen because of some pressurized re-entry tears or some other problems that do not create a completely thrombosed false lumen. And these patients have a tendency to extend the diameter and actually rupture late without any indication of it, completely asymptomatic. So it's important to look at the false lumen over time once the patient had been stented in the beginning. So is that worse to look at the other side, at the false lumen, and hopefully try and identify the problem and treat it? I think there is need for it in selected patients to subject them to the so-called FLIRT procedure. FLIRT is an acronym for false lumen intervention to promote remodeling and thrombosis. It's completely percutaneous, minimalistic, based on the use of occluders, additional stents, coils, and onyx. It promotes eventually late remodeling of the false lumen, what you really need for a good prognosis. It is amenable to communications in any kind of dissection. You can do that in A and in B dissections. And it avoids the risk, we believe, of additional BVAR or FEVAR or open surgery in the long-term follow-up of these patients. Let me guide you through a couple of cases to make it better understood. Here's my first case. Entry tear here. The patient had a typical presentation of type B dissection, complicated anatomy with a lusoria and distal malperfusion. So he also had a right arm collocation. We went in, placed the first TIVA stent and a chimney up here with a result that looked like this, however notifying a reperfused and incompletely thrombosed false lumen, which basically set the stage for a second attempt in order to address the false lumen percutaneously, coming from a re-entry side in the left leg, addressing the proximal tear or communication here by dropping coils and an occluder in order to promote thrombosis. And on the way back, we added a petticoat to this stent graft in order to better realign the aorta and finally achieve this result with a completely thrombosed false lumen in the thoracic cage. This concept has now been used in 14 patients in our hands. We have published the first 10 in a previous publication earlier this year. All of them were basically detected during follow-up, 5 cases in the ascending aorta after previous interventions to the ascending, and another 5 cases in the distal part or type B scenario after previous interventions. The follow-up so far is limited to a little bit over a year on average, and the procedural details are listed here. Success rate is quite high. We could actually induce, by use of various devices such as occluders, Amplatzer plugs, various difficult to describe coils, and onyx in combination with coils, which is a sort of a percutaneously applicable glue, we could achieve almost in all cases a complete thrombosis of the false lumen after we had identified the problem. And here's another nice case to show you. In the proximal area of the ascending aorta, this patient suffered from acute onset type A dissection. We couldn't stent this patient, and we couldn't submit him to surgery for other reasons and comorbidity reasons. He had a Euroscore of 21%. So the idea was to use this concept, occlude the entry tear, and promote thrombosis in the false lumen. For that, the CT needs to be measured and quantified, and with a completely percutaneous approach now from both the femoral arteries and from an axis from the left brachial artery, it was possible to identify the tear, drop initially some coils into that false lumen space, and top it up with an occluder in order to seal it completely from inflow from the true lumen into the previously perfused false lumen. This is follow-up. After 6 months, you see that the initial situation has completely resolved with no stent, with no surgery, but with just coils and a ASD occluder to top up the entry tear, with complete remodeling of the ascending aorta. So the patient doesn't have any kind of scar, he didn't have thoracotomy, and he's doing fine at follow-up. Here's another very complex case with lots of comorbidities. You see the abdominal aorta is completely thrombosed and occluded. He suffered from acute type A dissection in the beginning, and we were able to advance this territory and this pathology again from the left brachial artery, identifying the entry to the false lumen in a very individualized approach of a type A dissection. Oops. Same principle, identifying the tear, dropping some coils into the false lumen, and finally, because this is only a 5 millimeter hole, sealing it off with a PFO occluder. I would love to show you this image. Here, you can see the PFO occluder here sitting on top of the thrombotic coils or thrombogenic coils, and basically occluding the entry tear, occluding the flow into the false lumen. The final angiogram shows you that the tear is completely sealed, and the coronary ostium, which is just next to it, is unobstructed. Here's the left, and somewhere here's the right. So very delicate procedures, but probably not so difficult as you may think if you're used to coronary interventions. Here's the follow-up image of this particular person with the occluder sitting here, and the aorta almost, again, completely remodeling over 6 months. 6 months after the initial procedure, we see a very nice ascending aorta. If you take all those 14 cases together, we see that the true lumen volume goes up in the right direction. After 6 months, we have an almost normal appearing true lumen, and the false lumen, or total diameter of the aorta in the affected segment, is getting closer to normal from 63 to 50 millimeters diameter as a sign of ongoing remodeling. Let me just finish and conclude. I think this concept is a minimalistic approach to promote false lumen thrombosis, which you need for a good outcome of a patient, and induces remodeling over time. By use of coils, closure devices, etc., to manage the false lumen as an efficient minimalistic strategy likely to avoid problems with additional stent grafts or additional complex procedures such as fenestrated or branch devices in chronic type B dissection, and of course open surgery in those selected cases. First observations, as I've shown here, will be followed by a systematic documentation of any false lumen intervention in either the ascending or the descending thoracic aorta. So finally, this is a look into our group. There's a combination and a very nice interaction between surgeon and interventional cardiologist and imaging specialist, and every of the cases, every case that I showed you goes to this discussion, very serious discussion among various players in the field. And I think this group approach will benefit our patients in the next couple of years to come. Thank you very much for your attention.
Next presentation is open repair of thoracoabdominal aortic aneurysm endovascular area by Mr. Davidovic from Serbia. Thank you.
Ladies and gentlemen, Mr. Chairman, first of all, I would like to thank once again Professor Prapas as well as his entire collaborators for inviting me to this excellent meeting. That is a great privilege for me. It will not be so easy to talk after previous speakers, but I will do my best. The first reason for open repair of thoracoabdominal aneurysms in endovascular area could be unfavorable aneurysmal anatomy. According to this article, even 40% of thoracoabdominal aneurysms were not suitable for branched or fenestrated stent grafting. And to be more precise, that unsuitability has been caused by short distal landing zone, by severe angulation of the thoracic aorta, by an occlusion of infrarenal aorta, by stenosis of visceral arteries, as well as by severe tortuosity and small diameter of iliac arteries. This article is 7 years old. In the meantime, stent graft had further technological improvements. Nevertheless, a significant number of thoracoabdominal aneurysms are not suitable for total endovascular repair, and due to this, open repair should be considered for patients with complex, unfavorable anatomy of thoracoabdominal aneurysms. As you know, endovascular repair is not recommended in patients with connective tissue disorders, namely generalized disease of the entire aorta causes very often additional dilatation of non-treated aortic segments during the follow-up period. Therefore, endoleak type 1 and stent graft migration can occur. Due to this, majority of authors recommend TEVAR at patients with connective tissue disorders only as a bridging method to open surgery. That is especially important in emergency cases, including rupture and severe malperfusion. Finally, TEVAR is also recommended if patients with connective tissue disorders have associated significant comorbidity. But, ladies and gentlemen, I believe that open repair is method of choice for the treatment of vast majority of patients with thoracoabdominal aneurysms caused by connective tissue disorders. An improvement of operative strategy during open repair of thoracoabdominal aortic aneurysms has significantly decreased the incidences of paraplegia and mortality death outcomes in the first decade of the new century. Allow me to remind you that paraplegia rate after open repair of thoracoabdominal aneurysms in clamp and Sue era was between 16 and 25%. According to this article, early mortality and neurologic complications after open repair of thoracoabdominal aneurysms are similar, if not superior, to the endovascular ones. At the same time, endovascular repair is associated with higher rate of required reintervention during the follow-up period. Due to this, I believe that open repair should be and could be method of choice for the treatment of significant number of degenerative thoracoabdominal aneurysms at younger, good risk patients. As you know, some long-term complications after prior TEVAR require open surgical conversion as well. To be more precise, the incidence of these procedures is higher than previously thought, including very experienced endovascular centers. When we prepared this article, the incidence of open surgical conversion after prior TEVAR in my clinic, that is not very experienced endovascular center, was 6%. I believe that endoleak type 1 with aneurysm enlargement, then aneurysm enlargement without endoleak, thoracic stent graft migration and collapse, distal aneurysm formation, and finally secondary aortoesophageal and bronchi fistulas require open surgical conversion. According to these most recently published articles, the cost of branched and fenestrated stent grafts could be additional reason for open repair of thoracoabdominal aneurysms, not only in countries with limited budget for vascular surgery like Serbia. In the following slides, I will try to explain you briefly our strategy during open repair of thoracoabdominal aneurysms. You should know that Serbia is a small country with many limitations. The procedure begins with cerebrospinal fluid drainage that is established just before surgery and continues in the following 72 hours. Of course, diaphragm preservation, one lung ventilation, distal aortic retrograde perfusion with mild hypothermia, as well as segmental sequential aortic cross clamping are obvious. Unfortunately, we are still unable to check motor evoked potential. Due to this, distal aortic pressure is the main factor to estimate whether the distal aortic perfusion is efficient. And according to the common opinion, distal aortic pressure during open repair of thoracoabdominal aneurysms should be between 60 and 70 millimeters of mercury. But we have found that hypertensive persons with disturbed self-regulating mechanisms should have distal aortic pressure higher than 70 millimeters of mercury, and we use this formula to calculate distal aortic pressure for each of our patients individually prior to surgery. We perform routinely the attachment of all suitable intercostal arteries between TH9 and TH12 levels in patients with very sick aorta, Marfan patients, as well as in cases of post-dissecting aneurysms. We perform reattachment of intercostal arteries using Eleftheriadis or VU methods, instead standard Carrel's patch technique. But the best and the quickest option is to employ Carrel's patch to replant celiac trunk, SMA, and right renal artery together. During that procedure, selective retrograde perfusion of visceral organs is obvious and extremely very important. In patients with very sick aorta, Marfan patients, as well as in cases of post-dissecting aneurysms, we perform revascularization of visceral organs using multiple arm site technique. Left renal arteries is usually separately replanted. That reduces significantly the emission of the Carrel's patch and decreases the risk of a late visceral patch aneurysm development. After the establishment of anterograde flow through visceral arteries, retrograde distal perfusion is still working to make sufficient flow through hypogastric arteries. That prevents also the spinal cord ischemia occurrence. Namely, according to Jakob's data, even temporary exclusion of the both hypogastric arteries during open repair of thoracoabdominal aneurysms causes spinal cord ischemia in 8 to 12% of cases. Why? And iliolumbar and lateral sacral arteries that are branches of hypogastric artery supply also the distal part of the spinal cord. However, even when it is inadequate, prolonged retrograde perfusion of hypogastric arteries increases risk of the spinal cord ischemia occurrence. Due to this, some authors insist that the distal aortic anastomosis should be finished immediately after intercostal reattachment. That allows earlier reestablishment of anterograde flow through hypogastric artery than usually, as well as it allows better anterograde perfusion of the distal part of the spinal cord. Anyway, whenever it's possible, it is better to perform distal anastomosis, distal aortic anastomosis on aortic bifurcation due to possible difficult approach to the right iliac artery using left lumbotomy approach. My clinic performs routinely open repair of thoracoabdominal aneurysms since 2000, and until now we had more than 300 cases. Last year, mortality and paraplegia rate at elective procedures in my clinic were 3.5%. This year, unfortunately, our results are not so good. Our results are included in this meta-analysis, and of course, we are very proud because of that. Because of several reasons, I believe that open surgical conversion after TIVAR is even more risky and complex procedure than primary open repair of thoracoabdominal aneurysms. Due to this, I believe that open repair of thoracoabdominal aneurysms should not be forgotten in endovascular era. Main indications for that procedure includes patients with complex anatomy, patients with connective tissue disorders, younger good risk patients with degenerative aneurysms, patients with some of complications after prior TIVAR. Open repair of thoracoabdominal aneurysms should be performed in high volume centers, you should agree, while young generations of vascular surgeons should be educated in complex aortic surgery. Allow me to invite all of you to the next ESCVS Congress that will be held in Groningen in 2019, and thank you so much for your attention.
And we finish this session by the last speaker, who is Dr. Carrel, who's going to talk to us about thoracic and thoracoabdominal reoperations. Dr. Carrel.
Mr. Chairman, thank you very much for the invitation. I think the previous talk have shown quite extensively what is possible today in the field of the thoracic aorta. And in the era of increasing numbers of interventional procedure, it might be anachronistic to speak about surgical redos, but nevertheless, I think it might be helpful to have a very brief summary of some challenges that we are faced with when patients have already underwent one operation. It's not functioning. So we have potential reason for reoperation, what I would call inappropriate or perhaps incomplete initial surgery. And then we have in the mid to long-term follow-up of this patient some complication that might be expected and other one we may be unexpected. So what means inappropriate initial surgery? It might be that we have ongoing proximal or distal disease because the first procedure was too limited. We have seen some patient who received an aortic valve replacement in a slightly dilated ascending aorta of 4.5 centimeters, when it would have been better to replace the root or to repair the valve with root replacement in the first treatment. We have some patients, of course, with moderate aortic pathologies who are treated for coronary artery disease and valvular disease, and some of these patients may also require a little bit more aggressive indication regarding the treatment of a thoracic aortic pathology. And then we may have, of course, a progressive disease which is not due to any problem with the initial surgery. Then we have expected long-term follow-up and complications. Some patients may come back because they have a planned reoperation. Some of them have undergone successful treatment of acute type A aortic dissection, and they need some treatment in the long-term follow-up on the downstream aorta. We have patients with failed prosthetic material, tissue valve, homograft, failure of aortic valve repair operation, and we have also some patients with dilation of the pulmonary autograft in the neo-aortic position. And then we have unexpected situation, which means that we may have pseudoaneurysm at suture line, we may have new event of aortic dissection, and of course the chapter of infection, either on tissue valve and mechanical valve, or also graft and endograft infection might be very challenging. We have started 20 years ago with about 80 cases a year of aortic surgery, primary operation, and you see the number is increasing. We have now approximately every 6th patient in our institution has some kind of procedure, either surgically or endovascular procedure on the thoracic aorta. And probably the number will still be increasing since there is an increasing awareness of these patients, and also the follow-up of these patients has been much more conclusive in the last years. So I just want to review with you some brief cases with what I would call perhaps inappropriate initial surgery. This was a patient operated in an institution, most probably with less experience in the thoracic aorta. The patient was a Marfan patient. He underwent isolated valve replacement and a very short supracoronary graft. And you see the results about 8 years after the operation with 2 aneurysms, one in the aortic root and the other one in the aortic arch. This is another case where a patient received a very, very short ascending graft interposition when having already a slightly dilated proximal arch. And this patient came back, of course, with this huge arch aneurysm a few years following supracoronary graft replacement, and needed some treatment which have been which might have been possible at the initial operation. This is the results after the operation. Now, expected follow-up. We have some patients where tissue graft degeneration may require another aortic root operation. This is, for instance, one of these former shell-high prostheses implanted in rather young people, sometimes to avoid just anticoagulation. This young boy had a bicuspid valve with a very dilated aortic root, and he underwent several operations in the follow-up, ending with a complication that I will just present later on. Some patients may have also expected reoperation. This is a case of a patient with what I would call a mega aorta syndrome. It's an historical picture. At the time, there were no fat available, and we did the classical operation. The first part was usually putting an ascending graft and classical elephant trunk procedure, and the picture on the right showed the problem at the more downstream aorta. This time it was necessary to prolong the classical elephant trunk with graft prosthesis, which was the classical operation before endovascular possibilities were available. This is a very interesting case. On the left, a very young boy who underwent a David-type procedure on the aortic root, and the left picture is 7 years after the operation. Looking very fine. He came for a follow-up examination. We were very happy, and 2 weeks later, he developed type B dissection. You see the problem. In the middle, you see this dissection, and just 4 weeks after the initial type B dissection, the patient has rapid growing of the thoracoabdominal aorta up to 5.7 centimeters. He was about 24 years of age, and he was operated on a classical way because we were not very happy to put too much endovascular material in a patient, in a young patient with Marfan syndrome. Unexpected complication. You see here something which was detected by chance, actually, in a very first control after type A aortic dissection repair, a very small aneurysm of the close to the left coronary artery. It was not very clear, is it the button or is it something different? The challenge here was mainly that it was early postoperatively, and we were expecting rather dense adhesion. You see here the echo with the small aneurysm here, very close to the left coronary ostium. We repaired this just by opening the graft, and we saw that one of the continuous suturing was not under tension. With just one additional suture, it was possible to fix this problem. And at the end, we saw that the aneurysm was not perfused anymore here, and the cavity was even perioperatively already smaller than before begin of the operation. And this is the CT scan after the operation. Here, another very tricky case is a patient that underwent several aortic root operation. The last one was done by our friend Hugh Cameron in the States. The patient went to Europe back with his parents and presented with this really big aneurysm of the left main stem. He was operated 3 times before, and it was not very clear, is this just a problem of a weakening of the tissue, or is this an infection, a low-grade infection? And we found this problem here just behind the main trunk of the pulmonary artery. There was some discussion and attempts to treat the patient endovascularly, to close the aneurysm, putting some plugs there by the cardiologist, but at the end it was technically impossible, and we reoperated the patient and had to replace the root for the 3rd time, and we needed some very short saphenous vein graft interposition in a type of modified Cabral technique, if you want, just because it was not possible, of course, to bring the bifurcation of the left main stem directly to the aortic root prosthesis. Some other challenges might be the entry. This is a patient who was sent from the Emirates by Jean Bachet. You see the patient had also several previous operation and was bleeding always a little bit from the sternotomy. And at the end, we suspected that there was some aneurysm behind the sternum perforating across the sternum. And the main problem was just an infected Teflon felt at the site of the cannulation, which had been done, of course, several times. This patient might be challenging, but from the entry, it was cannulated on the peripheral way, and we cooled down the patient before, of course, opening the chest. Everything was completely floating in pus, so we reconstructed all this region with our technique of pericardial tube graft for the ascending aorta, for both first the supraortic branches, and we put a separate small biograft for the left subclavian artery, following a technique that Martin Czerny described some years ago in our institution. So if I look over the 20 last year, as I said, we started with 80 cases. We have now around 290 cases, and you see we have about 20% of the volume, of the overall volume, are reoperation, and we have an institutional incidence of 5%. So we get quite a lot of patients from other institutions. But you see, we have still what we call 90 patients with planned reoperation, where something was not done at the first step, for instance. Our CTU has tried to make some statistical analysis, even though I must say the dendrite database is not complete from the very beginning of this 20-year period. But we may at least see some factors which may be a little bit predictive for late redo, like prior dissection, the Marfan syndromes, and the location of the tear when we have an ascending aortic dissection with perhaps the tear in the arch or in the ascending. This is perhaps historical. I'm pretty sure that when the more aggressive treatment of the dissection with FET and other interventional possibilities will low down this incidence. Looking at the early mortality for redo operation, of course the mortality is higher than after previous initial operation. We have some factor like coronary artery disease, the uncontrollable infection, and patient with prior neurological symptoms before the reoperation. They are at higher risk for mortality during the second or third operation. And this is my last slide. I can only encourage all centers, of course, to structure the follow-up better than this has been done in the last years, because we have now excellent possibilities on the imaging side to really detect late complication before they need emergency surgery. There are a lot of additional questions to be solved sometimes, to investigate relatives, to adapt postoperative medication, and so on. And I think this is the way how to keep this patient coming back before they need some emergency surgery. Thank you very much.
I'm pretty sure there are some very hot questions from the audience, but I will take the privilege to start first. Dr. Tsagakis, I want to ask you about your approach to the big killer in acute aortic dissection, that is the GI malperfusion. Personally, I have never seen anybody survive a proximal procedure with an ongoing GI malperfusion. So when I was trained, there was a protocol to fix the malperfusion syndrome. That's the way Dr. Deeb called it. First, and then on a second stage, after the patient stabilizes and the extreme acidosis goes away, to go on and do the proximal part. The problem with that is that there were a lot of deaths in the interim from rupture. Do you have any kind of investigative tool to realize or conceptualize what kind of malperfusion you have, static or dynamic or both. Because if you have a static malperfusion, you have a big problem.
Yes.
And then proceed either with a proximal procedure first or fix the malperfusion and proceed with the procedure later on.
Thank you for this question. It's really the big point. Yes, we have the tool, and this is the angiography. And so the cardiologists in this field, at least in our institution, they have a great experience, and we also with them to evaluate the malperfusion by the angiography. You can very well identify if you have a dynamic or a static malperfusion. And in case that we have a static malperfusion, situation is more easy to decide. I come to this later. For the static malperfusion, we perform immediately the intervention. We want to reopen the vessel. For the decision making, to say I perform first proximal repair and I would see what happens thereafter, this is really difficult. The only can I say what we use from our experience is this: we included a 6 hours cutoff in order to decide if the patients come to us with a dynamic malperfusion, not a static one, a dynamic malperfusion. Within the first 6 hours after onset of symptoms, okay, it could be also 6.5, but not very longer, then we perform surgery first proximally. And if the patient comes later with a delay of 8 hours, 9 hours, 10 hours, then we stabilize the true lumen in the abdominal part first. Now, if the patient comes with a static malperfusion, immediately endovascular repair, and then we go to proximal repair. Now, if we have a situation that the patient is not critical circulatory, has not a critical circulatory problem, that means has not tamponade and has an aortic valve regurgitation, but is not severe. So, and if we have a patient with this, under these conditions with a prolonged visceral ischemia, then we perform the stabilizer true lumen first endovascularly, and then we go to the ICU. And the patient remains intubated. We leave the TE tube in place, and we perform a very aggressive antihypertensive treatment. And we wait. We follow the biomarkers. We see what happens with the liver parameters, the lactate, and so on. And then after 12 hours, 1 day, if everything goes down, we go to surgery. If we have problems, or we suspect a problem, really necrosis on the abdominal part, then we perform prior to surgery a laparotomy. We had 3 cases like this. We perform first the laparotomy, and then if it's necessary, we perform the resection first, and then we wait again 1 day, and then we go to surgery. So this is really a very difficult approach in order to categorize this, to say this you have to do this situation, this is the other situation. Therefore, we use this 6 hours around cutoff for our decision. That is the results up to now. It's really great. So we had reduced the viscerality, the mortality in this cohort in our hands more than a half. And yes, but you need a dedicated team. We are very proud to have our colleagues from cardiology on site. That's it.
Thank you. Any questions?
No, may I have a comment for this? A comment for this?
Can I just use the opportunity and tell you how we approach this problem, because we run into the same problem, of course, everybody does. In our hospital, in our setting, we changed the strategy in type A dissection in that sense that we still go in and operate. Our surgeons come anytime in the day and operate in a classical fashion, ascending or hemiarch or even a FED in a good day, in the afternoon or in the morning, but not at night. And then on the way out of the OR, we submit the patient to a CT angiogram in order to detect any kind of malperfusion after type A surgery as soon as possible. And in case there is some remaining malperfusion, we go in and stent the distal part.
You may be there too late.
Yeah, but we don't delay for the first part, for the proximal part.
problem that we have in this case is probably if you have the severe malperfusion, you lose the patient postoperatively. You will perform a great surgery, you will go for the pump, and after I wait in this situation, I know it's about 20 minutes to 30 minutes. I don't leave the place and I say to my anesthesiologist, wait, the problem will come, and then it starts. Pulmonary hypertension, a right heart failure. Every of these patients have this, the patient dies. So I think if you have the option of the hybrid OR, that means you can combine both procedures, control, surgery, angiography, surgery, and endovascular. This is the way in order to deal with this situation. And in order to have, at least to decide, for these patients, I will go first surgery, and after go to CT, for example, or I will perform first angiography and then go to surgery. You need this tool, otherwise it's not possible.
I have to come back to this issue. Mike Deeb used to say, there is a very, very thin line separating the ischemia from the malperfusion syndrome. Ischemia is something that you can reverse, but you don't have end organ damage. And I'm talking about the GI tract especially, all right? If you get to end organ damage, probably you're not going to get up with the patient alive.
I have to say, indeed, the risk is very high. But the patient, I will say, is not lost for 100%. You have to follow to stay. You have to operate, look to the ball, perform the laparotomy, resect the necrosis, and then wait. If the patient is circulatory stable, you can do it. You can do this.
Dr. Plestis.
Dino Plestis from United States. I agree with George. Acute aortic dissection is a lethal situation, and even under the best of the circumstances, the mortality may be as high as 15% or 20%. We have not achieved in the last 20, 30 years a mortality of 5%, and that tells me that no matter what you do, particularly because a lot of these patients come late, and a lot of these patients, at least in my center, they go to another hospital, and by the time they come to our hospital, the bird is out of the cage. You may not be able to achieve the outcome results. So in the United States, at least, the principle is do the simpler operation, the faster operation, get the patient out of the operating room alive, and think about the future when the future comes. Because also, a lot of surgeons, when they perform the dissection, they are not experts. They are regular surgeons that they do 5 dissections a year, and they have to face an immeasurable problem in the middle of the night. The other thing, and we believe very much in the University of Michigan approach, the patient comes with a lactate of 10, and the pH is 7.1, you may look at the belly and see if you can save the patient or not. And I agree with the laparotomy issue, because you can look into the belly, the bowel is dead, you know, you're out of the cage, you know. And I think a simplified approach to the problem maybe will not create such a significant impact, but we may save more lives rather than in a very complicated way. Thanks.
I have a question for the total assembly here. I mean, my old chairman used to say in acute aortic dissections, you have to decide what you want. You want a live cat on a dead lion. So I don't know how many of you are dealing with acute aortic dissections on an everyday practice, but when you face somebody with an acute aortic dissection, for Greece it's very difficult to say that because we have financial restraints. But how many of you do a frozen elephant trunk as a routine on acute type A or DeBakey type 1 dissection? 2, 3, Tsagakis, 4, 6. Okay, all right. And how many of you go for a classical hemi-arch? The majority. Okay, thank you.
Even a simple aorta replacement.
That's nothing wrong with that.
There's nothing wrong with that, okay? No. Let me put it that way to you. Okay, very good, thanks.
Tsagakis wants to rebate. That's good. Okay.
Yes. The problem in the acute malperfusion we face are 2. Okay, not rupture. We leave rupture inside, okay? Are 2. Circulatory unstable This we have it in most. If you don't have a coronary malperfusion, this is a tamponade.
Oh.
Okay. So the tamponade, to release the tamponade to stabilize the patient, this is not the problem. Also, under resuscitation, the patient comes back. I think you agree. The second problem is the malperfusion. If you control the malperfusion, where is then the problem to extend the treatment and to send after the patient at home with no risk for arch aneurysm or aneurysm in the proximal descending aorta? These are two points: tamponade as a circulatory problem and malperfusion. You solve the problem, you can operate as you wish.
I'm for it too, but in Greece we cannot use that graphene often because it's too expensive.
I have a question for Professor Ninaber. Thank you for your presentation. It was an excellent one, and we always enjoyed it. The proof of concept for FLIRT, that's what I would kindly ask you to elaborate. How many patients have you done this approach? What is the follow-up? And what are your concerns about the tissue that we treat? Because as you know very well, in most dissections, the tissue is defective and pathologic. And how much can we depend on this concept for mid-term and long-term? Thank you very much.
Thank you for these very interesting questions. The first answer to the first question, the total number of patients we have treated so far is 14. Of these 14, 10 have been published, and you can read them in this publication that I showed to you. The last one was last week. We are not dealing with acute situations because they are all patients that had been detected in the follow-up. So at least 3 months or later, we go in with this concept to promote thrombosis in the false zone because we detect that it is not completely thrombosed. So we're not dealing with super acute cases. They're all beyond 3 months. And in that situation, the tissues are stable enough to tolerate this intervention. Even an occluder in the ascending aorta is relatively easy, I think, for me to place in a patient who has survived 3 months.
Thank you very much.
Anybody else? So after this, Dr. Prapas wants to make an announcement. Go ahead.
This is only for Greek delegates. Θα δώσουμε λίγο χρόνο, 10 λεπτά, να πάρει ο καθένας κάτι στο πιάτο του και αμέσως σε ένα τέταρτο από τώρα να μαζευτούμε εδώ για να αρχίσει η γενική μας συνέλευση. Thank you all the invited faculty. It was a great session. We will start the next one at 3 o'clock.
I think we have to start in time, or actually it's after time, to have this session going. And we have some changes in the program. So first, we want to ask Professor Mestres to come to the podium to give his talk on connective tissue issues in aortic regurgitation.
Good afternoon, everybody. First, I'd like to thank you, the organizers, for the invitation. Let me go quickly through a complex topic, which is this one, which is a bit confusing. So aortic regurgitation in connective tissue disorders, so special precautions. So have no conflicts of interest. I'll try to go quickly through this outline of the problem. Connective tissue disorders, we understand what it is. So diseases affecting the parts of the body that connect the structures of the body based on abnormalities of collagen and elastin. This is clear and known. And that has gone through a number of modifications over time. One of the most recent is the new classification of connective tissue disorder that came a few years ago in the rheumatology area, but we know that this is a changing field with a lot of research and a lot of conditions, at least more than 200 under the same umbrella. For us, probably the most common or something that we see relatively often is this, and for us in cardiovascular surgery, two of the most important are Loeys-Dietz and Marfan, Ehlers-Danlos, and some other type of stuff like that. But this is, I found myself an evolving field, which is getting more and more complicated. We know that in many places this is under the umbrella of association. So the Marfan Foundation in Switzerland that Professor Carrel and Professor Turina know very well. They are using this very nice picture because of Niccolò Paganini was found to be something between a Marfan or an Ehlers-Danlos syndrome a while ago. And this is under the umbrella of many other international organizations as well. So I think Professor Turina and Professor Carrel, they are well aware of that, and we know some of the people who initiated this initiative in Switzerland about 30 years ago. And the whole thing came when Bart Loeys and Hal Dietz at Hopkins, they described this new syndrome of cardiovascular, craniofacial, and neurocognitive development caused by mutations of some genes, just a decade ago, no more than that. But again, it's the same, so we need to go through definitions. In the title of the talk, which has been officially assigned to me, is special precautions, which is, to me, complicated. But anyway, precaution, going to English dictionaries, is an action that is done to prevent something unpleasant or dangerous, or something which is done to try and protect a person or thing from something dangerous or harmful. So then I maybe understand a bit more about that. We know the surgical anatomy, and then it's easy to understand the pathophysiological sequence of aortic regurgitation in specific types of connective tissue disorders. We may discuss if bicuspid valve aortopathy belongs to this sort of diseases or not, which is, I think, a totally separate chapter. But according to that, those studies that we did many years ago in Barcelona looking into virtual reality was easy to understand that the abnormalities causing part of the structures of the aortic root could easily lead to aortic regurgitation. The information we have is, of course, there's aneurysmal dilatation or ascending aorta is associated with ectasia, and that presents clinical is aortic regurgitation. And that has been mechanically studied also. Mano Tubricar, has been working in bioengineering for more than 30 years. He also got very important ground on that. And we know that out of the aortic valve pathology, at least 25% could be dilated roots leading to insufficiency. A problem raises when we need to understand what is going on, but again, the definition is very easy. So a problem is a thing that is difficult to deal with or to understand. To me, at least for my own way of practicing, some things, they are still difficult to understand. The summary is that in cardiac surgery, we get young patients, aneurysmal disease, aortic regurgitation, and many times the valve is in danger, and they are closely associated. Question is, why do we
need to do something, like giving drugs. Today's losartan is a prime. Second, operations, because the life expectancy of those patients is reduced by complications within the aortic root, aneurysmal disease, and aortic regurgitation as well. But when we quickly go through the history of that, of course, there are hundreds of papers out there showing that, but I choose some of them to understand how we have done in the past 40 years with regards to this particular issue. When Vince Gott and his crew at Baltimore almost 4 years ago came with this initial paper on the surgical treatment of aneurysm of the descending aorta with a composite graft that was not, as you know, that common at the time, was easy to understand part of the problem. Very young population, large aortas, the percentage of dissection, almost all of them with aortic regurgitation, 2% mortality, actuarial survival, and that's the point. Very good results, and this is why they concluded, do it prophylactically before 60 millimeters of size. That has changed. And when they came 15 years later, 5 years later, with this increased experience, 100 patients out of 400 screened, they more or less they had a low mortality, 1% mortality, deaths according to the period of study on different causes, but at the end, the point is that survival 10 years was excellent, 80%, and late mortality only 5.7%. However, the risk factors for late death were all grouped here. It was very interesting to understand that we have a problem with all the conditions that I presented at the time of aortic regurgitation and ascending aortic aneurysm or root aneurysm, which is, of course, mitral regurgitation. Then, when University of Zurich reported for the first time a very long experience of almost 30 years, and that was a while ago in the European Journal, we knew that at least, as you could see here, between 60 and 70% of those patients, they have severe aortic regurgitation as part of the complex. So we should not forget that the aortic regurgitation is a problem. And then the other question is what to do. These were the results over time up to 15 years, excellent actuarial mortality according to the replacement of the root or the replacement of the valve plus different graft for the ascending aorta. And the point is that they concluded that the life expectancy of those patients is reduced mainly because of cardiovascular complications, and that the composite graft insertion, reimplantation of coronary arteries is the procedure of choice. So this is exactly what we learned. Then it came the new confounder, and that was when Tyrone David started to work on valve sparing operations, and Matti Jakub in Europe about the same with different approaches. And this paper from not so long ago, this prospective margin study from our colleagues in the US with something like 80% aortic valve sparings and about 25% replacements, we had excellent results overall. So there was no difference in hospital mortality, survival. However, he said that for the first time we had a difference because at least in just 1 year there was a 7% of aortic regurgitation plus 2 in sparing operations. And they concluded that there were no differences in anything, but the follow-up is mandatory. And these are the extreme course showing the different results. The point is not that slide's busy, but the most important is here. So the populations were not the same. So there was more elective surgery in sparings, longer cross-clamp times and so expected in sparings, and more valve replacement in aortic valve root replacement, meaning that the type of patient is different and more advanced disease. Our colleagues from Bern, they have published this study 3 years ago, which I found particularly interesting because of the messages given here and also significant proportion of patients. So over 20 years, they got 170 operations in 100 patients, but when they analyzed 59 patients with no prior disease or prior operation, first of all, there was a higher reoperation rate in valve sparing roots, especially for the Jakub, and no difference between mechanicals and valve sparings with a 0.8% incidence per year. And the neuro events in the mechanical group was 1.4% per 100 years. So which is interesting with no major differences in statistics. And these were the curves showing the freedom from interventions, which of course kicks on the sparing roots. And this is the freedom from cardiovascular events as well. So just getting into the final part of this quick presentation. Then our colleagues from Hopkins, again, they come from the long-term root operations for MAFANs, including, of course, a large proportion of them, more than 70% with aortic insufficiency. And they found that for 165 MAFANs, there was also different population. For the ventals, patients were older, larger aneurysmal size, more dissections, more aortic regurgitation. So we are not talking about the same thing. And they concluded that despite all things was okay, there were differences in valve sparing procedures. They have fewer thromboembolic of hemorrhagic events, which makes sense, but of course there was more root reoperation because of the valve in the sparing root. And these were also the curves that they are well known. And again, when we have a look at this busy slide, the three important things that there are, of course, different populations for the ventals and the sparing roots, functional class, moderate to severe aortic regurgitation, and emergency operations. So I think we are not talking about exactly the same. So the conclusion from Mayo Clinic was about the same after analyzing 30 years of experience. So the point is that predictors of late death were initial valve-preserving root reconstruction and a need for concomitant operation. So I think that when we have a look exactly of what is going on, if we have a look at this contribution from Italy, for the first time we're using a specific type of graph like the Valsalva. Initially it was a short series of patients, but again, with a short period of follow-up, less than 2 years, there was an 11.4% aortic regurgitation +2 in those preserved roots. And you compare that with David when he has a look at his large experience a few years ago in the JAG, which is interesting to see all these curves. They bring in a lot of information. However, the point is that only 10% of this large series by David had aortic regurgitation. So I think, again, we're talking about different types of population. And finally, the longest series so far, again from Hopkins, showed that valve-sparing procedures, particularly those with the reimplantation technique with the Valsalva graft, show very good promise, but have not yet proven as durable as the ventral. And I think this is a very moderate type of message. So finalizing, I think the facts, in my opinion, are that both mechanical and valve-sparing routes, they really work very well. Second, there is, of course, very low perioperative mortality, very low morbidity. The Achilles heel of the mechanicals, of course, is thromboembolic and hemorrhagic events. For the sparing rooms, the Achilles heel is aortic insufficiency. The patient population, in my view, may not be the same for each procedure. And again, there is limited evidence because most of the things are based on retrospective, small sizes, one-man shows, and so on, with an accumulative 1% failure according to Byrne, which was very interesting, against the same message that was distributed by Cameron. But when you have a look at the position by Florian Schonhoff, my colleague from there, you see that they think that we would not necessarily be inclined to perform valve-sparing operations first in very severely enlarged annulus, which still to be defined, large thin stretched cusps, careful in very asymptomatic sinus. Cusp repair is a problem, and valve, aortic bicuspid valve is asymmetric. I think we would rather go for a ventral procedure, and that was also a very clear message. So I think finalizing my precautions, because that was my question, again back to the definition. First, I think we need to look into the appropriate selection of the candidate. Second, to identify the risk. Third, to confirm the valve anatomy. Fourth, to confirm if aortic regurgitation is really serious, to understand if concomitant procedures are required, and select the valve-sparing procedure technique, although reimplantation seems to be better. But at the end, both options, according to the indication population, are very good options. Thank you very much.
Thank you for a very nice talk. Is there any question? Yeah.
Thank
Thank you very much for this excellent overview. My question goes about the drug treatment after successful surgery. I always thought, and I always gave my patients permanently beta blocker. Are there any new developments? Is a beta blocker still considered the prime choice?
Well, there's been, as you know, a lot of controversy recently, but I think, again, in the losartan era, when you have a look at some of these contributions, especially from Hopkins and some others, it's very clear that beta blockers, they should also be on board, despite there is growing evidence in the past 10, 15 years that losartan in these particular patients seems to be having a protective effect over time.
There seems to be some biochemical data that there is direct effect of beta blocker on the wall cells.
Sure.
Any other questions? I wonder, when you evaluate these patients, are you reluctant to do coronary angiogram and so on?
Well, I mean, most of them, they don't need it because every population in connective tissue disorder is really very young. And Marfan's, they're usually older. If you go to Lois Ditch, they are very young babies, so initially you are not going to do that unless there is a specific suspicion. Of course, the problem is that sometimes I think everybody in the room has found abnormalities of the coronary artery, especially in younger populations. But I think the role of coronary angiography today with very accurate 256 cardiac CTs, they could probably in this specific type of population be restricted.
Thank you very much. And just stay here. The organizers have a present for you, so I'm lucky to give you.
Thank you.
Thank you, Dr. Mistress. Wish you a safe flight. Our next speaker is Dr. Carroll. He has a great question about the guidelines. Are they clear on indication and timing? Dr. Carroll.
This one?
So it seems that my presentation has not been loaded, so I will go back to the, I'm sorry, I've given it this morning, but I will go and just go forward with the next one.
So can we ask Dr. Prapa to come to the, yes? Bicuspid aortic valve syndrome, latest gene data from research. Dr. Prapa.
Thank you. Just a quick question.
And we have to add that she is the daughter of the president of the meeting.
So yeah, thank you very much to the organizing committee for the invitation. It's an honor to be part of these. It's an honor to be a part of these esteemed, very senior colleagues who are part of this session. So my name is Dr. Prapa. I'm one of the registrars in clinical genetics in Cambridge, and I was asked to speak to you today and just give you an overview on the genetic basis of bicuspid aortic valve syndrome and whether this can help us in risk stratifying those patients. So starting with the basics, we do know that it's one of the commonest congenital heart malformations with a prevalence of up to 2% of the general population, and we do know that it has a strong genetic component. So both mathematical algorithms and familial studies have shown that it is a highly heritable trait, and I've included here a few pedigrees. From a study published in 2004, you can see that amongst 300 probants with bicuspid aortic valve and their relatives, approximately 100 of them, so 1/3, either had a bicuspid aortic valve and or other lesions that belong to the hypoplastic left heart syndrome spectrum or aortic root dilatation. We know that when this runs in families, it tends to be inherited in an autosomal dominant manner. However, this is with reduced penetrance and also of very variable expressivity. And generally, the recurrence risk that we advise to patients is that it can be up to 10%, although there are no accurate figures on that. And that's in cases of non-syndromic bicuspid aortic valve, where we've not established a genetic cause for it. So going further into thinking about how to genotype these patients, we have to think of how complex this trait is. First of all, starting with the morphology of the valve itself. As you know, there's a general consensus in terms of two subtypes of bicuspid aortic valve. These are a few pictures that I've borrowed from the cardiac morphology unit at the Royal Brompton, courtesy of Professor Yan Ho. On the top of the image on the right, you can see a true bicuspid aortic valve, where you have true fully formed leaflets and commissures, which can either have an anterior, posterior, or lateral orientation. And over here, you can see two functional bicuspid aortic valves. So the commonest is the right and left, where you have fusion of the right and left leaflets with a raphe in the middle. And on the other side, you see the right and non-coronary functional bicuspid aortic valve. And interestingly, there have been studies in animal models, and specifically endothelial nitric oxide synthase knockout mice, that have shown that those two different types of functional bicuspid aortic valves arise from different processes during cardiac embryogenesis. And in the bottom images, you can see transverse sections of the developing outflow tract in these mice. And in the first image, you can see that actually right and non-coronary fused leaflets arise from problems in the cardiac cushion formation. And this is the outflow septum. And at the bottom, you can see the pulmonary valve cushions. And next to it, you can see that actually right and left functional bicuspid aortic valves arise from a problem that occurs later on during development due to problems in septation of the outflow tract here with fusion of the right and left leaflets. So moving on to the complex heterogeneity of bicuspid aortic valve, of course, we cannot omit associated aortopathy. And again, this is a very big topic to discuss, but in summary, there's been a lot in the literature around genes versus hemodynamics. And I think the general consensus, again, is that both contribute to aortopathy to various degrees. It's been postulated early on that stenotic bicuspid aortic valves cause an impingement. Oops, sorry. Of high-velocity jet that actually corresponds with an increased shear stress and a bulge on the right anterolateral wall of the ascending aorta that we typically see in those individuals. Now we have more sophisticated methods to assess the hemodynamic contribution in these individuals with 4D functional MRI studies that assess the flow and the distribution of the wall shear stress. And again, although these findings in different publications are a bit discrepant, generally it's been shown that different types of functional bicuspid aortic valves, subtypes of them, can cause differential contribution in terms of shear stress and also phenotypes in terms of aortopathy at the level of the root, the ascending aorta, or the aortic arch. And of course, we know that the contribution of these also is evident at the level of the histopathological studies. So it's been previously shown that in terms of the convex and the concave parts of the dilated ascending aorta, there are histological abnormalities that may correspond to the hemodynamics. What's very interesting from the genetics perspective is that it's been postulated that actually the aortic root phenotype may be the predominantly genetic, in bracket, forms of the condition. And that's because we tend to see young males presenting with dilated roots and a degree of concomitant aortic regurgitation. And again, it's been shown from histopathological studies that those individuals with this particular phenotype tend to have quite significant abnormalities at the level of the ascending aorta, even in the absence of significant aneurysmal disease there. So it's something that may be relevant in terms of surgical guidelines in the future. Finally, an important thing to distinguish is syndromic versus non-syndromic bicuspid aortic valve. A previous speaker mentioned fibrillin 1, so Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos syndrome. There's a higher frequency of bicuspid aortic valve in these syndromes as opposed to the general population. And of course, these are very important to diagnose because the thresholds for repair of the aneurysmal aorta is quite lower. In terms of non-syndromic bicuspid aortic valve, there have been lots of different approaches that authors have taken to try and unveil the underlying genetic cause for sporadic non-syndromic bicuspid aortic valve. What most of the authors done is use the targeted approach, so they sequence genes that we know that are important for the integrity of the structure of the wall, for example, ACTA2 gene, or genes that encode proteins that are important for cardiac embryogenesis, in particular of the aortic valves, for example, GATA5 and GATA4. And there have been lots of animal studies as well, but not all of them correspond to humans in terms of finding the same variants. One very interesting study published 4 years ago is that of fibrillin 1 gene mutations found in individuals who have bicuspid aortic valve, but they don't have Marfan syndrome. In this table, you can see in the top two, those two individuals both had quite young onset in terms of presentation. They both had quite significant aortic root enlargement with aortic regurgitation. And the top one did not have any ocular or systemic findings suggestive of Marfan syndrome, whereas the second one only had a Gantt score of 2, which is very low and is not enough to make clinical diagnosis of Marfan syndrome. So he only had mitral valve prolapse and myopia. So that's something important to consider in terms of should we be sequencing fibrillin 1 gene, even though we don't see individuals that have Marfanoid habitus. And this is just a patient that I've recently seen in my clinic. We actually do encompass this a lot in clinical genetics. So I think what's happening now, I think we're just seeing the tip of the iceberg. So we see individuals with connective tissue disorders that are at the severe spectrum of the disease. However, as we offer segregation, so predictive testing in relatives, we found out that they also have the condition in a much lesser degree. And if you can spot who is the affected person here and what is the diagnosis, it's actually the gentleman who has Marfan syndrome. He's not particularly tall. He did not have any history of lens dislocation. And his Gantt score was only 2. I think it was just for myopia and mild chest asymmetry with no pectus deformity. And the reason he was tested is because his sister, as you can see here in that pedigree, was diagnosed with Marfan's after presentation with an aortic dissection during pregnancy. So she was found to have a pathogenic fibrillin 1 variant, and then on testing her brother, he also carried this particular variant. And at the age of 38, he only has mild aortic root enlargement, and he's on medical therapy for this with regular follow-up. We also offered predictive testing to his very young daughter, so that has implications to other relatives. And actually, his youngest of the two also carries the familial variant, so she's under regular monitoring. However, having said that, when do we draw the line and who do we offer testing to? Generally in the UK, and particularly in my department, we have an aortopathy gene panel that contains more syndromic and non-syndromic causes of aortopathy, and we have a low threshold of sequencing these individuals, particularly if they're of young onset, if they have mild connective tissue features, even if they don't fulfill clinical diagnostic criteria, and the ones who have a strong family history suggestive of an underlying heritable cause. I've summarized here a few studies of gene panel testing, and the top is a study that we've done at the Brompton. This is just a preliminary results. So you can see that overall in 176 patients, targeted sequencing of 63 genes actually gave a very low yield in terms of finding pathogenic variants. And a small proportion, we found 2 hits. So it might be a digenic hypothesis. When you have 2 pathogenic variants, those individuals were enriched in terms of aortopathy. And to summarize, just at the bottom, you see another study where they only sequenced individuals with a bicuspid aortic valve aortic root phenotype that we think might be the genetic form in brackets. And a significant proportion had suspected variants, and the top hits were Notch1 gene, followed by fibrillin 1 gene, again without a Marfanoid habitus. However, having done targeted sequencing, lots of problems come with it. One of it is finding lots of variants of a certain significance. And just to illustrate this, you can see here an individual who underwent targeted testing. He was heterozygous for variants in 4 different genes. all of them missense, no loss of function variants, and they did not segregate with the phenotype in other relatives, meaning that these are likely to be benign, or we still don't know enough about these. And just to finish off, this is how we generally, or I think, the picture is going to end up being in bicuspid aortic valve. So on the top of the scale in purple, you have very rare variants, so variants that you see in less than 1 in 1,000 and less than 1 in 1,000 general population. And these are causing Mendelian disease. So they have monogenic cause, they follow the laws of Mendel. And these at the moment are just the syndromic forms of bicuspid aortic valve, such as Loeys-Dietz syndrome. Then we have in the middle low frequency variants that have an intermediate size effect. So they're not explain the phenotype fully, but they contribute to the phenotype. And I think that notch 1 probably sits somewhere there. And then in red, you see common variants, also known as polymorphisms, that may be implicated in a common disease, but also contribute to the phenotype selectively, altogether, collectively, as a polygenic score. This can only be identified via genome-wide association studies. And actually, in Nature Communications, there was recently a paper where they found a GATA4 upstream non-coding variant that had a genome-wide significance in terms of bicuspid aortic valve. So in conclusion, we're still not there in terms of unmasking the genetic basis of bicuspid aortic valve, although we do know that it is heritable. It may be that there's a number of susceptibility genes, and they all have different liability thresholds. For example, a person with severe calcification has a notch 1 variant, and another person with a hypoplastic left heart syndrome may have a different, like for example, a GATA4 variant. So at the moment, even if we do offer testing, the yield is quite low. We do recommend, as you know, for first-degree relatives to be screened because isolated thoracic aortic dilatation can present in relatives even in the absence of a bicuspid aortic valve. And of course, it's important not to forget about the syndromic aspects of the condition where we would recommend for referral to a geneticist so that they can evaluate the person further and give accurate recurrence risk and further prognostic information. Thank you very much for your attention.
Thank you, Dr. Prapa, for a great presentation. A question for Dr. Prapa?
Thank you. Yeah.
So if the presentation of Professor Karel is uploaded, I would like him to share his experience on a subject that is really puzzling us lately. On the guidelines, are they clear on indication and timing?
Yes, thank you very much. My topic is really a simple one because I had only to read a little bit the guidelines and try to make a summary. So today there are two main guidelines, 2017 from the European Association and 2014 from the American Association, with one supplement. In 2017, AHA and ACC just wrote a focus update, which transformed a little bit the new knowledge, mainly in aortics for aortic stenosis and mitral regurgitation, as you see here. So aortic regurgitation was not found to need some additional comments since the 2014 guidelines. So if we look across this guideline, the main topics of interest are on the one side, of course, the severity of the AR, the symptoms of the patient, and then consideration about left ventricular function and dimension. And of course, the size of the aortic root is also playing some kind of role within these guidelines. Just to try to summarize here the guidelines for severe aortic regurgitation alone without any aortic pathology. This is the first part of the table. It's clear that the class 1 indication is found to be justified for patients which are real symptomatic and for those asymptomatic with a worsening of the ejection fraction lower than 50%. Some patients may need another kind of surgery like a CABG or mitral valve, and they have at least severe aortic regurgitation. And by the way, of course, if this problem can be treated, the class of indication, the class of evidence is also one. The other one are not so very important. You see indication 2A is something in between for patients who are asymptomatic with good ejection fraction, but already severely dilated left ventricle. It's a 2A, and the level of evidence is a B. So looking at the guidelines from the American colleagues, one not major addition is perhaps the stage of progression, which are very well defined in the American guidelines. They differentiate between stage 1 to D, depending on the definition they give to the patient, if they are only at risk, if the disease is progressive, if they suffer from severe AR, but they are still asymptomatic, and the highest degree is the degree D, severe AR and symptomatic condition. This comes later on in the table, and you see here just trying to summarize what the proposal is. If patient on the right have progressive AR and need other cardiac surgery, you may consider concomitant aortic valve replacement at a 2A indication. If they do not need surgery, they are usually entered in a periodic monitoring cycle. On the other side, the very clear indication, which actually are the same as those of the European Society for the symptomatic stage, stage D, according to this American classification, and those patients in stage C, asymptomatic but with worsening left ventricular function. What is interesting, and I will not emphasize too much this because the previous speaker has spoken about bicuspid valve and also the potential phenotypes of aortic root and ascending aorta in those patients with aortic regurgitation. Either the aorta is normal, or we have a root dilation, or we have an ascending aortic dilation. For a surgeon, it's really important to classify also these different categories of aortic insufficiency, because they have probably a significant impact on the technical possibility to repair the valve and not to replace it if the main problem of the aorta is also treated. I think I don't have to make too much comment on the bicuspid aortic valve, the three different types. Unfortunately, there is really less consideration of this type of anatomy and physiology which enters the guidelines. You will see the guidelines for bicuspid valve do not make too much differentiation about the morphologic changes of the aortic root and the ascending aorta. If we look here, the second part of the table from the European guidelines, which is mainly dedicated to the problem of aortic root or ascending aortic dilation, we see that valve repair, of course, can be recommended in patients with aortic root dilation and tricuspid valve, with an additional comment that this operation should be performed by experienced surgeon. And on the second row, surgery is indicated in Marfan patient when the diameter is more than 50 millimeter. There are some small differences between the American and the European guideline, about 5 millimeters of differences. Very interesting for me, the 2A indication. If some Marfan patients do not reach 50 millimeters, but they have additional risk factors like a mutation or a dissection in the family or something additional, we may consider, of course, a preventive operation in these patients also. Now, bicuspid valve, if we look at the American guideline, and aortopathy, of course, intervention is dedicated to repair or replace the sinuses and the ascending aorta. Here, the threshold is 5.5 centimeters. So threshold is clear, but when we discuss with the colleagues, it seems that the real life lets still a little bit of additional judgment, since a lot of surgeons still recommend operation beginning from 5 centimeters, even if this is not a class 1 guideline. And as you see here, class 2A from the American, very similar. The second is similar to the Marfan consideration, but it is aimed to define the optimal behavior for patients with a bicuspid aortic valve, and who have also, of course, severe aortic regurgitation. Here, of course, you may replace the ascending aorta as soon as the diameter is bigger than 4.5 centimeters. And this is some kind of summary of both guidelines, looking not only at the aortic regurgitation, but also if there is enlargement of ascending aorta, yes or no. If yes, and this is more than 50, usually surgery is recommended. If no, and it is only a valve problem, if the patient is symptomatic, surgery is recommended. If patient is not symptomatic, follow-up will be the main recommendation. I think one of the key points, if we look, is the problem of symptoms, how to define really symptoms, the problem to document left ventricular function and end systolic diameter should not be a stronger problem, because it's easy to do this by echo. The other key points, I think, to state that in asymptomatic patient with severe ER, a careful follow-up is mandatory, is really a little bit trivial. Gaps in evidence, yes, there are some gaps. One for us surgeon is on the basis of which criteria should be the decision either to replace or to repair the valve. Here it is not summarized, but in the discussion with colleagues, I think that the problem of bicuspid valve and aortic root dilation is still something which needs much more basic evidence to clarify the different opinions which are lying across the ocean. The prognosis is, to my impression, there will be an increasing awareness about this problem. Probably the numbers of patients who need operation will increase, and the treatment might be really earlier. Looking, of course, at additional factor is very important, and most probably, I think TAVI will also change a little bit the future of aortic regurgitation in the next future. Thank you very much.
I have a feeling that you are in a rush to go.
It's okay.
Okay.
Have a safe flight.
Thank you.
Yeah, okay. Have a safe flight. Thank you for your presentation. It was excellent. Okay.
Okay. We have a pleasure to invite Dr. De Paulis, one of the masters of valve-sparing surgery, to give us a talk about surgical technique for dilated root and aortic regurgitation.
Just a second, Yes. Okay. Okay. Thank you to everybody. Thank you for the organization for this invitation today on a beautiful day here in Greece. So speaking of aortic valve regurgitation associated with the aortic root aneurysm, first we go briefly on how to assess this, because assessment is very important also for the indication. So imaging modality is very important. So we know that in order to know exactly what you are speaking about, what type of pathology, you have to indicate the location where the aorta is abnormal and the maximum diameter of any dilatation of the length of the aorta. Usually we took, like most of the people, 4 different diameters: annulus, sinus of Valsalva, sinotubular junction, and ascending aorta. It's also important where to measure. So if you measure with the echo, you should measure from leading edge to leading edge, and also most of the time during diastole, because the signal is more stable. And it has to be orthogonal to the long axis. This is also very important because that's where the source of many mistakes. In the CT scan, on the other side, we have to measure inner edge to inner edge. It also is particularly important to ask for ECG trigger during diastole to avoid the artifact of movement that you can see in these images. You can understand that easily these 2 diameters is completely different because of artifact of the movement. Once again, it has to be orthogonal to the center line to precise. This is Dr. Anderson, you know, is a master of anatomy. He also highlight the difference of measuring, especially when you use a 3D dimension. So it's very important because you have 3 different ways of measuring. There is 2 diameters. This is called off-center right and off-center left, the red and the light. And then the bisecting that goes from the commissure to the sinus of Valsalva. And this is particularly important because you have to use a bisecting cut to measure the annulus, while on the other side you have to use off-center right for the sinuses. This is an example of how, I don't know if you can see well because it's a little bit out of the screen, but if you use the off-center right, you get the annulus that is smaller than actually C16. If you use the bisecting, the correct way is 18.9. So if you want to measure the annulus and the sinus, you have to do different projection. The take-home message is also that in general, the sinus of Valsalva, if you measure by echo, are generally 2 millimeters smaller, larger than when you're measured with the CT scan. So the problem is when to operate. Professor Carrel went through this very well. Usually, as a generally, max diameter is 55. If we can also consider the body surface area and having low risk, if this diameter divided by body surface is less than 2.75, a low risk, or more than 2.75 is progressively increased risk. Professor Leftriadres, who just described this chart with body surface area, just published a new article where with an increasing number of patients, we correlate this with the height of the patient that is more precise. So now there is a new table using what is called aortic height index. So it's much more important because it's more precise, especially we have a short, fat woman or tall, skinny man. Basically, to correlate the diameter of the aorta with the height of the patient is more precise as compared to the body surface area. As for the indication, you have seen 50 millimeter in Marfan's, 45 if there is some additional risk factor, but it has to be tailored in a specific case. In fact, there is class 2B, there is some situation like a small body surface area in the present aortic valve regurgitation, because in this case, earlier we get more chance to precisely spare the valve. Also depend on the surgeon experience, sometimes on patient preference, because some patients live with anxiety, the fact of having an aortic aneurysm. So we have out of the box some tailoring indication that is specific for everyday life. So I tend to be more aggressive in case of young patients that have a very long life expectancy. To be more aggressive if the patient is normally undergoes strenuous activity like a sport, heavy work, and so on, or because they have high likelihood of valve sparing procedure with the low operative mortality, a good chance that the spared valve would last for the rest of his life, and also in some case elongated the aorta. There is now some evidence that aortic elongation is also important in the risk of aortic dissection. So let's start with an entry-level easy case with a male 62, normal height, arterial hypertension, smoking with a medium-sized aortic aneurysm and a tricuspid valve with this central regurgitation. This is just the case. You can see, you can measure the annulus is 27 millimeter, senovalsalva 46, sinotubal junction 44. So this is look like a global dilatation at the limit of the indication for sparing the root. In fact, you can also approach in a very simple way, just replacing the ascending aorta. You can see in this specific patient, the shape of the roots completely changed. Now, even if you measure senovalsalva, you have reduced by 2 millimeters, so the valve is perfectly competent with the high coaptation level. Even the annulus is reduced from 26 at the post-op, the diameter was 24. So in this case, the tips and tricks can be verified the ratio between the annulus and the sinotubal junction, because normally it's 1.3. So every time you have mismatch more than 1.6, this is the main cause for the aortic regurgitation. And then also when you replace the ascending aorta, just have to be careful to proper symmetric orientation of the three commissures, because by suturing the ring exactly at the level of sinotubal junction, sometimes you can change the distance between the commissure, and this is the cause of a residual aortic insufficiency. To make this simple, to get the graft size, we size the annulus, and we had 5 millimeters for a tricuspid valve and 7 millimeters for a bicuspid valve. And so if the annulus is over-dilated 23, we stabilize the annulus to reach an aggregate diameter of 23 millimeters, and then we size the graft and choose, again, 5 millimeters for tricuspid and 7 millimeters for bicuspid valve. But always we have to keep in mind that the bicuspid valve, every time you take a bicuspid valve out of the root of 5 centimeters, you put again into the 3 centimeter aortic graft, the leaflet by definition will prolapse. This is a very rare left non-coronary fusion. This is 1% of the population, so it's very difficult to see one of these cases. You can see the valve, once everything has been taken out, coronary and all the root has been dissected, you see there is a perfect coaptation between the two leaflets. But then after you re-implant inside the 3 centimeter graft, you see how many 5 plication one side, 5 plication on the other side, in order to reach the adequate level of coaptation. Coaptation can be again verified at the end of the procedure by using a caliper. So this is very important. If you have a global root dilatation with severe ER, like in this case, young woman, normal size, asymptomatic, but with tricuspid aortic valve with severe aortic regurgitation, this is the typical case. So this you can see small annulus, large root. This is the excellent indication for a proper valve sparing. And with the good valve sparing, this is probably will be a definite operation for this. This is the post-operative care. You can see this is immediately post-op. You can see there is still some space between the diaphragm and the commissure, but you can see also how the leaflet is very much long and very much a line of coaptation at the moment of diastole, but also very important how the annulus stayed the same because it was not dilated in this case. So this is the best condition for a aortic valve sparing operation. So the anatomical key point this way to stabilize the annulus. Normally, you also reduce the annulus, and this was not the case because it was already small. Reestablish a proper leaflet coaptation, level and amount of coaptation. So effective height and also length of coaptation. Reconstruct the sinus of Valsalva. There are several ways to do. There are several grafts that you can use to reconstruct your sinus of Valsalva, of course, and proper coronary reattachment at the end of the procedure. Another important point that also Professor Carle pointed out is the jet orientation. This is a typical jet of central regurgitation because of dilatation of the sinotubal junction. Not too much of the annulus in this case because also annular dilatation gives a central regurgitation, but mostly from sinotubal junction. This is a clear example of cash prolapse with the eccentricity of jet toward the anterior leaflet of the mitral valve. But of course, so if you have a jet going this direction, is probably a prolapse of the right coronary cusp. If the jet goes in this direction, is a prolapse or of the left or the non-coronary. The problem is when you have prolapse of two of the leaflet, to understand the direction of the jet, understand what this prolapse coming from is more difficult. So in dilated root analysis of origin and direction of the jet can be more difficult to precise diagnose a localized prolapse of a single cusp. Because also, if you have a prolapse of a leaflet, it's easy if the root is normal, but when the root is dilated, all the tension on the leaflet change and may not apply the same rule. Let's see another example of the root aneurysm in the context of bicuspid valve. This is male, 54 years age, bicuspid aortic valve left-right with severe aortic regurgitation with a medium-sized root aneurysm, type 1 with the Raphe tricuspid valve. You can see on the valve analysis, you can see it's more rough in this one. You can see the leaflet, the prolapsing leaflet done. And now let's go to see the jet, to try to understand the direction of the jet. In fact, we see a little bit eccentricity, but most of the jet was going inside, and this was not what normally is a normal aspect of the valve. But no, that's why sometimes you have a special finding. This is a typical finding of huge prolapse of the fused cusp. This ring usually represents a huge prolapse of the fused cusp. Let me see if I can activate this video. Yes. This is the video that shows how abnormally they prolapse. But in this case, because of the jet was central like this, in fact, it was not a prolapse, but was a hole inside the leaflet. So sometimes the jet helps understand, even in those situations where I would swear that was a prolapse of the cusp, but the jet didn't correspond to what is thinking. So in this case, when the root is like in the range of 40, between 40 and 45, we can do a simple valve repair by stabilize the annulus. This is, I just changed the technique last year. I don't use the Dacron anymore. I use a Teflon and that I pass along the valve. But in the end, there is not too much difference. You have to go with your graft, with your Teflon or with your strip of Dacron below the left and the right coronary just to stabilize. And using this kind of soft material, you can really get, especially if you have done a very good root dissection, you can go at the level of the annulus deep inside and reduce the annulus diameter. So this is, in fact, was the patient after this annuloplasty. You can see the aortic root, it was slightly reduced from 44 to 42 immediately, and with the splication with one cusp associated with annuloplasty. And also the annulus was extremely reduced from 27 preoperative, you go down to 21. Actually, I try to reach always 21 and 23 in all cases, either tricuspid or bicuspid valve with annuloplasty. I put the necker inside, I tie until I reach this 21 and 23, because this is the normal diameter of the annulus we should get. Then we have some case with an asymmetric dilatation, especially for bicuspid valve. This is the case. You can see the asymmetric dilatation of the non-coronary cusp. In this case, this is very rare case because I don't like to change only one sinus, but this is a case where you can actually see the root is only dilated in one side. This is a long axis view. They show the normal size sinus this side and the very large sinus on the other side. If we go and look at the echo, we see that the majority of dilatation would do because of the non-coronary sinus. So the aortic root is 45 or 36, but the non-coronary sinus is 27. So it takes more than half of the whole diameter of the root. So in this case, we can really replace only that sinus just to simplify. You can see the aspect, that there's much more symmetric aspect at the end of the procedure. So now the non-coronary sinus, after replacing just this sinus, is 17 from 27, and a more symmetric proportion of the root is re-established. So we do this actually in order you know, because I don't like to do one sinus because very likely you can distort the whole root. So in order to avoid any distortion, I use actually what I take out from the patient as a mold to perfectly shape and also to change the direction of the pleats of the graft. So see now the graft, if you stretch the graft, is slightly larger than the place I've taken out, but since it needs to be sutured, you lose that extra tissue. And then starting from the nadir, all the graft, is simply reattached. And then I prefer to do a sinus alone and then perfectly reshape, following those rules I told you before, the ascending aorta. Then another case of global root in ascending dilatation. In the case of bicuspid aortic valve with severe aortic regurgitation, this is more or less the same as with tricuspid valve. Actually, it's a little bit faster being a bicuspid valve. Annulus 28, Valsalva 49, and ST and ascending aorta, ST 55 with the huge ascending aorta in this case. And the jet analysis, once again, tells you that is mostly due to dilatation of the sinotubular junction. There is a central jet, in this case of bicuspid valve. So we can do reimplantation. You can see after the operation already, the annulus is now 22, and the leaflet, you can see the whole leaflet during systole. And this video just shows that usually we mark the place of the stitch already on the graft, so we can adapt the graft to each individual patient. And then once again, you can see how the competency is reestablished and also the good movement. Even though one of the two leaves move less, usually this is the final. Most of the case, there is a slightly restriction of one of the two costs because of the raphe. So in conclusion, in patients with root aneurysm aortic insufficiency, in the majority of cases, the root is replaced. This is the majority of cases. But in majority of cases also, the valve can be repaired. And depending on the size of the root, a more conservative approach sometimes is possible in specific cases. Of course, the choice of Bendel procedure still remains and may depend on age and comorbidity of the patient. Thank you very much.
Thank you very much, Dr. De Paul. Is there any question from the audience? Yes, please.
Roger, you mentioned that you made a formula of annulus to sinotubular junction relation of 1.6, but this is a problem. My experience, at least in a good number of patients, the aortic leaflets grow with the aneurysm. So the original measurement or the normal root measurements do not relate to this secondarily changed valves. So I came up with no measurement, putting in the prosthesis and adapting the leaflets, which are usually then oversized, to the new dimension of the root.
Mm-hmm. Yes, but I agree. It basically is the same things, because we following different road, we went up in the same at the same point. Because I do agree that sometimes the leaflet are too big for that root. Often that is the case. That's why it's very important to know how to plicate the leaflet, to adapt the leaflet. But basically, I don't think the choice of the graft is different, because if you look at all number, always the average diameter of the graft is between 30 and 32, 95% of the time. So the size of the graft, that is the most frequent question, I think is not really, is very important. So either you take a 30 or 32 won't make much difference, but also it's very important that at the end of the procedure you measure your cusp and adapt the cusp to. And that is the same for the remodeling procedure. You know, in remodeling procedure, I think to keep a normal geometry is very difficult. So often they distort a little bit the geometry, but because they play with the leaflet after the remodeling, they reestablish a normal coaptation. So it's basically, yes, I agree with this way. You can always be in the right position.
Thank you. Any other questions from the audience?
Thank you.
Thank you very much, Mr.
Okay.
Thank you.
So then we continue, and now we will hear about the rings we can use for the aortic route. And it's Professor Stavridis from the Onassis Center that will tell us about this.
Dear colleagues, good afternoon. We are all aware of regarding the history of the aortic valve repair, regarding the insufficiency of the valve. Various things have been tried. It's many years ago, it was the subcommissural suture annuloplasty by Cabral. Later on, Schaefer's developed initially the internal and nowadays the external ring, the external suture, the Gore-Tex suture, and Emmanuel Lansac also developed this ring that it's based in the base of the heart, and in conjunction with other techniques as well regarding the aortic root. And nowadays also we have the Coroneo ring, which is the new model regarding this technique. Some prototypes also for the ring I'm going to talk about, which is this one. It's the child of Scott Rankin, and this is a ring, as you can see, a geometric ring, and it was based on a mathematical model that came out of the investigation of 11 individuals, and this is more or less what appeared. It's maybe as surgeons we're not aware of that, but after the period of the era of the TAVI, we found out that the geometric ring, it's not a round structure. It is more elliptic during the diastole, it's getting more round during the systole, but with a small variance between the two cardiac phases. And again, based on cadaveric measurements, it was found out that it's the free edge of the leaflet. It's more or less 1.5 times the size of the diameter regarding the tricuspid valve, and it's 1.8 times regarding the bicuspid valve. And of course, the nominal size of the ring doesn't mean much. It doesn't mean that 1921 doesn't ring a bell. It's because there are two axes. So you have to add more or less plus minus 3 to 4 millimeters. But what it represents is the circumference. So 19 means that you have a circumference of 60 millimeters. And these are the rings. The bicuspid ring is not available in Europe, but it has been cleared by FDA in the States. We don't have it in Europe yet. And the technique of it's a simple technique, the way we implant it. Some vertical mattress sutures, pledgeted mattress sutures with a 4 or 17 millimeter needle sprawling. Regarding the subcommissural areas, and some looping sutures, again, horizontal mattress sutures around the sinuses. 2 for each sinus, unless it's a small ring size 19, which is 1. Let's see some videos here. They should play simultaneously. And this one is a gentleman with a non-syndromic patient. This is a Barlow patient. It's a Marfan lady, which has also significant regurgitation of the valve. This is central. This is eccentric jet directed posteriorly. And also there is severe regurgitation of the mitral valve. Here you can see both valves are opened. This is 30 millimeter Heger. This is 26 millimeter Heger. You can see that the valve leaflets, they look normal more or less. This is measured by 21 specially made sizes in all three. This is 23 for both, but this is much bigger, 25. By looking roughly at the anatomy, you have the idea that maybe the left commissure is normal. Here there was a change of the technique in order to make the whole leaflets come up. The positioning of the ring has been proposed to, I don't know if we can run that. Can we just run it a bit, just because it has to be repeat itself? We cannot just run it, make it faster. Let's go to about 2.5 minutes if you can. And both of them, actually. Go where the sizing is happening. I think you can leave it as it is, just, I'll leave it as it is, that's fine. I'm sorry for that. It's again, more or less, you can see that the leaflets, and what I was saying before is that we noticed that the left coronary sinus that we see more and more frequently, it appears to be more or less normal in both cases in appearance. And that's why at the end I will go through the idea of selectively replacing the sinuses of both patients. And that's what I was saying before, is now we tend to position the ring lower in order to achieve a better apposition of the valve leaflets. So to increase the vertical leaflet coaptation side. Here you can see the way we position the leaflets. We have marked the area where we are going to put the top of the post. It's where in the previous patient we have to position there the lower part. So this is the mattress suture I showed to you. It goes from the east side of the ring. It doesn't matter whether you start from the bottom of the post or from the top of it. And once you position all these sutures, the ring is lowered in the LVOT tract. We cut the holder and we remove it, and we make sure that the ring is in the right position in the outflow tract. And then it's the time, there is always a small string left, so just remember to remove it. And then we put the looping sutures around the ring. Again, those are horizontal mattress sutures, again with the same needle, the 4 or 17 millimeter. It's the same for both cases, no changes. It's very important to position these sutures before you cut the sinuses, because it makes your life difficult. First, we tackle the valve. And once we tie all these sutures, before cutting them, to avoid of knots impinging against the valve tissue, we laterally secure the knots just to take them away from the valve area. And we make sure that there is a good coaptation of the leaflets. Here you use the 3 forceps. Here we have the caliper, and which is around 9.5 to 10 millimeters, which is more or less good. Then in this, we start resecting the sinuses. As I said before, being a small, normal-looking left sinus, we remove all the sinuses except the left one in both patients. Here we use a Valsalva graft, here a straight graft, and we start anastomosing the graft to sinuses, to the right and to the non-coronary one. And once we're finished here, we trim the excess part of the graft in order to accommodate the normal-looking left coronary sinus. And later on, we'll do the same here as well. And once here, we still continue doing the non-coronary sinus. Here, the stitching has finished. And here again, we trim part of the straight graft. And more or less after that, what is left is just to anastomose the right coronary sinus. We can look from inside just to see a good apposition. At this time, we can also inject some cardioplegia inside to see whether we have regurgitation inside the ventricle. And here, more or less, the operation has finished. It's by doing the distal anastomosis. And here the same, the distal anastomosis and the suturing of the coronary button. And at the end, the echocardiogram shows here a competent mitral valve with a mild regurgitation of the aortic. And here we can see a competent aortic valve with no regurgitation at all. So, what are the steps here? The steps is just to use this ring whenever you have either a tricuspid or a trileaflet or a bileaflet valve. Of course, it's sometimes necessary also to do a few things on the leaflets. The coronary buttons, depending on their size, can be selectively excised, and the coronary buttons, of course, are reanastomosed. And these are more or less most of the cases that this ring methodology is applicable, starting from the isolated aortic insufficiency to aortic aneurysm. So it's not only correcting the annular dilatation, but even if you have a small annulus, this is a question that I was asked by Dr. Artemiou and Dr. Agurazad here, so I owe you an answer for that. It's also to maintain the geometry when you have something. You can say loosely that it's maybe a way of prophylactically using it in that case. So, so I'm sorry for the right answer for that. And so it's more or less what you can do. You can use it either together with a Jacob remodeling technique or using it for just to replace the ascending aorta and to support and to maintain an aortic valve that's leaking together with some modification of the leaflets. So this is in contrary to the well-established and with a very good long-term results David procedure. It's, as you can see, it's simpler. And you don't need to have a deep dissection in the aortic root. Of course, somebody will say, is that a big deal? Yes, it's not everybody's kettle of fish just digging inside the septum. It's, of course, with seasoned surgeons that we have here, it's okay, but it's not for most surgeons easy to start digging to do these things. And for instance, see how far you have to go. You have to dig all there and bring your sutures down there if you want to do a remodeling, if you want to implant a Lansac ring, if you want to do this. That's the way you have to go. And of course, if you, on the other hand, you are clever enough to start cheating and doing a dissection, you will end up having a prolapsing leaflet. So with this technique, we avoid these things. And these are more or less what we have available so far. And apparently, what appears to be quite versatile is this ring here. The only thing that it lacks is the long-term data, so that somebody can be convinced. Of course, somebody can ask, why do you bother repairing the valve? Is that a big deal? Why don't you replace it and get out? But it is. It makes a difference, as you can see here, in the survival. And don't forget, even with the prosthetic valve, don't forget that these patients are young patients, so you will end up putting a mechanical valve. And of course, you are aware that if you have patients below the age of 40, probably you know that the chances of them with the prosthetic, with the mechanical valve in the aortic position of dying in 10 years is 1 in 10. It's a huge number, 10% mortality in 10 years. It's for young patients, quite significant, mostly, of course, related to anticoagulation. So the worries with this technique is sometimes when you have a right coronary ostium very close to the commissure, that the trick you can do there is just keep the ostium close to the commissure and resect the rest of the annulus, of the sinus. If sometimes, and that's one of the failures that we had with the Marfan patient, when you have a very high AV junction, a shallow sinus, and of course the ring, as I said to you before, about the bicuspid valve. Now the asymmetric sinus, it's quite frequently is considered a heretic approach to have patients with hereditary disorders or syndromic patients, saying that I'm going to do a selective replacement of sinuses. But it's, you're all aware of the recent article by Urbanski that shows in Marfanoid patients that they had all their criteria. They had very good results by doing a selective replacement of sinuses. These are almost since we started last year, these are more or less the more structural valve repair program that we had in my hospital. And regarding the heart ring, we implanted 13 patients, which is for the, as you will see, for the standards for the worldwide experience. It's more or less most centers, they have done about 15 to 20 cases so far. And these, the red ones, as there are some failures. And the failure, one of them, it was a young patient with a Marfan, as I said to you, with a very shallow right coronary sinus that puzzled me, because before the operation, the patient had the competent valve, and I couldn't understand the mechanism, but obviously there must have been an eccentric somehow coaptation. And that was a failure. And the other one was early in our experience. It was underestimated the amount and the excess of the fenestrations, and after the ring that caused more damage. But overall, the 2-year experience with this ring has been excellent. It's, as I said, it's 2 years with regarding the freedom from reoperation, the aortic insufficiency, the gradient, and also the symptoms of initially, when this started, they were, as you can understand, with every new technique, there were more complications, but the last 285 patients, the complications were much less. These are more or less most of the pathologies that somebody can use this ring, even including some congenital cases. And these are the centers worldwide so far. This is up-to-date data, about 360 procedures so far, and they're running quite faster, much faster in USA, where they recruit more and more centers on the East Coast. And of course, it's with a characteristic Tyrone David's a comment saying that somebody, in order to do the aortic valve, has to be a seasoned surgeon, very experienced, has to analyze a few things. But on the other hand, we have a wise dictum by Kirkland saying that an operation to be useful has to be useful in the hands of every surgeon. So it has to be reproducible and simple to do. And I think the case with the ring, it is a simple operation. So it's a simple and effective procedure. Some points include the downsizing of the ring. As you saw before, you have 3 sizes. One of them is larger. You choose the smaller one. The position of low position of those subcommissural sutures and the lateral fixation suture. The selective replacement of sinuses whenever it's necessary and appropriate for the patient. Even in the original trials, the first 81, the results were very good, although it was the beginning of the learning curve. And now that the numbers are increasing with all these techniques, it means that it gets easier in the hands of every surgeon. Thanks very much.
Thank you very much for interesting presentation. We can have one short question, if there are. Yes?
We know that often, most of the time, this aortic regurgitation is associated with root aneurysm in the presentation I just did. So this is most of the time, at least 80% of the time. So what do you think are the real advantages of using the ring plus any sort of root replacement as compared to the simple reimplantation?
I'm afraid I didn't hear anything because the mic goes that way.
Oh,
so the sound is terrible. I didn't hear anything.
So I'm saying, can you hear now?
Yeah.
Okay. Often the aortic regurgitation is associated with root aneurysm. So what, in your opinion, are the real advantages of using this ring plus a root replacement or a straight reimplantation procedure?
Well, it makes your life easier, as you can see, because you don't have to do any dissection during. It's a reproducible technique because everything has been measured. And of course, it's the fact that you're going to use a remodeling technique at the end if you have dilated sinus. I think that makes everything. But the most important thing is you avoid this guessing thing about what size of graft I'm going to use, how I'm going to put my stitches. It's just a reproducible thing. That's in the hand of every surgeon. It's something easy. For you, that you have such a big experience, maybe you find it's very easy to do the techniques that you've been using, their implantation or the modeling. For instance, Joachim Schaefer says, I use 28 grafts for my patients. For most of surgeons, they don't understand. Say, why do you use 28? Say, I use 28 for everybody. So if you've done 2,000 cases like that, you can say that, but it's not for everybody's practice, I think.
Yeah, but still, I think, you are adding a prosthetic material and a lot of suture inside the root compared to the other option. Yes. This is the difference.
Yes, you're right in that sense, but the time will tell. If indeed, after some years, we find out that caused some problems, yes, you're right, but we don't know. It's very early. It's very promising, but it's still 2 or 3 years. We'll see.
Thank you.
I think it should pass on. So.
We have to conclude because I have a lot of questions, but we have to continue.
It's a pleasure having Dr. Torino with us today, the present and the future of coronary artery bypass grafting. Dr. Torino.
Dr. Dahle, Chairman, ladies and gentlemen, having spent more than 49 years in coronary surgery, so I thought I could share with you some of the observations which I made in recent years about the development of the field. I've looked many years ago, I've looked at the growth of the open heart surgery in Zurich, and you can see that the dashed line are all operations with pump oxygenator, and below are aortic and coronary bypass. The exponential growth of heart operations was almost exclusively due to the rise of coronary bypass grafting. And then came my good friend Andreas Grünzig, who died much too early in a stupid airplane crash, which should never have happened. Nobel Prize was already prepared for him, and he really revolutionized modern medicine, one of the biggest developments in the last century, and his coronary dilatation. Now, everybody does PCI, and it's considered an easy procedure. 18, 20 a day are done in the same lab. The first clinical experience, very few people know it, where I looked at this material of the first 95 patients. There were 9 serious complications, close to 10%, necessitating emergency coronary bypass grafting. The patients were taken, some of them under continuous resuscitation from the X-ray lab to the operating room, 2 stories up and continuing resuscitation. I had to open them under resuscitation, put them on bypass. In 2 or 3 of them, the pump oxygenator was not ready yet, and I did, because the patient was stable, I did it off-pump bypass. I never wanted to publish it because I was ashamed of doing it outside of rules. There was no mortality in this. We have learned that these patients, if they are revascularized within 2 hours after onset of infarction, mostly it was an acute dissection or the acute closure of the vessel, they will not have a coronary infarction because of the prompt revascularization. But the PTCA in the beginning was a risky procedure. And now, where we stand now, this is, for instance, in Switzerland, there are, in red, are PCIs, and you can see the continuous rise of the PCIs, and coronary bypass grafting is remaining constant. Presently, in Switzerland, only about 25% of the patients with a coronary artery disease will receive bypass grafting, and the rest as PCI, and probably it will be, the percentage will even change. Looking at this healthcare cost and utilization project statistics, In trends in operating room procedure in the United States, you can see in red that there is a decrease of coronary artery bypass grafting in the United States of 48%. There was also some decrease in green up there in PCI, but decrease in coronary bypass grafting is much more marked, and this is the future. In one of these recent statistics from Israel, it shows, for instance, the PCI-CABG ratio up there. You can see that practically 1 out of 10 gets coronary bypass grafting, and 9 out of 10, close to 9 out of 10, get the PCI. And interesting fact is also there's a huge variability between various centers. Some of them will have 2-to-1 ratio, and some of them will have 9-to-1 or 10-to-1 ratio PCI or CABG, depending on personal preference. One of the reasons for the increase of PCI is, of course, they cost much less, between 30 and 40% less than coronary bypass grafting. This is assessment for this health system tracker. And this is a marked difference. Another not quite explainable fact is the huge difference in the incidence of coronary dilatation, PCI, and coronary bypass grafting among various European countries. You can see, for instance, that in Germany, it's a huge predominance of PCI. There's about 4 times as many as in Switzerland. It's basically the same population. There are no differences. It's not medical reason why there are 4 times as many in Germany. In red is the incidence of coronary bypass grafting, always quoted per 100,000 of population. One of the reasons can be found in this report from Europe, from OECD. When you look at the percentage of PCIs on depending on the payment mortality, you will see that, for instance, in Belgium, in France, the cardiologists are directly paid for PCI, and there is a very high proportion of coronary artery diseases treated by PCI. In the countries like Denmark, Finland, Norway, and Sweden, the cardiologist's income is independent of the number of PCIs, and they have a substantially lower incidence of coronary dilatation. Looking at the statistic of Great Britain, in Society of Cardiac Interventionists in Great Britain, you can see that there is a continuous growth of this in violet marked PCIs and decrease in coronary bypass grafting in yellow. It's interesting also to observe at this point in 2010, new European Society of Cardiology, EACTS guidelines came, which gave strong preference to several situations where coronary bypass grafting is much more adequate. The results of these guidelines is 0. Cardiologists are simply not following them, and the number of PCIs is still increasing. There are some excesses you can find in literature. For instance, I like the title of this report, Oculostenotic Reflex and Iatrogenosis Fulminans. It describes a patient who was asymptomatic, but for some reasons they did a coronary angiography, and they put immediately 2 stents. He was asymptomatic, but they put 2 stents. The stent thrombosis developed 2 times. He had 3 more PCIs and ended with coronary artery bypass grafting. This is the iatrogenosis fulminans. This is another report in JACC showing a patient with 67 stents. And of course, when you see this patient with 67 stents, then the American surgeons call it, from the movie, full metal jacket. It's almost impossible to put anywhere a bypass graft. But the patient, when interviewed, when this paper was published, he said, my doctor saved my life 8 times. And that is the opinion which the patient had. And now you can read in Europe, United States, the excesses are now punishable by law. And you can find it in the newspapers that the Westlake cardiologist got 20 years. The FBI reports that the former Louisiana cardiologist got 10 years. The Salisbury doctor sentenced to federal prison, all excessive PCIs, which the people are protesting now. Still, when you're looking at the market research report, the industry always knows where the future is because they are dealing with money. You can see that the interventional cardiology devices market, for instance, in 2018, in this year, they are more than $7 billion. 7 billion for you non-English speakers is 7 with 9 zeros behind. It is a lot of money. And this is the market for the cardiology devices, and obviously they stress the necessity to use their devices, and that is why so many are put in. And it's interesting that real-life statistic, for instance, this report by Weintraub showing the clear advantage of survival in coronary artery bypass grafting. Even when adjusted with this inverse probability weighting, it is still the better survival after 5 years with bypass grafting than PCI. But still, most of the patients get PCI. This is analysis of 200,000 patients. It's nothing prospective randomized. It's a real life. Bilateral IMA grafting, this is one of my patients 20 years later, is still ideal substitution. And it is first time it was observed in 1986. And for the younger people, it's interesting. This report by Floyd Loop in 1986, it was not a prospective randomized study. There was nothing, selection of the patient. It was just very thorough follow-up of patients who received either a saphenous vein graft on the internal memory artery and much better survival after 10 years with IMA. And the same, this big report from Australia, 51,000, shows a much better long-term survival with IMA than even with the use of radials. The reason is, of course, unclear protective effect of implantation of internal memory artery on the distal coronary circulation. Nobody knows why it is really, but distal coronary vascular bed is sometimes protected after you put the internal memory artery or a radial graft, and you see very low incidence of distal disease. Why doesn't it work in randomized studies? David Taggart started this randomized trial of bilateral versus single internal thoracic artery, and results were surprising for all of us who like to do this surgery. There was no statistical difference in survival between the patients with the bilateral and single graft. But the reason is really to be found in the statistical analysis of it. When you look in a group which were assigned to bilateral graft, and there were crossovers, when you look at, see, out of 1,548 which were assigned to bilateral graft, only 1,531 underwent surgery, and 1,294 received bilateral graft. It is a crossover, and if you analyze them intention to treat, there is no difference. If you analyze them as treated, there is a difference because of crossovers. I was surprised also to read in this market research that in the United States, they still continue to calculate the high growth of saphenous vein implants. Why it is so, I cannot quite explain, but this is the fact how the industry looks like. And what the two new things are to be known, surgeon specialization seems to become more important. This University of Maryland analysis has shown at the red sign, they switched coronary surgery not to every cardiac surgeon, but only specialized coronary surgeons in the team. And the mortality in the group immediately went down. Then it is shown also in literature that the high volume centers have coronary bypass grafting with a low mortality. You will see the crude mortality goes up to 15, close to 15% in some centers, but in the large volume centers to the right, there is a low mortality of about 2%. And the same is also in the United States, surgeon total coronary bypass grafting versus risk-adjusted mortality. It shows that very clear, the more bypasses you do, the better you are. The differences in OPCAP. OPCAP is going to be a small segment, and it probably should be reserved for specialized surgeons. You must have a team, you must have an anesthesiologist who work with you all the time, and then the results are good. Otherwise, surgeons should stay away from OPCAP. Robotic coronary bypass grafting, I do not think it will be a future. Worldwide use of robotic goes down. In Europe, it goes also very much down. So presently, there is no breakthrough there. Hybrid procedures, there are prospective randomized trials, but only smaller studies have been published. And it seems that the classical operation of IMA to LAD and the mini thoracotomy and later by the PCI, this seems to be the best procedure, but the only trial which I have found is the Polish trial, which doesn't show a difference. So for the all younger surgeons who will be now developing the profession after we leave, we should listen to the advice of the Marquis de Talleyrand, who salvaged French territorial integrity after Vienna Congress. And he said the art of statesmanship is to force the inevitable and to expedite its occurrence. We have to insist that the inevitable things do happen fast. So the future of coronary surgery, if I have to summarize, I think the PCI will be standard treatment in a substantial proportion of patients with coronary artery disease. Arterial revascularization and OPCAM will advance, but they will be given in specialized centers which have achieved very good results. I also think that the low volume CABG centers, now there are too many around, they will disappear, and coronary surgery should be done only in specialized centers. And it is also obvious that coronary bypass grafting and combined intervention, what you see now with the valves, should be done in a hybrid operative room with the surgeons and cardiologists working together. Thank you for your attention.
We are already behind time, and thank you, Dr. Torino.
I would like to invite Dr. Adale to share with us his experiences on the subject is catheter treatment and option, aortic regurgitation following treatment of A dissection with supracoronary graft or failed AV plastis.
Thank you for giving me the opportunity to present it. At least I have shortened the title, so I will try to go fast through my presentation also. I tend to speak a bit fast. Okay. So I changed it to transcatheter aortic valves and aortic regurgitation. Well, we have now seen that aortic stenosis patient and aortic regurgitation patients are different types. So we can actually divide the aortic regurgitation patients in two groups, in several groups. It's native regurgitation and it's following surgery. And after David repair, A dissection and other surgery, and also after deteriorated bioprosthesis that leak, it's stented, stentless, and homografts. But we have to remember some of these patients may have a connective tissue disease and may not be suspect for prosthesis in like stents. So we've gone through these guidelines. I just want to emphasize that I think management of aortic regurgitation is difficult, I think, according to guidelines, but Carell had it very clear. It also says, like he says, that the strongest indication for valve surgery is the presence of symptomatic symptoms and a left ventricular diameter below 50% and other and systolic diameter above 50 millimeters. So, and the gaps in the evidence he already went through. So we have challenger in the catheter treatment because these patients have regurgitations, they have no calcium markers, it's big anatomy and no landmarks for sizing. And when you do the procedure, you can have PVL, you have coronary obstruction, more need of pacemakers, and it's a problem to position in the annulus. The alternative catheter treatment valves should be self-expanding with stabilization arches or self-expanding with clipping mechanism, self-expandable and repositionable, and mechanical expandable or balloon expandable. A lot of prostheses are on the market. These used for RR are these. Is the Evolute R, self-expandable. Some of these prostheses are now out, like the Engager, that was very good to use, but it was taken off the market because of too high gradients. The only one that is CE mark is the Jena valve. Before it was transapical, now it's only transfemoral, and you have the Symetis Accurate that is both transapical and transfemoral. The Sapien family, there you have one shot, and often two is needed. And you have the Lotus valve that is mechanical expandable that you can retrieve and resheath, and the direct flow that is out of the market. And now there's also a new kid in town, they say, that is the Jena valve, the Chinese. So far, I don't think it is available in Europe, and it's very similar to the Engager. And it has a transapical delivery. You have also the Meridian valve that I also think is not available in Europe. It's also self-expandable and repositionable and retrievable, and that is the clue with the aortic regurgitation, that it's very good to have a valve that you can reposition and retrieve. Now I will give some examples of some patients that we have treated. We had this patient with pure RR, and we used the Jena valve, transapical, and we see no landmarks in the first picture and sequence, and we take the feelers out and have the tactile feedback and then deploy the valve. If you are doing valve-in-valve and aortic regurgitation, there are also some considerations to think of. The sizing, you always have to rely on the CT reconstruction and not the labeled inner diameter, and not often always the app you can also use, but as Vinny Babat say, you must not rely on that, you must measure yourself. And the cups may not have any calcium, and the tube of for instance, the homograph may be very calcified. And the suturing may dilatate above the annulus, and the true annular plane may also be above the suturing. Another thing to take in consideration is the variety of implant techniques that has to be considered for planning. So now we show the preoperative planning is the clue for it. And here is a preoperative evaluation for a degenerated homograft. As you see, no calcium in the annulus. You have to know the exact level of the coronary cusps. And you can use some fusion imaging or other imaging tools to evaluate the CT. But for this treatment, it can be an option also to use the purse valve. Then you go in, you always have to make a high incision for the purse valve, and you can make these sutures to steer it down, and you have it's easy to position in a degenerated homograft. This is a Symetis Accurate in degenerated homograft also. We did the transapical, and the same thing. You have no landmarks for the annulus level, but we deploy it, and we can have the tactile feedback and have a good implantation. This is the Sapien in freestyle. Same thing, no landmarks. We tried to make an external. We thought we were very clever, but that was not a good idea. So we had to place another valve after the one. So we had valve and valve. Very expensive, but good result. Then we had a patient with a dissection. We normally do supracoronary graft. Initially, it was no aortic regurgitation. 7 years later, the patient presented with regurgitation, and he did not want reduced sternotomy. So we evaluated him, and he found that he could use the Symetis, and it was good result. We had another patient that had also treatment with the supracoronary graft. Initially, good result, or that we ignored the regurgitation at the first operation. Then we did a transapical Engager that is not on the market, but that was the only one we had on the shelf, and no other on the companies wanted to give us the valve because they thought it was a bit strength indication. So we did the engager, and initially good result, but he then had the increase in symptoms after 1 day and VSR, and maybe this was the cause of the regurgitation too, because we saw he had the very high markers for coronary obstruction. But we did observe the patient after 1 month, and then we did the open redo procedure with patch closure of the VSD and kept the valve. So, following David procedure, some technique is the same technique and planning as with homografts, but be aware of coronary reimplantations, high from the annulus, and possibly obstructions. And the graft may be better support for the catheter valve, but be aware that these patients can have connective tissue disease. And personally, I don't have any experience with the David procedure, but we had this huge patient that had ASD, VSD, double outlet, right ventricular transposition of the great arteries and pulmonary atresia. 3 operations before with the GOBT stent, reconstruction ad modum Castelli, and then aortic root ad modum Jacob. He presented with aortic regurgitation with a very dilated aortic annulus, but he had some calcium below for anchoring, so we decided to do some 3D printing and try to plan for a catheter procedure. And we did this with a Sapien valve, transapical access, with a good result. I will go further on in the video. Here we see soon the deployment of the valve. And it functioned very well. I know the patient has, this was in 2015, and the patient has been for follow-up afterwards and was doing very well. Here you can see the first CT scan afterwards. But as I showed in this, the planning of the operation is alpha and omega. So good imaging and planning will give improved results, and we use CT reconstruction, 3D print, and we also started using the HoloLens. So my conclusion is that TAVI and RS is still not recommended unless on special indication. Only one prosthesis has CE approval, and that is Jena. TAVI in RR is challenging but feasible, and the patients with RR are younger and different from the patients with aortic stenosis, and durability has to be addressed, and repair has to be considered instead of replacement. And TAVI in R as redo can be considered in high-risk patients. Thank you very much.
Thank you, Dr. Dahle. Any comments? Any burning questions? Okay, we can move to another paper.
And thank you very much. And I'm calling Dr. Moritz to give us the last speech today. It's about the ROS procedure, this variation in young patients with aortic valvulopathy. Dr. Moritz.
Well, we'll see. Thank you very much for the invitation, and if we get ready. Not yet loaded. Yeah, thank you. Well, I should share our experience with the ROS procedure and the lessons learned and what we can do for young patients. That's correct. There is a major problem in mechanical valve replacement. If you, sorry, yeah. if you do a mechanical valve replacement in a young patient, he has a loss of life expectancy, and this is tapering out with increasing age. So a young person loses easily 10 to 15 years once he wears a mechanical prosthesis. And we know this from the usual curves of survival after mechanical valve replacement. There is a difference in the comparative or the normalized population versus the treated population. And the reason is either underlying disease or the problems of the mechanical valves. Now, this was also proven in the Vienna studies where we compared our original results with the Ross procedure and the propensity-matched population of after mechanical valve replacement, that the autografts had a normal life expectancy. Is there any chance to get this mouse in here? Of life expectancy for the Ross procedure, you know, the green line is the normalized population, age and sex matched, and you have a much higher mortality rate after mechanical valve replacement, so that proved the other experience. Now, when we started out doing the Ross procedure, we were taught this Rotterdam type of supraannular tube replacement, and we found that these tubes very early already dilate to 32 millimeters, and when we did intraannular, the aortic annulus was after the Ross procedure slightly smaller than it was originally, so we were able to reduce the aortic annulus size. And we know very well that we know this from the switch procedures, and we know it from pulmonary hypertension, that the pulmonary wall does not really stand in long term the arterial pressure. So if you don't do anything to reinforce the sinusotubular junction, you will get a progressive increase in new aortic root diameter. If you do it, you can keep it quite stable. There was one reason not to completely reinforce, for us, to completely reinforce the aortic root. This was, there are two studies on pressure increase before and downstream a rigid segment. So if you put in a short piece of prosthesis, you get a higher dPdt downstream and upstream this segment. So this we just saw with a patient after aortic dissection repair, that you get a dilated root, it's a weakened wall, and you have increased stress, so they secondarily dilate. So what we did, we kind of reinforced the root with the original aortic wall and put a resorbable mesh around it. This was the primary thought, to have a kind of flexible support. When we analyzed our first 100 results from the Vienna group, we had the first 100 patients, and we had experienced after 13 years 4 reoperations on the autograft. That's a rate of 0.35% per patient year, and a little higher rate on the right ventricular outflow tract with 7%. It's 0.8% per year. Then we went to a not very good idea. There was always a problem on the right outflow tract with some gradients, and there was a very optimistic study from the Mayo Clinic showing that the bioprosthetic valves had a better performance in the right ventricular outflow tract than the homografts, and so we unfortunately switched to bioprosthesis in the outflow tract. And what we observed was quite a number of strictures, and they usually developed at the lower suture line. Then we put in a Dacron skirt to avoid this. This was described also by Hans Sievers for the homografts. And what we observed then was the development of a distal stenosis. So this rigid segment in the pulmonary outflow tract seems to be a problem, and we finally came back to the homografts. And you see this in a figure. The re-intervention rate or failure rate of the homograft is much less in 15 years than for the prosthetic valves. So this was not a good option for our patients. What we else did very early in the course of our experience is to remodel the aortic root to the new autograft. Very often in the bicuspid root you have an asymmetric root, you have the and you have also the dilated root, so you have to adapt this to the diameter of the autograft to the new root, and this can be done by plication stitches very well. The other problem is in the bicuspid valves that usually the non-coronary sinus is much deeper than the others. So if you put in a regularly sized tricuspid pulmonary autograft in this route, you have to keep up with this height mismatch. We did this that we put in the autograft slightly supraannularly, and we paid for this with pseudoaneurysms developing in this area. And the next slide shows the reasons for reoperation on the autograft. This were, and certainly these are avoidable, so we know now that we should not put the autograft supraannularly without any reinforcement, so these were early reoperations. We had cases of endocarditis, 2 were early. I think they're also avoidable. Structural deterioration or not perfect geometric match was the reason in 4, and late aortic dilatation was another reason in 4 patients to do reoperations. But as you see at the timeline, these were very late reoperations. Now, we did not find any correlation between aortic root dilatation and the type of valve we did surgery on, whether it's bicuspid, tricuspid, if we had valve incompetence or valve stenosis. We didn't find a difference. So in our hands, it didn't make any difference whether the original valve was bicuspid or tricuspid. What we learned from our own David series is that the David patient had a perfect survival, and the reoperation rate or failure rate, that's aortic incompetence grade 2 or larger. So after 10 years about, we had 80% free of these problems. So it's a much lower rate of reoperations or really failing valves. And this was the reasoning to rethink the support of the aortic root. And what we came finally up is a David type of reinforcement. There are many techniques described. What we came up is that we put in 3 subannular sutures to the autograft as we always did it. Then we slip the prosthesis over the autograft and the original aortic annulus remnant, cut out the coronaries, reimplant the coronaries in the autograft, and then we reopen the aortic clamp and fix this sleeve over the usually then ascending aorta, and if necessary we can do coverage of the dilated ascending aorta to not necessarily replace the ascending aorta. Now, for the reoperation cases, we usually found normal aortic valves. We did, in some patients, we did a David type repair, as you see it here. It's a perfect new valve. In some patients, we had to replace the valve because the ventricles were dilated, the patients were elderly, and so we did not go for the longer procedure of repair. Now, the long-term complications, this is our reoperation rate that's very reasonable over the 13 years. The scale is from 100 to 70, so it's around 95% free of reoperation. And we know this from the Dutch-German registry. Once you do not reinforce the sinotubular junction, you have a very high reoperation rate. Once you reinforce it, you're pretty good off. So we had a total of 18 reoperations on the autograft, but only finally 6 valve replacements. We only had 9 embolic events, which were related to atrial fibrillation. That's a low rate of 0.54 per patient year, and 9 events of endocarditis, which is also lower than for mechanical valves, and no, of course, no anticoagulation-related hemorrhage or valve thrombosis. Now, if we compare the valve-related complications For the matched population I showed you primarily, it's also that the total rate of thromboembolic complications was 1.35 per year for the mechanical valves and 0.06 for the Ross procedure. Endocarditis was lower, bleeding was of course nil, and reintervention rate, that's the Achilles heel, was slightly higher. The big advantage is that the Ross groups in most series showed a normal long-term survival. That's the results from Hans Sievers from Lübeck. These were our Frankfurt results. We did a small randomized study, which probably is too small to really get a hard figure on it, but the mechanical survival for the survival curve for the mechanical group was much lower than from the Ross group. And for the Old Vienna group, it was also quite normal compared to a match, an age and sex matched population. So I want to sum up. When respecting certain technical principles, the Ross procedure provides excellent and stable hemodynamics in the long term. Valve-related complications are reduced to reoperations, which are due to conceptual problems in maturity. I think what we have learned now is that we might reduce these reoperations to in maturity. Degenerations of the valves are very rare. The autograft provides a durable biologic valve. Right ventricular outflow tract replacement is a possible long-term problem, but might be cured percutaneously in the future and is much less for homografts than for bioprosthetic valves. And normal long-term survival appears to be the major asset of this technically demanding procedure. Thank you.
Thank you, Dr. Morris, for a wonderful presentation. Are there any questions from the audience? We are a bit late, I think, also. Would you give the closing?
Well, then we have to conclude this session. It's been very interesting to hear all about this aortic regurgitation. It's a very, very difficult topic, I think. But there are new methods coming in, and we will see what happens. Any more comments from me?
It's okay. We have to conclude our session because we are already behind schedule, and we encourage you to attend the next session. Thank you very much for attending. Thank you.
Okay, good evening. I'm Christopher Olympios, and I have the pleasure to chair this session. This is the last round table of the very interesting and very successful Athens Crossroad. The main topic of this round table is what we say the forgotten valve, I mean the tricuspid valve, and other miscellaneous topics. We have the pleasure to have not only very good scientists, but also very good speakers. So it's my pleasure to call to the podium Dr. De Paulis from Italy to present his topic entitled Guidelines for Treatment for Tricuspid Regurgitation. Clear and obvious, Professor Paulis. Hello.
Thank you very much. Now I learn how to do it. Is this one? Should be. Ah, okay. He's coming. Okay, thank you again. For now, we open a different chapter. I will go briefly along the guideline for treatment of tricuspid regurgitation. As you know, this valve is always considered a forgotten valve. Many times there is not too much information about what to do in case of presence or not with tricuspid regurgitation. And this is recently has been a more importance given to this problem. Why there is a question? Because we don't know exactly what are the indications, what have to do, how we should approach this valve, how is it better to do the repair? There is several ways of repairing, use or not of the ring, and what are the outcome? There is not an agreement also regarding the outcome. You will see in. So we went through this guideline. In 2011, we had some guideline from Brazil, then American guideline, European guideline. More or less, they were on the same line. Let's start with the guideline from Brazil. You can see that at the beginning, the first, as a class 1 indication, they put the old patient with a severe tricuspid regurgitation when he associated with any need for surgery on the left side valve, but also in the case of primary high tricuspid regurgitation when it's symptomatic. As class 2A, there is all patients with moderate tricuspid insufficiency associated with dilatation of the tricuspid annulus. So already the presence of dilatation has been considered. So in summary, for isolated tricuspid regurgitation, surgery is always indicated when it's severe, and also when it is associated with the disease of the mitral valve. However, in the moderate tricuspid insufficient with this moderate, you should assess other factors like the dilatation of the valve, the presence of pulmonary hypertension, and sometimes age and etiology. As for the American colleague, again, they consider in class 1 only the presence of severe tricuspid regurgitation. In class 2A, there are all tricuspid with mild, moderate, or functional tricuspid regurgitation, and also they mentioned the tricuspid annular dilatation or prior evidence of heart failure. This is also another important point. It also can be beneficial that those to severe tricuspid regurgitation, they do not respond to the medical therapy. So let's see, the European guideline is more or less in the side, similar to the one the American colleague. Like you see, in case of severe tricuspid regurgitation, we are all in class 1. And in class 2A, every time there is a moderate tricuspid regurgitation associated with annular dilatation. The problem arises in class 2B, in those they have mild or moderate tricuspid regurgitation in absence of annular dilatation when previous recent right heart failure has been documented. Though there is some case where there is a documentation of heart failure even though the annulus is not dilated. And this is somehow controversial. So basically, if we look all together, the amount of indication similar to mitral regurgitation, primary tricuspid regurgitation require intervention sufficiently early to avoid secondary damage to the right ventricle. And secondary tricuspid regurgitation should be liberally treated at the time of the first operation. So we should be more aggressive in any case. Of course, consideration of isolated surgery in case of secondary tricuspid regurgitation after previous site, that is more often the case. We see patients already operation with 1 or 2 operations that come back because of tricuspid regurgitation. In this case, this is a difficult case because it requires a comprehensive assessment of the underlying disease, especially right ventricular function and pulmonary hypertension.
Recently, there has been added a position statement of the European Society of Cardiology exactly on the management of tricuspid valve regurgitation. And so, along with what we already see, since the clinical presentation can change because of the medical therapy, diuretic therapy decrease volume overload and change the clinical presentation of the patient. So in this recent update, they've had the proposition to be more aggressive in case of mild or moderate tricuspid regurgitation every time that there is a recent sign of right heart failure with the pulmonary pressure around 60 millimeters of mercury, or when the tricuspid annulus is dilated over 40 millimeters of mercury. Because this, if we go with this old sentence by Robert Fradier, functional tricuspid insufficiency is the dynamic, it does not respond to medical therapy. So we may have a gross insufficiency, and then after we treat the patient and we arrive on the table, on the operating table, the tricuspid insufficiency has become mild. This is not a mistake, this is somehow is a correct indication. So tricuspid annular dilatation goes 80% on the posterior part of the valve and 40% of the anterior part. And this causes some change. Also is different from the mitral valve. With the mitral valve, with the tricuspid valve, the competence is lost for a 40% dilatation, while for the mitral valve, we need the 75% of dilatation because leaking starts. So the ability to compensate for the tricuspid valve is much less than for the tricuspid valve. What happens every time you have dilatation? You have dilatation of the right ventricle. And on the other side, you have restriction from the left ventricle because the septal shift from the right to the left, and this is caused also increase in pulmonary pressure, pulmonary hypertension that deteriorate furthermore the function of the right ventricle. So in fact, if you look at the valve indication for tricuspid valve, in the year 2000, compared to almost 5,000 indications, there were 1,700 cases of tricuspid regurgitation, and that has been increased with the time. You can see these were 35% associated with mitral valve, and now after 9 years, there were 61%. So the increase in tricuspid treatment has increased much more as the increase in the number of mitral valve repair or treatment. So there is increased awareness of the problem of the tricuspid valve. That's why, because it's important to win the battle even before start. So to program the operation is very much important. However, nobody agreed, and Tyrone David quite recently reported this, the tricuspid regurgitation was uncommon after mitral valve repair for degenerative disease, reporting that the annuloplasty was needed, in this case, it's 37% of the time in this publication, 7% in the next one. And also because he reported the survival in case of you did or you did not treat the mitral valve was not different. So if you see the hazard ratio comparing C and B, meaning the tricuspid regurgitation without annuloplasty or with annuloplasty, the hazard ratio was not different as compared to the survival. But of course, the results are different if you have presence of tricuspid regurgitation. So if you have the no preoperative tricuspid regurgitation after 15 years after the operation of the mitral valve, you have 11.5% of incidence of residual important tricuspid regurgitation, while this is almost 70% if you didn't treat the tricuspid, the presence of tricuspid regurgitation at the time of the first operation, and only 3% if this has been treated. So severe tricuspid regurgitation needs to be treated, but he said that it's not related to the dilatation of the annulus. This was the title of this manuscript, say tricuspid annulus diameter do not predict the development of tricuspid regurgitation. So this goes in opposite direction where most of the literature went in this. That's why this was an editorial, was a prophylactic tricuspid repair. Should we do or should not we do? And that's why is now there is an ongoing, let's see, this is an ongoing randomized trial just to try to understand, in case of simple dilatation of the annulus, if it's necessary or not to replace the valve. The one we introduced the importance of tricuspid dilatation was Dreyfus, that showed that a measurement of the 7 centimeter intraoperative that correspond to 40 millimeter as echocardiography is when, at the moment where you have to do no matter if the valve is leaking or not. So, of course, we need to do some special consideration for tricuspid regurgitation because the pathophysiology is complex. It is certainly influenced by the loading condition. That's why we can have several clinical situations depending on the loading condition. So I think we should still base our judgment on tricuspid annual diameter rather than intraoperative assessment. So the degree of tricuspid regurgitation is probably less important, despite what some of the manuscripts are saying. So in conclusion, in case of primary tricuspid regurgitation, what you should do? Surgery is limited to the tricuspid valve is recommended in symptomatic patients with severe primary tricuspid regurgitation. But all asymptomatic patients should be looked closely for any signs of progressive RV enlargement or RV dysfunction. Otherwise, it's too late for a proper treatment. And when it's functionally, it's indicated in patients with severe tricuspid regurgitation, but we should be more aggressive even in case of mild or moderate or in case of dilated aortic annulus. But especially in patients with prior recent right heart failure, because one episode of right heart failure is very important as to give an indication early enough for this patient. So the message is, please do not forget the tricuspid valve. Thank you very much.
Thank you very much, Dr. Paulis, for your presentation. Very comprehensive. Are there any questions from the audience, please? Thank you very much again.
Thank you.
The next speaker does not need any further presentation. I will ask Professor Calafiore to present his speech, Surgical Options in the Adult. Professor Calafiore.
Μία σύντομη ενημέρωση, ψηφοφορία λίγη σε μισή ώρα ζήτησε να ανακοινώσουμε ο γραμματέας.
Good afternoon. In patients with mitral valve disease, functional tricuspid regurgitation follows on increased chordal tethering due to any grade of pulmonary artery hypertension. The increase of the pulmonary artery pressure causes changes in right ventricular geometry with the enlargement of its mid-cavity diameter, displacement of the papillary muscle, and increase of the tethering height of the leaflets. As a second step, the basal diameter increases as well as the tricuspid annular size and the tricuspid area. The results of the study are coming from the evaluation of an experience that I had in Riyadh in Prince Sultan Cardiac Center from May 2009 to December 2015. During this time frame, 688 patients underwent tricuspid repair on inactive tricuspid valve for functional tricuspid regurgitation secondary to mitral valve disease. 423 patients underwent a follow-up echocardiography after a median of 35 months with a minimum of 6 months. Residual or recurrent FTR was defined as a presence of FTR moderate or more at discharge or at follow-up echocardiogram. The right ventricle was defined as dilated when the basal diameter was more than 41 millimeter and or mid-cavity diameter was more than 35 millimeter. This is according to the recommendation of the American Society of Echocardiography and the European Association of Cardiovascular Imaging. You see here that at discharge, 12.8% of the patient had moderate or more tricuspid regurgitation. This was by far less than preoperative, 83.5%, but still some patient more than we perhaps could expect. The preoperative functional tricuspid regurgitation grade was a risk factor of residual FTR at discharge. You can see here that when the TR was, functional TR was mild, residual FTR at discharge was 1.4%. When moderate, rose to 8.6%. but when was severe, went up to 27.3%. The preoperative right ventricular dimensions were higher in patients who had functional tricuspid regurgitation at discharge. The basal diameter was 44.6 versus 41.8, with a cut point of more than 43 millimeter, just to divide the patient with a high possibility of FTR at discharge. The mid-cavity diameter was 40 millimeter more or less versus 37 millimeter, with a cut point of more than 36 millimeter, just to evaluate the possibility of a higher residual FTR at discharge. Evaluating the tricuspid valve apparatus remodeling, we had some other cut points. The tricuspid annulus was 40 millimeter or higher, for a higher possibility of FTR at discharge. The coaptation depth was 6.5 millimeter or higher, and the tenting area 0.85 centimeters square or higher. In the follow-up, so more or less after a mean of 36 months, we see that the FTR moderate or more, that the discharge was 12.8%, went up to 20.1%. You can see here that the presence of FTR moderate or severe at the discharge was anyway a huge risk factor for FTR at the discharge at the follow-up. You see here that we had 81.1% if they at discharge was no mild FTR versus 41.4% if FTR was moderate or severe at the discharge. The diameter of the right ventricle was again a risk factor. The preoperative right ventricle, if normal, had the possibility of FTR at follow-up of 6.8% versus 28.5% if dilated. But even the postoperative right ventricular diameter was significant. We had, if there was in the normal range, the possibility to have FTR at the follow-up was 11.3% versus 37.1% if the right ventricle was dilated. Then, in general, severe FTR before surgery, right ventricular dilatation, and the TV remodeling are then the greatest surgical challenges as risk factors for moderate or more FTR at discharge and at follow-up. In this patient, annuloplasty alone can be not successful. Alternative surgical strategies have to be considered. We just summarize some of them. We see here the technique proposed by Dreyfus, patch augmentation of the anterior leaflet. You can see here with the ring, and this was just done to reduce the tethering height of the tricuspid regurgitation, or the tricuspid valve, sorry. And another technique is the Clover technique that was described by the Bonis and co-worker, where the tricuspid valve was joined together just to, was a different way of the Alfieri stitch for the tricuspid valve. And this is just a patient when we did the Clover technique that I must say had a very good result with a very minimal gradient. That was, so it can be in selected cases, one of a technique that can be done successfully. What we did, we just changed a little bit the things because in Saudi Arabia we had a lot of patients with a very huge right ventricle. So let us say for late presentation. Here you can see what we are proposing in this patient, what we call full orifice patching without annuloplasty. So basically what we do, we disconnect 50% of the tricuspid valve. As you can see, that means most of the anterior and the posterior leaflet close till the commissure. Again, we cut the second order cords for two reasons. First of all, if you do not cut the second order cords, the possibility of the leaflets to go toward the septal are limited by the second order cords. And second, in this patient, the second order cords can have a tethering effect that is very clear. As you can see here, you look at the second order cords, so these are most likely anterior leaflets, you see how tense they are and how they are limiting the movement of the anterior leaflet itself. But this is just a picture I took from the literature. You see here, if you do not cut the second order cords, the patch is going toward the right atrium, not all the leaflet is going toward the septum. So this, I think, is a technical mistake that has not to be done. So cutting the second order cords is really very important. Later on, basically, you take a patch, the pericardial patch that you see here in place, that is as large as the orifice of the tricuspid valve. And this is what is how the tricuspid appears at the end of the procedure. We do not perform an annuloplasty, as the approximation of the anterior-posterior annulus to the septum will increase the tethering of the cords of the anterior papillary muscle. So basically, we eliminate any possibility of an annuloplasty and we leave alone the annulus of the tricuspid valve. I want to show you here there is a patient who had a severe TR. You see that the right ventricle was bigger than the left ventricle. So this was the postoperative control, and you see here that the patch was just this one, is covering most of the part of the tricuspid orifice. And this patient had a really very good result because she had a very huge ventricle, and this is a big limit that we have when you are performing only an annuloplasty. Based on these possibilities, we are trying to build an algorithm to treat patients with a severe functional tricuspid regurgitation. We have a patient where the base and the mid cavity are not dilated, but we are mostly focused not on the basal diameter, but on the mid cavity diameter, because I think the base is not a big problem. Only when you have the mid cavity dilated, the problem is there. So if it's normal, so less than 36 millimeter, you can do annuloplasty alone, except isolated cases when you have a coaptation that is more than 6.5, that is very rare to happen. And we notice in this patient the possibility to have FTR, recurrent FTR, the follow-up, are really 8.5%, that are more acceptable. But when you have the mid cavity that is higher than 36, but we found this cut point less than 41, so it means it is dilated, but not such importantly dilated, but not normal. Annuloplasty is good, but you must do something more. Either clover or you patch the anterior leaflet, just to have the possibility to cover the orifice. And in these cases, if you do annuloplasty alone, the possibility to have a recurrent FTR, the follow-up is 25.2%. But in patients when you have the dilation of the right ventricle more than 41 millimeter, honestly, your possibilities are very limited. What in this patient, what I am doing is I just put a huge patch in the, as huge as the tricuspid orifice, and I don't do any annuloplasty. This means that the ventricle will adapt to the situation, even if sometimes you have not zero residual FTR immediately, you can have a mild to moderate. After a few weeks, it goes down because the ventricle adapts better. It goes down to mild or it disappears because it is an ongoing process. So my suggestion is not to put any annuloplasty in these cases. In this subgroup of patients, if you are doing only annuloplasty, you have a possibility of 37.5% of recurrence of functional tricuspid regurgitation at the follow-up. We are using this, we started to use this, and we have not only a small group of patients, but in Italy are not as huge, the number is not as huge as I find in Riyadh. But you have 71% where it was done, they isolated the tricuspid annuloplasty, the remaining was done something different. Mostly, as you see, as a full orifice patching for patient versus the other possibility technique. Isolated tricuspid annuloplasty is enough in around 70% of our patients. In the remaining 30%, other techniques have to be considered. Of course, each surgeon can choose his own strategy, but remember that tricuspid annuloplasty is not enough in at least 1/3 of our patients. Thank you for your attention.
Thank you very much, Professor Calafiori. Any questions from the audience? Dr. Panhellenic, please.
Antonio, thank you very much for the presentation, excellent presentation. You clearly presented that in cases of severe right ventricular remodeling, just an annuloplasty is not enough, okay? we should do something else. The problem with this, and try to compare it with the mitral valve surgery, is that in cases of severe remodeling, we know from the left heart that we should do something to prevent or to enforce the leaflet procedure with an annuloplasty. Your concept is quite the opposite. In case of severe annular dilatation, so severe remodeling of the right ventricle, you don't do anything as anti-remodeling procedure. You just put a patch. And the second is, why don't you add the septalization of the anterior papillary muscle as an anti-tending procedure?
Just starting for the first question, I think that the mitral valve and tricuspid valve are totally, completely different, because the mitral valve, you have the possibility, even if you put a huge patch in the mitral valve, you will never be able to put a patch as huge as you're putting in the tricuspid valve. In the tricuspid valve, I am putting a patch and I know that I am covering everything and I'm pushing what is remaining toward the septal. So I can have an effect that is not increasing any tethering, as it happens if I put a ring. Remember another thing, that the tricuspid dilatation by itself is not very dangerous. If you have only tricuspid dilatation, as you have sometimes in patients with atrial fibrillation, you have never the same tricuspid regurgitation grade that you have with the same area but with the tethering. So what is important is the tethering. And in this case, we have not a lot of things we can do. In mitral functional mitral regurgitation, often, of course, when I reduce, often I put a patch on the anterior leaflet to increase the length of the anterior leaflet. But this, you can increase this length of 1 centimeter, 12 millimeter, but not as big as you can do in the tricuspid valve. This is the first point. You know, there are many techniques now are describing what to do, septalization or this or that. Personally, I think when you have a ventricle that is very big, that is, most of them don't move a lot. So putting something that is a little bit unpredictable, because you can do anything you want below, but at the end, the result is unpredictable, because you don't know always the right position of the papillary muscle has to be. I think you must work what you have. You have a bad ventricle, huge dilated ventricle, you have a great tethering, and you have to do something. If you put a ring, anything, or a band, anything you are doing, you are increasing the tethering. So at the end, anything you are doing, you are counteracting with a maneuver that is worsening. So what I decided to do, because I had many patients like this in Saudi Arabia, I just decided to put a huge patch and to see what happened. And believe me, the results are very good, because you are not touching and living in the nature. You cannot change a bad right ventricle dilated hypokinetic. You can just palliate it, just hoping that it can recover. Most of them will not recover. Some of them will recover, but you cannot push too much this kind of patients.
Any other question? Thank you very much, Professor Calafiore. Professor Calafiore explained to us what surgery can do in case of tricuspid insufficiency. Let's see now what can catheters do in these cases. I call to the podium Dr. Daly from Norway to present his topic, transcatheter treatment options. Dr. Daly.
Okay, I'll use this then. Thank you for the invitation. I think the main thing here is to think like a surgeon and to realize that sometimes it's too late to do anything. So it is the forgotten valve, we know, but there are a lot of articles coming up. And if you Google it, there's also a lot of findings. So we have to, but we have to know that the mortality and tricuspid regurgitation is increasing. This is big. And what to do? So we have also, like Calafiore said, the tricuspid is not like the mitral. It's totally different. It's more circular, planar, elastic, 3 leaflets, more clefts, more variable, and more difficult visualization for the catheter treatment, and underestimating of the severity. And we have to look at the tricuspid like not the forgotten valve, but the more complex valve. And the guidelines, like the Paulus said, is not totally clear. Much evidence-C. And you also have to remember that there is a fluctuation in TR in response to fluid load and medical therapy, so it's not always that you see the TR. So, and the etiology of the TR is primary, 25%, and secondary in 75%. And the TR primary can be endocarditis, Epstein, carcinoid, pacemaker leads for most, and also blunt trauma. For the secondary TR, it's 3 phases. And I will go into each of them very briefly. We have a phase 1, annular dilatation, and it's the free wall that dilates, and not always regurgitation. And as we know, if you have a circle, for the same perimeter, you have a bigger area for a circle than an ellipse. So then you have failure in leaflet coaptation, and most often TR, and if annulus diameter is more than 40 millimeter on echo, an annuloplasty is recommended for most cases. And you have volume overload and pulmonary hypertension. And then you have the phase 3, tethering of leaflets, severe TR, and maybe this is too late. So why haven't there been done any catheter treatment before? It's because we think that TR is not so important, and if you fix the mitral, it will go away, and yeah, it doesn't make any difference. But that is because the lack of transcatheter options, and they haven't been found a really good one, and I still don't know if there is really one good one. But when you have to decide for catheter treatment, you have to think of, is this a treatment of previous surgery with annuloplasty ring or annuloplasty or valve replacement, or if you have a native regurgitation and concomitant MR. And there are different access routes. There are transfemoral, transjugular, and transatrial. And as mentioned, we have a lot of surgical treatment options, and the same is for the catheter treatment. You have the direct suture annuloplasty, direct ring annuloplasty, coaptation, and valve replacement. I will briefly just mention some of these, but what's important to know is that the staging is important, and you have to also think of what kind of pathology is behind it. And this is why I say you have to think surgically, and you have to know when enough is enough. So these are some studies going on with different devices. It's a huge area of for the industry, but they're struggling to find the best solution, because I don't think if you have a solution for the mitral, you can use it for the tricuspid. As I mentioned, it's a different anatomy. And there is a tricuspid tribal registry that Taramaso has in Zurich, that he collects all cases done, and most is by the mitral clip. But we also have other, why won't it go further? Is it because it's, okay. Yeah. So you have this mitraling that mimics a modified K. This is a transjugular approach and can be done. You also have this MIA, micro-interventional device, that is transfemoral device, and you have a series of myoplast implants that deployed, and then you kind of strengthen them. Then there is the tricuspid, the cardioband for tricuspid. It's used in the mitral several times, and you can adjust the delivery, so you can also use it for the tricuspid. It's a transfemoral approach, but the thing is that you have to remember that the tricuspid is bigger than the mitral, so the band can be too short. And here is an example of how you see it on the fluoroscopy. You also have this new thing, this iris millipede system that is transfemoral approach and was bought by Boston for a huge amount of money. You go transfemoral and you have a kind of a attachment using screws, and then you can just tighten it and get rid of the regurgitation, and it is used concomitant with mitral, also in the mitral, and was good result for this patient. I only see one with that. Then we have something that I think is very strange, the TRAP, the transarterial intrapericardial tracheal spondyloplast. I don't believe so very much in this, and I don't think it's done in men. You kind of have something outside the ventricle and just going to tighten it, so the regurgitation will be smaller. Then you have the mitral clip that is mostly used, and now you have two mitral clip. You also have the mitral clip XT that has a bigger grasper, and I think maybe this could be better, but this can also cause rupture, I think, of the leaflets. And it's the Pascal device that mimics the tricusp, but it has a spacer in addition. Maybe that could help. This is also delivered transfemoral. And you have the Forma device that is also a kind of a spacer that you put into the mitral, now the tricusp. You go transjugular, and then you now via the subclavian, and then you have a rail that you fasten in the ventricle, and after that you place a kind of balloon that will take some space in the annulus, and then should theoretically stop the regurgitation. There's a lot of things in the heart, so I think that could maybe cause thrombosis, but they say no. We have the Fortec that has been in several generations. That is a coil system that, and you have a stent in the cava inferior, and then you can kind of support the cinching system. But the problem here is that the stent may be too small because the cava inferior tend to be very big in the regurgitation of the tricusp. Then you have the cava valves. That I think looks very promising, but then you have one valve in the inferior and one in the superior. There has been used the Sapien valves, and you have also this special design for inferior and superior cava. Here you can see them. They are in different sizes. The 43 for the inferior and the 38 for the superior. And then there is a new thing, that is a Tricento device that kind of combine a superior and inferior stent, and then have an opening for the tricusp. That is actually done in Switzerland. And you have the Navigate, very big delivery system. You go transatrial and deliver it, and you can also go transfemoral, but the valve is very big and the system is big. Like I showed here, and you can go transjugular. But then there is a bit problem with the coaxiality. So I think the best to deliver this is right atrial access. I have not any personal experience with this, but I had done a transatrial valve-in-valve for a tricusp stenosis, and then we also did the pulmonary valve concomitant, and we started with that and continued with the tricusp. So we are any closer to the conclusion, I think, about the tricusp catheter devices. The right ventricular failure may not be treated by eliminating the tricusp regurgitation, and timing of intervention, I think, is the most crucial. And catheter treatment might be an option in redo situation and some other situation, but I don't think there is any very good specific device. So I think, as is mentioned before, the solution is to be more aggressive in treating TR in early stage and in the first procedure. Thank you.
Okay, are there any questions? Thank you for your excellent speech, and I would like, it's an honor and pleasure for me to introduce Professor Anastasiadis, who is the founder of Minimal Invasive Corporal Technologies International Society. to answer the question whether this technology represents an evolution or a revolution in perfusion.
Thank you, Mr. Chairman. At first, I would like to say that I'm a bit disappointed to see that such a technology or such a topic that's supposed to answer a question if this is revolution or evolution is included in a session called Others, whatever has all the neglected valves as a tricuspid, as we said before, and all the rest that have been categorized. And we include perfusion in this. And this is why we still have the problem in our results. And we try to go from excellent to perfect in our surgical techniques, trying to modify some stitching, and then we say we still have morbidity, as I will present to you. But to, let's say, confess, whenever I go to congresses, especially in the United States, and I ask, do you know about minimally invasive extracorporeal circulation? Majority says no. So if it's something rare, irrelevant to cardiac surgery, or let's say we have the gold standard and don't need to talk about this, then I would be good. But if the answer is no to all three, then we have to go for a thorough insight to physiology and try to integrate it to our practice, and then we will find why there is a problem. So for the last 50 years, from the Gibbon's years when the CPB the contemporary CPB was developed, we needed 50 years to go to another circuit, which is the minimally invasive extracorporeal circuit, and you see these two patterns are similar. So these 50 years, a lot of development has been integrated into the systems, and we do have now, as you see in the lower slide, very good and modern devices in the CPB. However, this resembles to me the history of the phone when we switched to the mobile phone recently, and the last 10 years we are now having, instead of a mobile phone, a smartphone, which is literally a PC, a portable PC, which integrates a PDA, a camera, and MP3 player, many more. That means that this is completely different technology from what was 10 years ago. And the same applies to MIEC, to minimal invasive extracorporeal circulation, because the systems we have now, as you see, are fourth generation systems. So type 4 systems are modular hybrid systems and are completely different from where we started. So is it necessary, all this? I mean, my introduction was a bit aggressive, but let's see if it needs to be like this. Look at this contemporary data from the STS, which is the biggest database in the world in cardiac surgery, and see what is in the complex cases, what's the morbidity, mortality in each category. And you see you have 4 to 10% problem to each of these categories. So there is a problem. And as I've already mentioned, what we mean as surgeons, recent advancement, we mean surgical techniques. So I would say that this is fair enough for us. But if you see this picture, half of the picture that we operate, it's a classical picture, is perfusion. So I'm surprised why we neglect this part, which MIEC occupies. And if we go further, we see that just in the left, in the right bottom corner, there's the anesthesia, the anesthesiologist, which plays a part. And if we go in and see their results, you see that they affect a lot our results, because anesthesia is really a risk factor for surgery, for cardiac surgery. So when MIECTIS, as the chairman said already, has been founded, the reason was that we needed to unite all these centers that have been practicing minimal invasive extracorporeal circulation, and we formed a multidisciplinary society, as you said, comprising anesthesiologists, perfusionists, as well as surgeons. So first of all, MIECTIS
characterized MEAC as a system, because before that there would be dispersed in the clinical practice a lot of custom-made devices and minimized circuits that are not MEAC themselves. The major difference between MEAC and conventional CPB is, as you see, the absence of the open reservoir. That means this is a closed circuit, and that makes the big difference. The other major issue that MEAC is stated is that MEAC represents a strategy, and for this reason teamwork is mandatory. So it's not just a circuit, it's not just for the perfusionists, but it's something bigger. As you see, it's a system, and if you go out and include everything, then you may find the strategy as I will present you. So this is a procedure, literally, and it's a multidisciplinary procedure. So why MEAC is different from the conventional CPB? As you see here, the rationale, throughout the CPB period, MEAC, which is with red, produces much better mean pressures with lower flow, and that goes with much less inotropes. So this can be translated in the microcirculation with less hypoperfusion, because the patient is less hemodiluted, and with faster recovery of microvascular perfusion when we operate on MEAC. Is there a clinical evidence from this? Because that was physiology. Yes. So far, as you see, we have class 1 level of evidence A favoring MEAC systems regarding hematocrit and RBC transfusion, myocardial protection, renal function, and atrial fibrillation. But we have also class 2A level of evidence B favoring MEAC regarding inflammatory response of the patient, brain function and stroke, and other end organ function like lung, liver, and intestine as well. So if this is the evidence, do we have it in the guidelines? Yes. From last year, as you see, the joint EACTS and the ACTA guidelines have already integrated MEAC as a strategy into the intraoperative maintenance of hemostasis and minimizing blood loss and reducing RBC transfusion. So it is already in the guidelines. However, if you go and see all the rest of the literature and try to see the meta-analysis or the randomized control trials, the biggest one indicates that there is not just morbidity benefit using MEAC system, but also mortality. And as you see, it's very strong because all the trials are on the same axis. So this is consistency and reliability from statistical point of view. And then we go and see which is the biggest network meta-analysis, 22,700 cases. You see that MEAC is even better from OPCAP. So if you say that OPCAP is physiologic because you don't use the pump, MEAC is even better regarding morbidity and mortality, as you see here, very hard endpoints. And if you see the meta-analysis regarding this, it's very comparable, and it's even a bit better from OPCAP because it definitely preserves, maintains patient perfusion throughout the case much better from the OPCAP. So if this is the literature, we should go and see what's going on in the real world, and this is why we have already started this COMICS trial, which has two cohorts. One is conventional and the other one is MEAC systems, and we have 3,500 cases allocated into two cohorts, and 31 centers have been already participating, started to participate. The trial has started 6 months ago, and we believe that we will have results in 4 years' time. So I've already said that this is not just a circuit, it's strategy. And what I mean strategies means that we need GDP, as we see here, spectroscopy, and of course you have to integrate all this in a practice as we've already published. This is our practice, and including point-of-care coagulation, heparin protamine, and blood management. And this is why, as you see here, just using the strategy with the same systems, we have better results regarding stroke, acute kidney injury, and intraoperative red blood cell transfusion, as well as bleeding and preservation of platelet function postoperatively. So if you put all these together, you see that we form a goal-directed cardiac surgery on the base of MEAC system, and this is really multidisciplinary, and this is why we say that operating on MEAC, what we have is we operate in a more physiologic perfusion. And is this for everything? Yes, it is going for all cardiac surgery, but if you want to see which is the maximum benefit is that you have early extubation just because MIEC creates conditions as off-pump surgery, and in high-risk cases, it's absolutely mandatory. When I say high risk, I mean low ejection fraction, elderly people, and a lot of comorbidities, because optimizes the patient outcome. And we shouldn't forget that MIEC also optimizes quality of life and improves it postoperatively. So, to conclude, it's obvious nowadays with all this research that has been going on the last 15 years that MIEC improves and organ perfusion and microcirculation is benefited. That's why we say MIEC equals better perfusion, and it has a result, a more physiologic perfusion, which is mandatory nowadays. And if you put that MIEC not just as a circuit, but as you see here, system and strategy, as I've already mentioned to you, that makes a therapy regarding patient care. And you shouldn't forget that therapy is our goal. So, to conclude and answer the question, this question that has been asked to me, it's already in the literature from the first initiation of the systems in the practice, and we've already answered some years ago that minimally invasive extracorporeal circulation is a revolutionary evolution in perfusion. Thank you very much.
Thank you very much for your excellent presentation. And any questions from the audience?
Just one clarification, Professor Anastasiadis.
Yeah.
The choice of the topics included in this roundtable is not the responsibility of the
Oh, yeah, absolutely. No, it was a figure of speech just to emphasize how significant perfusion should be to all cardiac surgeons, because we really don't mind that our practice is depending on perfusion, and we just try to improve the results. So to me, perfusion is very, very, very important.
In this way, we agree.
Any other question? Thank you very much. Okay. We move on to the next presentation, intra-left ventricular double patch closure for VSD. Professor Takamura from Japan.
Thank you, Chairman. This is my second visit to Athens after the honeymoon. Okay. Recently, the number of the cases of the VSP after MY is decreasing. In Japan, there are only 300 cases whole in Japan. So it means the experience, but also the mortality is very high, around 30%. So there are many variety of the procedure for the treatment for the VSP. Dajet, David, Comeda, and also the approach is the left ventricular and right ventricular. And we're using the single patch or double patch. So today, I want to show my technique using the modified procedure from the left ventricular and using the double patch and also the bioglue. So this procedure, the advantage of this procedure is no touch for the necrotic tissues, and very simple technique using the landing suture. Just one case presentation, 68-year male, suffered from chest pain, and he was diagnosed with the AMI, and he underwent the emergent CAG and the PCI for the LAD. But 7 days after AMI, systolic murmur was detected, and the UCG showed the ventricular septal rupture. So this is the CAG at the MI, LAD was totally occluded, and this is, sorry. This is just after the PCI, and there's no disease in the right coronary. And 7 days ago, the patient was referred to our hospital. And the TTE showed leakage between the left ventricle to the right ventricle, just close to the apex. And the QP per QS was 2.6. So we did the emergent operation. So this is just short video clip. So with just one graft to the obtuse marginal branch using the saphenous vein. So this is the anterior of the left ventricle. The wall was very thin, and open the left ventricle. The part was a little bit necrotic. And putting the sutures, so we can see the hole on the septum. Still, the lung tissue was necrotic. So I decided to put the double patch using the lung suture, so using the pericardium. So first, I put a 4-fluorine suture with a running suture, putting the needle on the healthy tissue and to the pericardium. And you can see it's very easy technique to suture between the pericardium and the healthy left ventricle. So the pericardium is going up, going out from the left ventricle, and then I put second patch, just similarly using the 4-fluorine running suture, just next to the previous pericardium patch. So my point is that I used bioglue just on the suture line of double patch, not on the whole space of the patches. Because there's some leakage, there's some risk of the leakage on the suture line because there's some trabecula on in the left ventricle. So I want just to seal the suture line of double patch. So putting the gauze, as you can see, I just put a bioglue just on the suture line of double patch. So after that, I close the left ventricle using the telephone felt as the usual manner. So this is the completion of the operation. So far, I did 10 cases for the anterior infarction and the VSP. So all patients are alive, survived, and there's no leakage. This is the postoperative echo showing that no ligand shunt between the left ventricle to the right ventricle. So this we reported the case of the ventricular septal rupture and went intra-left ventricular side double patch closure. Thank you very much for the attention.
Thank you, Professor Takemura, for the excellent presentation. And is there any questions?
May I ask you, if you had a posterior VSD, would you use the same technique?
It's a very difficult case. So it is for the anterior. I use right ventricular approach double patch sometimes. So it depends on the situation. It's very simple for the atrial infection. Okay. Thank you very much.
The next presentation is from Andreas Kaladzis from Germany. He is monitoring of coagulation using the viscoelastometry for the management of bleeding value algorithms and new developments.
Ευχαριστώ πολύ. So, ladies and gentlemen, when I have my slide, I will start. That's good. Yeah, this is my disclosures. I've been in our working group in Munich, Germany. We have been quite active in this field for more than 20 years. So, the topic is about acute bleeding during surgery. And we all know that bleeding enhances transfusion requirements, prolongs the surgery, can, as we heard already also, impair the outcome, can cause surgical explorations, prolong the ICU stay, and of course makes overall surgery more difficult due to the poor visibility of the surgical field. There also is a number of publications that have shown that transfusion in general and bleeding in particular is related to adverse outcomes. This is just as an example, a retrospective study from Milan with more than 16,000 patients, which studied the association of anemia, bleeding, transfusion with clinical complications and 30-day mortality. And we can see the significant correlation with, of major bleeding with mortality and all kind of undesired side effects like longer intensive care unit stay, stroke, myocardial infarction, and so on. And the authors concluded that major bleeding is a modifiable risk factor, at least in part, and adequate preemptive and treatment strategies should be applied to limit this event. Today we have a number of therapeutic options in the situation of bleeding. And of course what is visible is that we have significant, oops, I'm sorry for that. We have high differences in costs, and of course, totally different treatment modalities that we use. So if, for example, patient is bleeding because of a fibrinolysis, then of course, application of platelets will not help. And this is, of course, leading directly to the question, what to do, how much, how often. And on the other hand, if unnecessary transfusions are given, this not only increases costs, but is also associated with risks. One of the problems we face here is, on the one hand, that the coagulation laboratory analysis often takes too long in order to wait with the therapy to get the results. But on the other hand, also a low predictivity of standard coagulation tests in acquired coagulopathy. So there is a number of studies which has evaluated the predictivity of PT, APTT, fibrinogen cell count towards bleeding complications, and which have found a limited predictivity. This is, for example, also review analysis which has analyzed the available randomized controlled studies in terms of the coagulation lab towards the evidence for the management for perioperative bleeding. If we look in the current European guideline on the management of major bleeding and coagulopathy following trauma, we see here the recommendation that resuscitation of bleeding measures should be continued using a goal-directed approach, guided by standard laboratory coagulation values and or viscoelastic tests. This brings us directly to the question, what does that mean, viscoelastic tests? What this is about is an assessment of the coagulation process by the continuous measurement of blood clot firmness, so of the mechanical quality of the clot. So these is methods that are used under the name thromboelastography or thromboelastometry. So I think in Greece, for example, most popular the Rotem analyzer, Rotem Delta or the Rotem Sigma, the automated version. Then we have the TEC systems by Haemonetics. We have a new system by Hemosonics called the Quantra. And from our working group in Munich, a new system called the Clot Pro. So what's about viscoelastometry? If we look once again into coagulation analysis in the PT, APTT or other tests, then first of all, this is analysis in plasma. The coagulation is activated and with the fiber information, the test stops. In the use of viscoelastometry, we analyze the process of also platelet activation, clot polymerization, down to the process of fibrinolysis. This whole measurement is summarized in a curve, is optically shown in this curve, which detects the coagulation activation, the clot firmness, and the clot stability or fibrinolysis. Just as an example, actually from my own practice about 20 years ago, on the use of viscoelastometry on liver transplantation. Here was one operation where, as you can see, the major problem was impaired stability of the blood clot. And these patients, if not treated with antifibrinolytic agents, continue to bleed, will not stop bleeding if you give other things like platelets or FFPs or concentrates. And he was treated effectively by antifibrinolytic treatment 2 times. While in a second operation, without the use of routine antifibrinolytic treatment, different therapy was needed, which was also given in a targeted manner. There are different assays with viscoelastometry, so similar as if when you run the coagulation monitoring in the lab, you can run different assays, which will, for example, give you a rapid overview over the coagulation process, or will give you an information on the fibrin clot. There are tests which are sensitive to heparin or factor VIII. Again, on our new system, we have also assays which are sensitive to the effect of tranexamic acid, here the TPA test, or for the new oral anticoagulants. So basically, as an overview, there are different assays available evaluating different aspects of the coagulation system. And in the meantime, there are various published algorithms, treatment algorithms, here, for example, from a group in Geneva, which in a more or less similar way evaluate step by step the coagulation system and lead to an application depending on the cause of the bleeding of coagulation factors, platelets, fibrinogen concentrate, or antifibrinolytics. There is an increasing amount of literature on the success or the usefulness of these kind of strategies. This is, for example, a publication from anesthesiology from a couple of years ago, which was a randomized study testing patients either undergoing point-of-care testing of coagulation or conventional strategies of coagulation management, studying cardiac surgery. And there was an algorithm on both sides, so based on the conventional coagulation tests, different therapeutic consequences were taken, or based on the point-of-care tests. And what was seen was that the blood loss, the postoperative chest tube blood loss was lower in the point-of-care group, and also the costs, the transfusion costs per patient were significantly lower in the point-of-care group. So the ideal result with the use of viscoelastometry in surgery is, of course, less costs due to the less overall transfusions combined with better outcomes. Of course, there are a number of obstacles to be taken into account. Is, of course, the cost of the equipment, the cost of the tests, the question how this is organized, that this can happen in a timely manner, the question of quality management, and of course the question of the interpretation. And this is always a local challenge, how to organize this. From a performance point of view, there are two different groups now available. On the one hand, there are cartridge-based devices, which basically run the assays automatically in a cartridge, so you just enter the blood, and the semi-automatic devices, which require pipetting. And it's also here a local decision based on costs and the possibility to perform the assays, which kind of analyzers make sense in a local situation. This is now just a picture of the system that we have developed. We have basically targeted to simplify the use of the semi-automatic system. One of the innovations we introduced is what we call the active tip technology, which contains the reagents in the pipette tip, so to minimize reagent handling. And of course, just to mention, not to forget the topic of quality management. So in summary, viscoelastometry is increasingly used for the management of complex coagulation disorders. There is some effort associated with establishing such methods in the point of care, but it can also lead to better management and reduced overall costs. Thank you very much.
Thank you, Dr. Kaladzis, for this presentation. Is any questions? It's clear.
Thank you very much.
The next presentation is from Theodoros Bisdas, is endovascular treatment of acute and chronic deep vein thrombosis and pulmonary embolism.
Dear Chairman, dear ladies and gentlemen, thank you very much. We are changing a little bit the topic, but still you will see that this will be a topic of your practice in the next years, because if you see the current, let's say, trends regarding deep vein thrombosis and pulmonary embolism, we have an increasing trend. This is the first page of an issue of 2014 from Endovascular Today. This is a journal for endovascular specialists, and you see the provocative title, Venues Rising, the role of interventional management of deep vein thrombosis. And if you see in the epidemics, DVT in the US is actually reaching 950,000 people per year. We have 60% that will develop a post-thrombotic syndrome. Pulmonary embolism reaches about 600,000 people per year, with a really increased number of deaths. Here is a paper showing actually the first time occurrence of venous thromboembolism, deep vein thrombosis alone, and pulmonary embolism. And you see that we have an increasing rate of DVT and PE actually on all these patients from 2003 up to 2009. And we know for the pulmonary embolism that 50% they will have an exercise limitation at 1 year, 4% will develop pulmonary hypertension at 2 to 3 years. Up to now, everybody knows the old practice of anticoagulation, now with the new oral anticoagulants and the compression stockings for the acute iliofemoral DVT, but this patient will still have a post-thrombotic syndrome. In case of Lechmasia cerulea dolens, you have to perform, according to the old practice, a cut down of the common femoral vein to remove the thrombus, to put an IVC filter, and then a fistula between the vein and the artery. Actually, it is a big disaster due to the morbidity at the level of the groin. And looking to the pulmonary embolism, the old practice was actually classified by the type of the pulmonary embolism, non-massive, submassive, and massive. And of course, you have the respected and then, let's say, mortality rate for its type of pulmonary embolism. We are starting, or we have started always with anticoagulations going to systemic thrombolysis. We have seen that with a systemic thrombolysis, you have a 40% reduction of the mortality risk, but you have high major bleeding rates in the pulmonary embolism. And there were some new studies showing that if you're doing an ultrasound-assisted catheter-directed thrombolysis, you have, let's say, similar results to the systemic, but you have really decreased rates of bleeding. That is the reason, if you see now the US inpatient sample, you will see that there is current increasing threat of catheter-directed thrombolysis. If you see now at the current guidelines regarding the treatment of pulmonary embolism, you will see that for low-risk PE, it is recommended to perform the systemic anticoagulations going to the submassive PE. There, it depends if you have a contraindication to thrombolysis. If yes, you are going back to oral anticoagulation. Otherwise, we can do a catheter-directed thrombolysis, but in the case of massive PE with RV dilatation, then you can go for a mechanical or pharmacomechanical thrombectomy. Now, let's go to the modern practice. The modern practice started more or less after the last 5 years, and the modern practice is more than a catheter. In the modern practice, we have now dedicated thrombectomy devices. This is the rotational thrombectomy, pharmacomechanical aspiration. We have large ball aspiration thrombectomy catheter or acoustic pulse thrombolysis for DVT. And if we're going to PE, then we have a plethora of new devices, ultrasound assisted, small bore devices, large bore devices, and of course the ECHOS is one that has been best investigated in the majority of the prospective trials. Here is a video how it works. Please give me the, I can play the videos. Here you are. So this is, for example, how it works with the catheter. This is the Indigo catheter from Penumbra. There is an olive. It's very more or less a Fogarty catheter. You are fragmenting the thrombus at that level. At the same time, you're aspirating the thrombus, and by this way, you can remove even thrombus even from vessels that they are reaching a 24 millimeter vessel diameter. There is also devices like the Zelante DVT where you're having a directional thrombectomy due to the big velocity. You are decreasing the local pressure by the Bernoulli effect, and at the same time you are aspirating the thrombus, and this can be used in the DVT, can be used also in the pulmonary embolism. Moreover, you have also dedicated filters. This is a filter that it is from Straub Medical. It is a filter that is introduced by jugular vein. You are just opening the filter below the renal veins, and then you can perform your DVT thrombectomy by leaving the filter at place. You can remove the filter directly without any conflict on the vein wall, and this is, of course, very important if you have the risk of pulmonary embolism due to the amount of the thrombus. We have nowadays multiple access to remove the thrombus from transfemoral, transpopliteal, or transjugular. All of them are now working very well. It has to do with the location and the difficulties to remove the thrombus. This is a case, an example. Again, please give me the mouse. You are having here a patient with a complete occlusion of the external iliac and common iliac vein. At that level, it's difficult to see. It is a stent, a vein stent that has been implanted. It is occluded. You can go now with your thrombectomy device. You're just removing the thrombus. On that time, you see with a small tip here, this is the olive. At the time that you can remove the thrombus, you don't need to open it, but afterwards you have a complete removal of the thrombus, and then at the end you can go directly to the filter. You can remove any thrombus from the filter at that level, and you have an excellent result. Now we are trying to use this kind of catheter to remove thrombus from hardware. We're working now with Hanover Medical School on, let's say, on the pig model because it really works fine. This is the case after the occlusion. You see here was the occlusion of the common iliac vein. This is now the patent vein system. Another more difficult case with the 3-level DVT. Again, we went through a transpopliteal approach. We removed the thrombus from the femoral and common femoral vein and from the external vein. We performed some vein stenting with dedicated vein stents, and this is the result at the end of this acute thrombosis. Now, this was a really challenging case. This was a 41-year-old male with patent PFO. He had at the same time pulmonary embolism. He had through the open foramen ovale, he had an embolism at the level of the right renal artery, and he has an embolism of the superior mesenteric artery. This was a difficult case. We went from a transbrachial approach. Here you see the embolism of the right renal artery, the embolism of the SMA. We removed with a catheter the thrombus from the SMA directly, and then we removed also the thrombus from the right renal artery in order to save, let's say, the function of the kidney, and then we could go with an 8 French catheter through the right ventricle into the pulmonary arteries, and we use the Indigo 8 French to remove the thrombus and to have a very nice result at the end. Few words about chronic deep vein thrombosis and post-thrombotic syndrome, and regarding the modern practice. Here the clinical picture is well known. You have patients with ulcer, pain, poor quality of life, edema, swelling, and an overall walking impairment. In that cases, you need a really dedicated stent, because if you see how it looks like the vein, the deep vein system in those patients, they have fibrotic tissue inside. You cannot open this tissue with really arterial stents. You need dedicated vein stents that they are large in diameter. They have a really high resistance in circumferential and focal load, and at the same time they are really flexible, because you have to go with these stents below the infrainguinal ligament. And this is a case, a patient that comes to our department. In this patient was 25 years old with post-thrombotic syndrome. Every radiologist said that this was an aplasia of the caval vein and both common iliac veins, but in the majority this is not the case. And you can see that you can recanalize these veins. This is again 25 years thrombosis, and we have put 2 stents parallel, and this is the result after opening these veins, and this is the final clinical result. So that means that now we have a modern practice with new stents. A similar case, again, everybody said that this is an aplasia and a genesia of the caval vein, and with a new dedicated stents, these patients have a really nice solution. We have, of course, dedicated devices like the intravascular ultrasound. This is of great importance and essential to have a nice outcome. Here, this is how it looks like if you have a chronic DVT, and then after putting the stents, you see the radial force and how the stents open this lumen. Now, let me summarize. The endovascular treatment of deep vein thrombosis is rising, I think, not only as a vascular surgeon, but also as cardiac surgeons, because you have to work with a pulmonary embolism. You need to know the new endovascular tools. It is a safe and effective procedure for acute DVT and also for pulmonary embolism. In the chronic DVT at the moment, we still want to have more evidence. Let's say the principle is try to remove the clot as fast as possible. If you are not able to do it, then wait to make this DVT as a chronic DVT and to work only for a stent. You have to carefully select the patients, and as you see, this is the same issue from the same journal, 2017, where you can see that now we are talking about ensuring the appropriate venous care, because a learning curve is required. Thank you very much for your attention.
Thank you very much, Dr. Bisdos, for your presentation. Excellent results, very impressive. Can you tell us what's about the percentage of patients that you have to treat with this modern technique? I mean, how often do you need to use this inside to thrombolysis technique?
We don't have numbers, because the problem is there is a variety of the disciplines that they are referring to you, these patients. So we are vascular surgeons, and we are trying now to see all of these patients at the moment. If I'm able to say it, from the 100% of the patients with this kind of problems, we have about 10% of people that they are coming with chronic DVT, because there is no awareness at the moment in Germany regarding this issue. And for the acute DVT, we are one of the dedicated centers in Germany regarding the treatment. And now, let's say from 100% of those patients, we are treating almost the 60% 40%. The 40% that it is not treated are patients that they are have paraneoplastic acute DVT, or patients that they have, let's say, low risk or submassive pulmonary embolism, and for those patients we're still working with anticoagulation. But for massive pulmonary embolism and for DVT in young patients within this window of 7 days, we are now more aggressive than we were before.
For intermediate risk PE?
We are working with our cardiologist, and if we see, let's say, if the patient has problems like COPD or has positive biomarkers, then we're going to do it. But in that cases, we have to let's say, to have an interdisciplinary approach with cardiologists, and we are deciding together if it is worth doing it.
Other questions from the audience, please? Okay, thank you very much.
Thank you.
Dr. Business. So we are going to close this very, very interesting final roundtable discussing tricuspid regurgitation and miscellaneous topics. And I invite Dr. Bilali to give us his presentation entitled The Role of 3D Printing in Adult and Pediatric Cardiac Surgery. Dr. Bilali.
Hello. Thanks a lot for the invitation, first of all. My name is Leonardo Bilalis, and I'm an engineer for 3D print diagnostic models, working for 3D Life company, which is based in Athens. And our mission is to provide best quality and value 3D printing products for advanced personalized surgery to the benefit of patients and healthcare system around the world. I have added this slide in order to emphasize the importance of 3D printing in a global market. As you can see from McKinsey Global Institute, they said which is disruptive technology that will transform life, business, and the global economy. In addition to that, the world 3D printing market for healthcare will reach 2.3 billion by 2020. Yesterday I read an article, a new article, that we have exceeded this amount this year in 2018. So imagine how important the 3D printing in healthcare system is. I will do a quick introduction for history of 3D printing, 3D printers and technology, what 3D printing is, the application of 3D printing, presentation of 3D printing model, the preparation, sorry, for 3D printing model, tomography, CD, and MRI, and some cases. Actually, there are 4 to 5 cases I will show you. Very quickly, 3D printing starts in 80s and introduced by Dr. Kodama in Japan. And after in 1983, Charles Hall, which develops actually the technology and call it stereolithography, becomes the standard file and calls it STL, which stands for Surface Tessellation File. In 1999, we see the first 3D printing object implanted to the human body in the area of the bladder. Here on the graph, I would like to show you the evolution after the 2000, and especially 2013, 2015, as you can see, in medicine. A little words about 3D printers and technology. We have the stereolithography. We have the fused deposition modeling, we call it FDM, the laser sintering, and the inkjet. I would like to mention here, and my point for these slides, it's for my experience also, everybody in the world, in order to have a very good quality and important model in your hand so you can analyze it very well, you need to spend some 100,000 euros for a very good printer in order to have a very good model in your hand. So that's what we need to care of. What 3D printing is? actually is a digital 3D CAD file which is transformed into a real object. I'm going to talk about this case at the end. You see here on the left, it's a digital model. On the right one, it's the 3D printed model. And the accuracy, it's approximately to some micro millimeters. So we are close to 0.016 millimeters, the accuracy of the surface finish. The process creating a 3D printed model, it's very simple. We get a CT or MRI, a DICOM file, we analyze it and reconstruct all the pictures. We create, first of all, in our computer a 3D object, a digital object. We transform into STL file because 3D printers only reads an STL file. And at the end, we send it to the printer. We have the end of product, which is shown on the bottom right. Now, in tomography, the parameters we are using normally for the cardiac purposes, it's a CT. We get actually the DICOM file from a CT scan, which must be ECG gated, and normally it requires to have a good scan with clear contrast everywhere in all the ventricles and atriums. The slice increment, the slice distance must be the same. Here I have a number of 0.625 millimeters short for the triple M, and must be no misalignments. We do not want the patients to move during the exam, the test. As you see from the next slide, this is a very bad MRI scan, which we have a misalignment on 2 axes. So the result, it's not as good as we wanted to. Now, the applications of in a medical 3D printing, as 3D Life, we are focused in surgical models and education models in the beginning. We are directly providing to the hospitals, surgeons, and universities models for pre-surgical planning, for patient education, learning education, surgical simulation, which is very important. And also we have close very good cooperations with companies and universities for medical devices and bioprinting. In the future, I hope we can show you very well bioprinted models. Here, it's better I will tell you a short story from Hellenic, which they did a left atrial appendage, and they reduce the complication rate from 16 to 0, the operation time from 80 minutes to 45 minutes, and the average device usage per patient was from 1.8 to 1.2. And that's very important to have a very good quality of 3D printing model. I would like also to introduce you the first in Europe anatomic heart library, and we are proud of, as a company, 3D Life. We have very good quality and difficult cases, and we are second in the world after the NIH in US. And now let me talk a little bit about some cases. Do we have... Oops, sorry. Okay. Do you have a pointer here? Thank you. Thank you very much. Okay, that's a patient which has already a stent-mounted pericardial sutureless implantable aortic valve, and there's a potential valve for the surgeon. Before the surgery will look at all the information he had, but really wanted to have a 3D printed model to be sure as an additional information for him if he goes through to the surgery or not. As you see here, when I press the pointer, it just changes the slides as well, you see. Anyway. Okay. From this area here, you see the aorta from the top, and you can figure out this is the stent here, and the aortic valve here. Also, this part outside from the aortic base, it's absent, as you call it. This area here, it's a mitral valve, and all this is being developed from calcium in many years, and the doctor, when sees this after he had it in his hand, he didn't want to touch the patient anymore. It was high risk to do the operation. Let me show you one more. This is a potential transcatheter valve in a ring in a mitral position. Here, from the left ventricle, you see inside the mitral valve, and you also can examine and measure on a 3D printed model the area. So it's very also important to have a 3D printed model to do measurement to see if you can do the operation with a model in your hand. I have also one more case to show you. This one, it's a congenital heart defect, which is situs inversus dextrocardia. It has here the pulmonary artery, which is, has a stenosis, and also it looks on both of the ventricles. It has DORV. As you see on this picture, it has a VSD. Also, it has an open area from the right ventricle to the right atrium. And this is approximately 10 days old baby, which has this, it's called ductal arteriosus. It was closed to be closed, so we opened it with some medical treatment. That's it. Thank you very much for hearing.
Thank you very much, Mr. Bilalis. Something really exciting for us physicians. I don't know how many of the audience can discuss, can understand everything you demonstrate to us, but certainly this is the future. I agree with you. This is the future. Anyway, any questions for Mr. Bilalis? Thank you very much again.
Thank you very much.
I express also the opinions of my co-chairman. I think we ended a very interesting roundtable with different topics. We have heard from cardiac surgeon, vascular surgeon, engineers, and we thank all of you to stay with us until now. Thank you very much, and have a nice day.
Nice presentation.
Bye-bye.